Good morning. This is Melinda Wharton. We will be restarting the meeting in just a couple of minutes. Hopefully many of you have been able to get back onto the broadcast with the updated link, and we'll ask those on Zoom to just wait a moment. We'll be starting in just a couple of minutes. Thank you. Good morning. I will now turn the podium back to Dr. Talbot.
Good morning. We're going to start our next session with Lyme disease vaccines, and an introduction will be given by Dr. Marks.
Good morning. My name is Grace Marks, and today I'll be giving an introduction to the Lyme disease vaccines work group. Next slide, please. Lyme disease is a major public health problem. It's the most common vector-borne disease in the United States, with an estimated 476,000 people diagnosed and treated each year. Lyme disease is estimated to cost between $345 million and $968 million annually in healthcare costs in the U.S. Next slide, please. In the 1990s, several human Lyme disease vaccines were developed, each containing outer surface protein A antigens from the Borrelia-Burgdorferi spirochete. The mechanism of these vaccines was to elicit OSPA antibody development, which then neutralized the spirochete in the tick midgut during a tick bite, thus preventing transmission. One of these vaccines, Lymerix, was licensed by the FDA and was available during 1998 through 2002, when it was discontinued by the manufacturer due to low demand. Since then, however, the burden of Lyme disease has steadily increased in the United States, with expansion outward from high incidence areas in the Northeast, Mid-Atlantic, and Midwest. In the past several years, new vaccine candidates have been developed. VLA15, a multivalent recombinant protein subunit vaccine, is currently under evaluation in phase 3 clinical trials. Several mRNA vaccine candidates have also been developed and are currently under evaluation in early clinical trials. Next slide, please. The ACIP Lyme disease vaccines work group has several objectives. We will review the epidemiology and burden of Lyme disease in the U.S., as well as the data about risk for Lyme disease. We will review available safety, immunogenicity, and efficacy data for Lyme disease vaccine candidates in advanced clinical trials. We will also review economic analyses related to Lyme disease vaccination, including cost-effectiveness analyses. Based on the available information, we will develop evidence-based Lyme disease vaccination policy options for ACIP consideration. And finally, we will identify areas where additional data and research are needed. Next slide, please. The chair of the ACIP Lyme Disease Vaccines Work Group will be announced in the coming months, along with other work group members. I will be serving as the CDC lead for the work group. Next slide. We anticipate that the first work group meeting will take place next month in May 2025. And at the upcoming June ACIP meeting, we plan to present on the epidemiology, burden, and clinical manifestations of Lyme disease. Next slide. Thank you.
Thank you very much for this introduction. Greatly appreciate it. And now we will move on to influenza vaccines, and Dr. Jamie Lair will start us off.
Thank you very much. I'll wait for the slides to come up. This is the introduction to the influenza work group. Next slide, please. We have several ACIP members on the work group, a number of ex officio members and liaison representatives. The CDC lead, who is doing a wonderful job keeping us on track, is Lisa Groskopf. Next slide, please. And here are some more CDC participants. Next slide. Thank you. One more, please. Great. This slide is mostly for information. We have a vaccine composition for 2025-2026 influenza vaccine. The second bullet is the most important bullet. The composition includes an update to the H3N2 component. And for those of you who like to get into details, here are the actual lineages, which will be in the vaccine compositions. Next slide. We'd like to do a job of providing vaccine effectiveness estimates to the ACIP as we go along over the course of the flu season. The effectiveness varies, and so we have several CDC platforms that assess the effectiveness annually, and we both have end of season and interim presentations. We try to do estimates as they become available. And so the updates today will be the interim estimates of the seasonal influenza vaccine effectiveness from Dr. Aaron Frutos, and also a more California-based from Dr. Sophie Zhu. Next slide. A very interesting update is that FluMist, which is LAIV3, has been given FDA approval for self-administration or caregiver administration. And this program is expected to be available for the 2025-2026 influenza season. So we'll have an update from AstraZeneca, Dr. Alan Bandel, on FluMist self and caregiver administration. Next slide. There will be some votes on the influenza statements at the June 2025 ACIP meeting, but there will be no votes for this meeting. Next slide. And thank you very much. I think we can move on to the first interim estimate.
Dr. Frutos?
Good morning. I will be presenting the CDC's interim estimates of 2024-25 seasonal influenza vaccine effectiveness. 4 networks contributed to the interim estimates of vaccine effectiveness against laboratory-confirmed influenza for children and adolescents and adults in the outpatient and inpatient settings. The CDC influenza vaccine effectiveness networks that are included in this presentation are the Investigating Respiratory Viruses in the Acutely Ill, or IVI, the New Vaccine Surveillance Network, or NVSN, the U.S. Flu Vaccine Effectiveness Network, or U.S. Flu VE, and the Virtual SARS-CoV-2 Influenza and Other Respiratory Viruses Network, or VISION. This graphic shows the age and settings included for each network. Across the networks, all ages across multiple settings are included in the interim estimates this year. And I'll go through each part to show how each network contributes to interim VE estimates. Starting with children and adolescents, NVSN includes patients from outpatient clinics, emergency department, and urgent cares, and those admitted to the hospital. U.S. flu VE includes patients from outpatient clinics, emergency departments, and urgent cares for children and adolescents. Vision includes patients from emergency departments and urgent cares, and those admitted to the hospital. Now moving to adults, IV includes patients admitted to the hospital. U.S. flu VE includes adult patients from outpatient clinics, emergency departments, and urgent cares. Vision includes adult patients from emergency departments, urgent cares, and those admitted to the hospital. Again, these networks together include all ages across a variety of settings. Moving forward, we will refer to outpatient clinics, emergency departments, and urgent cares together as the outpatient setting. This map shows the geographic representation of the different networks, as these networks include patients from 23 different states. The methods used by each network to estimate influenza VE are very similar. All enrollees across all networks sought medical care for acute respiratory illness. Patients are included from fall 2024 to early 2025. Each network uses a test-negative design, which compares the vaccination odds among case patients with influenza confirmed by molecular assay versus control patients testing negative for influenza and SARS-CoV-2. Vaccination status was determined as receipt of any of the 2024-25 seasonal flu vaccines according to medical records, immunization registries, claims data, and/or self-report. Vaccine effectiveness is calculated as 1 minus the adjusted odds ratio times 100%. Each of the networks adjusted for geographic region, age, and calendar time of illness. IV, U.S. flu VE, and Vision also adjusted for sex and race and ethnicity. VE estimates were calculated for influenza A subtypes A H1N1 PDM09 and A H3N2 when possible. Influenza A subtype estimates were not calculated for Vision because of limited subtype data. VE was not estimated for some age groups and settings when sample size was small or when models did not converge. We did not estimate VE against influenza B because less than 3% of national influenza surveillance specimens were influenza B. Before presenting the VE estimates, I want to highlight some differences in influenza A subtype by network. This table shows the network on the rows and the number of specimens with influenza A subtype in the columns. Again, Vision is not included here because subtype was not available in that network. If we look at the influenza A H3N2 column, we see that among subtype specimens, IV at 69% H3N2, MVSN had 48% H3N2, and US flu VE had 67% H3N2. These differences are important to remember when evaluating each network's overall VE. Now I will present the VE estimates stratified by age, starting with children and adolescents. This table shows the number of influenza-positive cases and influenza-negative controls, as well as the prevalence of vaccination among both across network and setting. I want to highlight the prevalence of vaccination among controls in the second column, which varies from 22 to 40% across settings. These same controls are included as part of each of the following pediatric VE estimates. Because we have many estimates from the 4 networks, we'll now show the VE estimates in a graphic. Pediatric VE against any influenza ranged from 32 to 60% in outpatient settings and 63 to 78% in the inpatient setting. Pediatric VE against influenza A H1N1 PDM09 ranged from 53% to 72% in outpatient settings and was 63% in the inpatient setting. Pediatric VE against influenza A H3N2 was 42% in outpatient settings in MVSN and was 55% in the inpatient setting. VE was not significant in the outpatient setting in the US flu VE network with a point estimate of 16%. Now I will present the VE results for adults aged 18 years and older. Here's the table of included influenza-positive cases and influenza-negative controls. We see in the second column that vaccination prevalence ranges from 34 to 39% among test-negative controls. Adult VE against any influenza ranged from 36 to 54% in outpatient settings and 41 to 55% in the inpatient setting. Adult VE against influenza A, H1N1, PDM09 was 42% in outpatient settings and not significant in the inpatient setting. Adult VE against influenza A, H3N2 was not significant in the outpatient setting with an estimate of 25% from US flu VE, and VE was 51% in the inpatient setting. Now I will show the results for adults age 65 and older. Among adults age 65 and older, the prevalence of vaccination amongst test-negative controls ranged from 45 to 59% across settings. Among adults age 65 and older, VE against any influenza was 51% in outpatient settings in the VISION network and was not significant in US flu VE with an estimate of 18%. VE was 38 to 57% in 2 networks in the inpatient setting. These estimates presented show that vaccination with the 2024-25 influenza vaccine reduced the risk for medically attended influenza outpatient visits and hospitalizations among children and adolescents and adults across 23 U.S. states. Vaccination was effective against influenza A with variation by subtype across network. These results were recently published in CDC's MMWR in February of this year. Thank you.
Our next speaker is Dr. Quint from the California Department of Health.
Thank you. Good morning. Yes, my name is Joshua Quint. I'm an epidemiologist from the California Department of Public Health's Immunization Branch. Today I'll be presenting results from our study titled Interim Influenza Vaccine Effectiveness Against Lab-Confirmed Influenza on behalf of our study team, which was led by Dr. Sophie Zhu. Next slide, please. So understanding vaccine effectiveness for influenza or VE involves several considerations regarding population of interest, patient care settings, sources of data, and record type. Next slide. In California, recent changes in reporting has made new public health data sources available, which have allowed us to investigate VE across a wide range of age groups, settings, using electronically reported vaccination and testing records. Next slide. Beginning in January of 2023, next slide, all influenza vaccination records became reportable to CARE, the state's immunization registry. Next slide. Positive influenza test results became reportable in California in October of 2019, but it wasn't until recently in June 2023 that negative results also became reportable to the state's electronic communicable disease reporting system. And positive and negative results are derived from electronic records sent by laboratories performing testing throughout the state. Next slide. Last year, we published our vaccine effectiveness findings in the Morbidity and Mortality Weekly Report for the 2023-2024 influenza season. At the end of the season, we compared our interim estimates to those of traditional hospital network-based platforms, as Aaron just mentioned. And although the populations and systems are not exactly comparable, our VE estimates were remarkably close to those from those traditional platforms. So here looking at the pediatric population, ages 6 months to 18 years, we calculated VE to be 56%, which was within nearly every confidence interval provided from the CDC. Next slide. Next, I'll describe the methods of our study with results and conclusions. So next slide. We used a case control or test negative design in which persons testing positive for influenza are classified as case patients. Dates for the analysis were October 1st through January 31st of 2025. Persons eligible for the analysis were California residents aged 6 months and older with a molecular culture test for influenza reported to the state electronic laboratory system. Participants were considered vaccinated if there was at least 1 dose of seasonal influenza vaccine documented in the immunization registry 14 or more days prior to the date of their influenza test. For persons with more than 1 test result, we selected the earliest positive test or the earliest negative test earliest negative test if they never tested positive. And during data quality checks, we identified a few labs that were reporting unusually high positivity rates. So we excluded labs with greater than 50% positivity, which accounted for less than 5% of total tests. And same as the previous presentation, VE was 1 minus adjusted odds ratio times 100%. Using mixed effects logistic regression model adjusted for continuous age, categorical race and ethnicity, testing week, and county as random effects. Next slide. As you can see, flu activity in California this season peaked towards the end of December with about 17,000 positive test results and remained high throughout the month of January. In total, 85% of positive specimens were classified as type A, 7% classified as type B, and the proportion of type B was about 10% in October and 7% in January. Next slide. For samples tested by public health laboratories, the predominant subtypes were H3 and H1, with about 53 and 43% respectively. Only 300 influenza B samples were lineage typed, so results for that are limited. And persons with severe disease may be more likely to have results subtyped. So this counts for about 5% of all tests that go on to public health laboratories. Next slide. So with a total of 591,000 samples meeting eligibility criteria, we found 23% were positive for influenza, 77% were negative. And then among those, the vaccination rates were 17.6 and 25.9% respectively. Next slide. Median age for cases was 30 years and versus 43 years for control group. The distribution of race was similar for case and control patients, although cases were 5 percentage points more likely to be Hispanic, 7 percentage points less likely to be white. Next slide. So we'll share these results across these groups. Next slide. So adjusted vaccine effectiveness against lab-confirmed influenza, 44.7% overall, with confidence interval ranging from 43.7 to 45.6. Looking at age group, we calculated about 50% for children under the age of 18, 46% for ages 18 to 49, 39% for ages 50 to 64, and 65 and older. Next slide. Broken down by influenza type, VE was against influenza A was lower than against influenza B across all age groups. VE against influenza A was 42% overall and 71% overall for type B. Next slide. And recalling that less than 5% of all flu A specimens received subtyping, we were interested in comparative vaccine effectiveness among different subtypes. And we found that the VE for H3N2 was 47.9% and 49.5% for H1N1. Next slide. We also looked at the live attenuated influenza vaccine effectiveness among children ages 2 through 17. And the LAIV was 61% versus 48% for those not receiving an LAIV. And in the previous season, these values were 45 and 52%. Median age was similar between children who did and did not receive the LAIV vaccine. Next slide. Here we see the cumulative VE estimates. So while the earliest available interim estimates from the system in October had very wide confidence intervals, we did see the cumulative VE reach about 50% at the end of October, and then peaking to 55% in early December, then trailing off towards the end of the study period to about 45%. Next slide. Looking separately at each month of testing data, we can see a similar pattern with the highest VE measured in November at about 56%, and then decreasing in the months of December and January, which also produced the most narrow confidence intervals. Next slide. Looking at results by month and type, we see persistently high VE estimates for type B, which was in contrast to the pattern seen for type A. Type B remaining high at about 75% in December and 70% in January. Next slide. And you can advance to display all the rows. So while the data is robust and produces narrow confidence intervals, there are a number of limitations to this public health surveillance-based approach. So first, compliance with rules for reporting could be suboptimal, and it's difficult to know which labs are not reporting. We could not differentiate between partial or full vaccination for children under 9 years of age due to the more complex requirements and lack of complete historical data. Third, influenza results reporting does not include information on symptoms, which could lead to uncontrolled confounding if control patients were not as likely to be tested as case patients due to differential symptom severity. We did not have a testing setting or final outcome status of persons in the analysis, which meant that VE against hospitalization and death could not be calculated. Finally, we did not control for some potential confounders such as healthcare seeking behaviors or pre-existing conditions, which may bias the test negative design. Next slide. So in summary, despite these limitations, the data available indicate that current influenza vaccines provide protection against laboratory confirmed influenza in persons 6 months and older. VE was higher for influenza B and younger persons, but vaccination still provided protection for all age groups. Our study also demonstrates how expanded and improved public health data can be leveraged to calculate timely in-season influenza vaccine effectiveness estimates, which can support existing public health prevention efforts prior to the peak of influenza infections. And this knowledge could also benefit healthcare settings and providers in the planning and allocation of resources to respond to future needs and increased hospital capacity. And this work was a big team effort. I want to thank the California local health departments, the staff at CDPH, Division of Communicable Disease Control, and the ongoing collaboration with CDC's NCIRD for their support and input throughout this process. Thank you.
Thank you very much. I'd like to open the session to questions. Dr. Shaw.
Yeah, thanks very much for those two really helpful presentations. I'm not sure, it could be a question for either Dr. Frutos or Dr. Quint. We're coming out of, I think, an exceptionally active influenza season, and I was wondering if there was any information on vaccine effectiveness against H3N2 for older adults. The reason being, I believe the antigenic characterization of circulating strains suggested that there were a greater percentage of H3N2 isolates that did not have strong reaction to reference antisera, and also H3N2 likely affects older adults in particular. And I also note that it seems that the H3N2 component is the only strain that appears to be changed in the recommended 2025-2026 vaccine.
So for CDC's vaccine effectiveness estimates this year, we do not have H3N2 by older adults, but that is information that is regularly estimated each year. And final estimates from the networks that have older adults will be available at the end of this season.
Thank you.
Dr. Asturias?
Yes, thank you for those presentations also. For Joshua, do you have data on the timing of immunization and illness to sort of define that if the drop that we see in the vaccine effectiveness for the influenza A types is related to the timing of vaccination or is that a sort of a strain-specific sort of a decrease in vaccine effectiveness over time, depending on the type that we're seeing? Over.
We do.
Dr. Zhu is on the call, but I think we did not include that in the model, but we can sort of infer that the tailing end is likely related to the fact that vaccinations are received earlier in the season. I don't know if Dr. Zhu has anything to add.
Thanks, Dr. Quint. To add on to that, for the previous influenza season, we do have a manuscript under peer review that looks at waning specifically, in addition to the overall VE estimates. So be on the lookout for that. We haven't looked too closely at waning for this season, but we expect the trends would be very similar.
Thank you.
Dr. Frutos, did you have anything you wanted to add? Okay. Sounds great. Ms. Moser.
Thank you. Thank you for both presentations. I have a question for each one of you. Dr. Quint, on the slide related to the pediatric LAIV vaccine efficacy, your groups were vaccinated with LAIV or not LAIV. Can you please just clarify whether that means those children in the control group were not vaccinated against influenza at all, or could that group have included children who received inactivated vaccines?
Thank you, Dr. Mose. I can take that question. So for the pediatric LAIV, children in the LAIV group, so we had around like 455 children who were vaccinated with LAIV specifically. The control group for those children would be children who were not vaccinated. And then we use a similar control group for the non-LAIV children. Those would be children who were vaccinated with other vaccines, non-LAIV vaccines. So the comparison group for both would be the same. So I know it's maybe a little confusing, but we're kind of like stratifying the population, but using a similar control group for each calculation.
Okay, so not LAIV could include children who got inactivated. Sorry if I confused that.
Yes.
Okay, thank you. And then my question for Dr. Frutos was just in relation to the 4 networks that we usually get data from regarding calculating vaccine efficacy. You mentioned IV, NVSN, US Flu VE, and Vision. And I just was wondering, are all of those still funded to actively collect data through this season and then in anticipation of next season?
Yes, this is Sasha Ellington. I wanted to answer that. We are planning for 3 of the 4 networks will be actively collecting network in the 25-26 season. So there is a planned sunsetting of the IV network. So we will not have those data for the next flu season. Thank you.
Thank you for those answers.
Dr. Sineas.
Thank you. For those who, for vaccine effectiveness by type and age group for patients over 65 years, do we have any breakdown by vaccine type received, for example, high dose?
We do not at this time, no.
Thank you.
Quint and Dr. Zhu, do y'all have any?
Sure. For our current presentation, we did not have those estimates available. However, we did calculate product-specific vaccine effectiveness for, again, the previous season. So again, those estimates from last season will be available soon.
Thank you very much. Dr. Hoag?
Yes, just a quick question and comment about the test negative design that it was alluded to at the end that different thresholds for getting tested. For example, if vaccinated people tend to seek out testing or be tested for lesser symptoms or asymptomatic or are asymptomatic, that would affect the vaccine efficacy results. And if that is being taken into account in any way in either of these test negative design studies that we saw today, because I think it's important to keep in mind that we might be ending up with some bias in our estimates, and that should be considered.
Yes, I think our CDC colleagues can make a comment.
So that's a key strength of the platforms and networks that we use to estimate VE each year, is that both those that test positive for influenza and those that test negative for influenza, they both have acute respiratory illness, and our estimates again are against medically attended influenza, not necessarily against infection. And so in that instance, we don't think that the impact of bias would be large in this regard, and that we're confident that it is minimal and that the estimates are accurate.
Thank you. And Dr. Carrillo, you get the last one.
Thank you. Has there been any attempt or consideration of estimation of vaccine effectiveness stratified by individuals as to whether for the prior flu season they had had a flu infection and or been vaccinated?
We did not take that into account for the interim estimates, but that is something that we are regularly looking at and will be accounted for in some further analyses that will be forthcoming.
Always a topic of interest. Thank you so much. All right, we're going to move on to flu miss, self, and caregiver administration from Dr. Bandel.
Good? We're good?
Great, thank you.
Great. Hey. My name is Alan Bandel, and I'm the U.S. Medical Lead for Influenza at AstraZeneca. Thank you for the opportunity to meet today regarding FluMist, which received FDA approval for self and caregiver administration last fall. I'm looking forward to sharing the work that we've done to make FluMist for self-administration available for the upcoming 25-26 flu season. FluMist for self and caregiver administration offers patients an innovative approach to protect themselves against the flu, and in the bigger picture, reduce barriers to vaccination that could help to improve vaccination rates against influenza. The self-administered FluMist vaccine gives patients the opportunity to benefit from the same approved, safe, effective, and recommended FluMist vaccine that has been available to help in the healthcare setting for over 20 years, simply delivered to the home. The key differences for the home version are that it extends the option for who can administer the vaccine beyond a healthcare professional. The age indication is 2 to 49, which remains the same. The extension is who can administer FluMist. And by doing so, it enables administration in the home setting using an established online pharmacy service where a pharmacist determines the eligibility using the screening criteria aligned with those currently used in the traditional pharmacy setting. It also expands access and empowers individuals to administer the vaccine to themselves or others according to ACIP guidance. FluMist for self-administration provides patients a convenient household-based option for a flu vaccination that increases flexibility. It really builds on the acceptance of in-home healthcare. This is important because even people who signal an interest in annual flu vaccination don't necessarily do so consistently due to any number of factors such as scheduling, work, family. Life just often gets in the way. FluMist for self or caregiver administration provides an option that is easy to self-administer and increases access to flu vaccine. A recently published influenza disease state modeling study, which was independently undertaken by researchers at the University of Pittsburgh, evaluated the possibility of reducing symptomatic cases of the flu overall by increasing vaccination coverage only in school-age children with FluMist given by parent or caregiver administration, which would avoid missing school for the child and time off work for the parent. The authors found that using this method to increase vaccination in 5 to 17-year-olds had the potential to reduce the number of symptomatic cases against all age groups. Providing this additional option for accessing flu vaccine would mean less spread of flu at home and at school. Our presentation today will discuss how the safe and effective use of FluMist at home is based on a series of well-tested and trusted tools and services. FluMist for self-administration is the same product that is available in the healthcare setting that will be in a patient-friendly packaging for flu vaccination delivery and administration to eligible patients at home. The instructions for use provide step-by-step instructions, all based on our human factors usability study. The online pharmacy service, known as FluMist Home, supports the ordering, delivering, and documentation of FluMist for self-administration. And as the FluMist device is labeled as medical waste, there is a return shipment program that instructs how to dispose of the FluMist sprayer after use. I'll first review the FluMist package insert and instructions for use. There is a single package insert where the FluMist is administered in the clinic by a healthcare professional or at home by an eligible adult. It guides healthcare professionals, adults, and caregivers on eligibility and how to give the vaccine. The package insert also details who can administer or receive FluMist, including instructions on self-administration and for when an adult administers to children 2 to 17 years old. It notes that children should not self-administer and directs adults to review the instructions for use. The recent approval for FluMist self and caregiver administration in 2024 was built on the original approval of FluMist in 2003. Listed here are a sampling of studies that have reported on the effectiveness, immunogenicity, reactogenicity, and safety of self and caregiver administered FluMist. This includes an early study of more than 4,500 adults that compared self-administered to healthcare administered FluMist and found similar effectiveness against flu-like illness, immunogenicity, and adverse events. Reactogenicity events were comparable. A Department of Defense study of more than 1,000 adults comparing self versus healthcare administered FluMist found immunogenicity did not vary by administration method. Mean geometric titers for influenza A were similar with a p-value of 0.43, and local and systemic reactogenicity events were also similar. And in a study assessing feasibility of caregiver administration to eligible children 2.5 to almost 18 years of age, all doses were successfully administered, adverse events were mild in severity, and some noted that they would not have been able to vaccinate without home access. Beyond the studies investigating effectiveness, immunogenicity, and safety, AstraZeneca also conducted an FDA-required human factors usability studies that led to the development and approval of the instructions for use and consumer packaging. The objective was to confirm that intended users could administer FluMist to themselves or to an eligible child without errors or difficulties, such as administering half the dose or if they spray the mist into the air and not to the nose. Study participants were recruited to reflect intended users and included a mix of male and female participants, right and left-handedness, a range of educational backgrounds, and those with and without nasal spray experience. The human factors study population included eligible adults and caregivers who were representative of intended users with demographics balanced between adult patients and caregivers. And the outcomes confirmed that FluMist could be used safely and correctly by intended users. The results demonstrated that 100% of participants were able to successfully self-administer or administer to child a full dose of FluMist. And additionally, 100% of intended users were able to successfully read and understand the instructions for use. The final packaging instructions used in the human factors studies were included in our supplemental BLA to the FDA. On the top left, you see the top of the FluMist package before it's opened. And when you open it, you'll see the instructions for use are the very first thing that the patient sees as soon as they open the flap. The information sheet includes important directions on storage, administration, and disposal. And on the right, you'll see the plain language and simple illustrations that guide the proper use, step by step, beginning with a description of the FluMist nasal sprayer, that 1 dose equals 2 sprays, and that they use 1 spray for each nostril. As the patient reads the instructions, they get guidance on how to open and inspect the package before administering to themselves or to others. Here are steps 1 through 4 on how to prepare to use FluMist. And there's guidance on the amount of time that FluMist can be out of the refrigerator and items to review prior to administration, including checking the expiry date. The instructions further guide patients on the steps for using the sprayer in each nostril. Steps 5 through 8 guide them on the first spray with do's and don'ts for how to hold the sprayer, remove the cap, and place the sprayer in the nostril. This includes easy to understand language and visuals showing you that you should not put the entire tip into the nostril. Steps 9 through 12 provide direction on a visual on removing the dose divider clip, and then to repeat the steps they've just taken, use the sprayer in the other nostril. The instructions for use even calls out concerns that someone might have, such as describing that it is normal to feel a slight tickle in the nasal passages or that some dripping might occur. The instructions also include information on the safe disposal of FluMist after use, and I'll share more details of that later in the presentation. I'll move on now to the online pharmacy service called FluMist Home that supports patients interested in administering FluMist at home. It's important to keep in mind that AstraZeneca and Aspen, our pharmacy partner, are adhering to standard roles for any vaccine manufacturer and pharmacy. AstraZeneca will manufacture and supply the vaccine, develop education and awareness campaigns, and provide support for anyone with FluMist-related questions. Aspen is providing the FluMist Home service and will ensure eligibility, manage dispensing and delivery, and provide pharmacist counseling and support. Importantly, Aspen pharmacists will comply with state-by-state rules and regulations for determining patient eligibility, writing a prescription, as well as documenting administration of FluMist into the immunization information systems based on the address where FluMist is shipped. Here is a slide of the online pharmacy service experience that is similar to the interfaces routinely used by other major retail pharmacies when you're signing up for a vaccination visit. I'll walk through these now. Step 1 is for the adult member of the family to opt into the ordering process, provide typical contact information, and initiate ordering FluMist. They then have the option to add orders for others in the household, including other adults and children, by entering patient information for each. This includes ages, allergies, underlying health conditions, and their address. With the household members identified, the patient will be asked a series of simple yes or no questions based on their medical history that allows the Aspen pharmacist to determine eligibility for receiving FluMist on a patient-by-patient basis. The screening questions are aligned with the ACIP seasonal influenza recommendations for LAIV, including contraindications and precautions, and they can be reviewed on the immunize.org website. While I won't go through all of them today, they include a series of questions such as whether someone has had a serious or a severe allergy to eggs and other absolute contraindications such as salicylate use in 2 to 17-year-olds. We also ask if there is household contact with immune compromise, whether a child is receiving the vaccine, a flu vaccine, for the first time, and whether anyone has received another vaccine in the last 4 weeks. After responding for each family member, a panel will appear that identifies which household members have been determined to be eligible to receive FluMist at home, whose prescription might be under review based on some responses, and if someone is not eligible, in this case based on their age. Here is an example of what happens if there is a yes response to one of the screening questions, such as if a child between 2 and 4 years has a history of wheeze. In this case, mom marked yes for Emma, and she would not be eligible for FluMist at home, the parent or caregiver would get a recommendation to have Emma receive her flu vaccine through her healthcare provider. The next step checks for insurance for each person to confirm pharmacy coverage for FluMist. And during launch year, FluMist for self-administration will be available for people with health insurance without an option to pay out of pocket, as the insurance review allows the pharmacy to validate information that the patients entered into the eligibility section. Importantly, FluMist will continue to be available through the VFC program when administered in participating healthcare centers or provider offices. And we'll work with the VFC program office to consider how self or caregiver administration options could be incorporated into the program in the future. In the traditional pharmacy setting, the patient would choose their appointment date and time. Here, the patient then selects a delivery date, enters payment details to cover the $5 to $10 shipping fee, since insurance coverage is already factored in, and then submits their order. Much like any other things that you order online, emails, text alerts will track the order status, including the order confirmation and updates on whether the order is on time or whether it's delayed for any reason. These communications also include a link to the patient portal where they can get additional information and connect with the pharmacy for any reason, including if they need to reschedule their delivery. On the day of delivery, the patient is notified about its arrival and receives instructions for storing FluMist before use. They'll get a text message as soon as the package is delivered that includes the time of delivery so that they know how long the package has been at their door. There's no requirement for signature upon delivery. There'll also be an information sheet visible as soon as the package is opened. And that document includes a list of all the package contents, including the FluMist devices and cold packs, includes instructions for storing FluMist in the home refrigerator until use. It includes the vaccine information statement and provides multiple ways to access additional instructions for administering FluMist, including a QR code that links to the how-to videos on the website, where we anticipate those who are digitally fluent will get their information. The shipping and handling process will deliver FluMist to the right patient at the right time at the right temperature. FluMist is shipped under strict cold chain procedures, which we're using a validated storage, packaging, and delivery method that were reviewed and approved by the FDA during our supplemental BLA process. FluMist will utilize 2-day shipping, and each package can hold up to 4 devices, FluMist devices. The inner box contains FluMist and a temperature monitor, which can be scanned with a smartphone to confirm that the vaccine has stayed within the appropriate temperature range during the shipping process. The process for the online after the package has been delivered, text messages are sent to confirm administration of FluMist. If the patient doesn't respond yes, they will continue to receive reminders. They will be prompted to say why, selecting from a list of reasons, including if there's been a problem with the order or if they want to ask a pharmacist a question via the 1-800 number or a chat function. When they respond yes, the patient can report the vaccination to the immunization. The pharmacy can report the vaccination to the immunization information system after obtaining consent, if that's required, and also report to the patient's physician if that information was provided as well. The patient can also download their vaccination record. The process that the online pharmacy uses to enter the vaccination data into the state immunization information system after confirming administration is the same as the process for retail pharmacies administering vaccines in the outpatient setting. And in terms of updating the medical home, in addition to the pharmacy being able to send documentation to the patient's physician, the patient can also download a record of their vaccination from the patient portal and provide that to their physician. And this process mirrors the current retail pharmacy setting. The FluMist packaging sent to the home also includes a return shipment program to ensure appropriate disposal of FluMist sprayer after use. The used FluMist sprayer is considered medical waste, and instructions and materials explain how to dispose of a used FluMist device. The easy-to-follow process includes a prepaid, pre-labeled envelope which can hold multiple FluMist sprayers and be placed into the mailbox. There's no need to go to the post office, FedEx, or UPS. And a medical waste disposal company receives the envelope, records the tracking information, and then disposes of the contents appropriately. The availability of FluMist for self-administration provides an opportunity to offer seasonal influenza vaccination more conveniently. For this upcoming 2025 flu season, FluMist will be available two ways: for self and caregiver administration through the online pharmacy, and for administration by healthcare professionals at clinics and pharmacies. Looking ahead, AstraZeneca is continuing to advance the self-administration option with plans to create materials in additional languages and finalize a phase 4 vaccine effectiveness study in the self and caregiver administered population. Thank you. We're looking forward to helping to expand vaccine accessibility for seasonal flu in the United States this coming season. I'm joined here online with Dr. Amy Patel. She's the VP of Hub Operations at Aspen Pharmacy, the online pharmacy service providing support for FluMist Home, and Angela Leone, the Executive Director of Vaccines and Immune Therapies at AstraZeneca.
Thank you. I can imagine there'll be a fair number of questions. And in fact, Dr. Asturias is already ready.
Thank you for that presentation. And thank you for walking us through the process. You did resolve one of my initial questions, but I have a second one. What happens if a patient experiences any potential adverse event at home? What's the mechanism of them reporting, or who's going to be responsible for the subsequent process of not only reporting this, but also taking care of the patient, or that's contained within the instructions? Over.
So there are quite a number of instructions that are available to the patient, both what comes in the package and online. But much like other medications that patients take at home, they'll follow the same steps as they would for other prescription medications. So this includes several ways for them to report adverse events, just as they would with any other medication they take at home. They have access to the Aspen pharmacist through email and chat. They can report it directly to AstraZeneca, and they could also share adverse events directly through VAERS. So it really mirrors what exists now, and it's really similar to that what happens in the retail setting as well.
Thank you. Dr. Sineas.
Thank you. Did your usability studies include speakers of any other languages? And what are the plans for developing materials in particular Spanish and additional languages?
So the usability study primarily had persons who English was their first language. We do intend to have Spanish availability for next season. Our package insert is available in Spanish, and we do have support through Aspen Pharmacy to help Spanish speakers this first year get through the online ordering and any other support that they might need. So they have online support for Spanish and additional language, and a further rollout for Spanish will occur in the future.
Thank you.
I have a question to tag along on that. Are there plans to involve more languages in the next year?
Yes, but not this first launch year where everything we need to sort of, with the website and everything, we need to make sure that is solid in its current form before moving on to additional languages.
Very reasonable. Dr. Chen.
Thank you. With respect to the guidance on amount of time out of refrigerator, that being 12 hours, do you have guidance on temperature range?
The temperature range is the same as it would be in office, and it is fairly standard between like 35 to 45 degrees for Fahrenheit. And most refrigerators in the US are within that range. And that information is clearly provided multiple times to the consumer, to the patient.
Thank you. Dr. Zucker?
Yeah, thank you for the presentation. My question is clarification around the IAS reporting and whether, so the vaccine is shipped to the person, to the household, and then the pharmacy is going to report the dose to the registry. Is there a step in there where there's actually an attestation or verification that the parent has person has actually administered the vaccine?
Yes, I'll have Dr. Amy Patel answer that question.
Thank you. So yes, once we dispense it, we will follow up with the patient or the caregiver to confirm administration, and we won't report to the IIS until that has been confirmed.
Right. Thank you. And then my second question is just that there are, 50 states, 50 plus immunization registries, and just confirming that there will be a system in place to report to all the individual state registries.
Yes. So we are using or contracting with a reporting vendor that's widely utilized across retail pharmacies today to make sure that we have that connectivity to all the jurisdictions throughout the country.
Yeah, and what kind of testing is done? Because I know, just thinking back to COVID and the pharmacy program, there were some difficulties that were encountered with the pharmacy reporting. So just wondering what kind of advanced work is being done to make sure that you don't run into the same problems.
Yes. So we've already started contracting with the company and building out the connection. So we plan on having the testing completed before September, when we anticipate the first reporting to occur.
Thank you.
Ms. Lyons?
Yes, thank you. To piggyback on to Dr. Zucker's question, are you anticipating any issues with any state laws for linking to an IIS via an online pharmacy versus a pharmacy that has a physical location in that state?
I'll have Dr. Patel answer that she's with Aspen.
Yes, it has been brought to our attention that some of the states do require local jurisdiction, a local physical site to report into that jurisdiction. So we're going to work with the IIS to determine where or how we can work with them.
Okay, thank you. May I ask a second question?
Absolutely.
You said on slide CO15 that the pharmacy will comply with state rules and regulations based on shipping address. I'm making an assumption that means you'll follow state laws as to the age that pharmacists can prescribe. If that's correct, then my question is there any mechanism to offer FluMist at home to a younger child, for instance, through a prescriber, through a provider prescription?
So I'll have Andrew Leone respond to that.
Yeah, so obviously each of the states have different pharmacy laws, so that will be worked into the modeling. So if an individual is under the age of, let's say, 7 and in that state, they cannot receive through the pharmacy, that would be blocked. A message would come up to instruct that individual to go to a traditional setting. So obviously FluMist will be available in traditional settings, and so if not available through this service, they would be encouraged to talk to their pediatrician and or healthcare provider.
Thank you.
Ms. Moser.
Yeah, I just had a question. I'm figuring you had pretty good compliance in your trials. What are the mechanisms that you have in place regarding follow-up beyond text messaging and the return or this getting rid of unused vaccine? Do you anticipate that to be a significant issue, and how are you planning to think about and address that?
So if you bring up slide 31, yes. Yeah. So we've made this, the returns program really as simple and easy as possible. Everything is pre-printed, pre-labeled. It can go right back in the mailbox. Multiple sprayers can go into it. And I think we don't anticipate that this would be a problem for folks to comply with.
I guess my question is if they order the vaccine and then say they go and get it somewhere else and they don't want to use their FluMist dose. I guess that's where I'm thinking about unused vaccine as opposed to the waste from a vaccine after it's administered.
I'll have Dr. Patel respond to that, since that would be a still dispensed product.
So unfortunately, we are not able to take returns on products once it's been dispensed, just for safety reasons. So they would be instructed to dispose of it in the same manner as they would a used vaccine.
Thank you.
Dr. Lair.
So as the chair of the flu work group, there are a number of other questions that the work group wanted to make sure the ACIP is aware of. I thank the presenters for the excellent presentation and all the questions that have been asked so far, which covered a number of the questions that the work group had. One of the work group questions was, will it be possible to distinguish self from provider administered vaccine on the registries? Will there be some clue that we would understand that for?
Yes, we've had that come up a lot, and it will absolutely be able to distinguish. Importantly, the NDC number for self-administered versus healthcare administered FluMist differs. So in the vaccine registries, you'd be able to identify it through that process, through the NDC code.
Thank you. Do we have any sense of how to handle problems when a child ends up not getting the vaccine or wiggles so much that the vaccine doesn't go in the nose or gets squirted on the cheek? And how would the parents manage that kind of situation to get another dose when they didn't get a full dose for some reason?
I'll have Dr. Patel answer that.
Okay. In that situation, they could call into the pharmacy, let us know what happened. We would do the appropriate reporting to VAERS. We would also work with their insurance to be able to get that patient a second dose through like overrides that may be available. And then we would space it out by 4 weeks.
Thank you. And then the last comment, which is really not a question, but is more of a comment. There are a lot of people who are required to prove that they have gotten the flu vaccine. And there's always these questions about whether or not a self-administered at home would be sufficient. We didn't feel that was appropriate for the manufacturer. That would be more the hospital or the organization saying how they would accept a home dosing or not. And so if the hospital says, we're not going to accept a home dosing, that would just be something the hospital would say. But it's not fair to the manufacturer to have to come up with a specific system to qualify for certain rules of different organizations. That's all I had. Thank you.
Thank you all. Lots of good questions. We are going to take a 15-minute break. We would love to start earlier so we have to stay on time, but it's unclear if we're going to be able to do that. So please return and be ready at 11:30. Welcome back, everyone. We will begin our next session on the COVID-19 vaccines, and our introduction will be started by Dr. Schechter.
Thank you, Dr. Talbot. Good morning. Next slide, please. To recap, in August 2024, the U.S. Food and Drug Administration authorized and approved the 2024-2025 COVID-19 vaccines, including 2 mRNA-based vaccines from Moderna and from Pfizer-BioNTech in persons at least 6 months of age, and the protein-based Novavax vaccine in persons at least 12 years of age. Next slide. Last year, ACIP made recommendations for everyone aged at least 6 months to receive 2024-2025 COVID-19 vaccination. Specifically, children aged 6 months through 4 years need multiple doses to be up to date, including at least 1 dose of 2024-2025 COVID-19 vaccine. People aged 5 to 64 years should get 1 dose, and people who are either at least 65 years or who have moderate or severe immunocompromise and at least 6 months of age should receive a second dose of 2024-2025 COVID-19 vaccine 6 months after their first dose. And people with moderate or severe immunocompromise may receive additional doses of 2024-2025 COVID-19 vaccines under shared clinical decision-making. Next slide. Turning to data on COVID-19 outcomes in the last years and months. For these last 4 years of provisional weekly COVID-19 deaths in the United States reported to CDC from October 2021 through March 2025, there are trends for each subsequent year to have lower numbers of deaths. In the first 3 years, we see 2 surges per year, the first being early in the calendar year in the winter, followed by a late summer or fall surge. For the first 3 years, the winter surge was larger than both the following summer-fall surge and higher than the previous summer-fall surge in the preceding year. This pattern has changed in 2025 for the blue line at the bottom, in which the surge in the recent months in early 2025 was lower than the summer-fall surge on the right-hand side of the purple trend line in summer-fall 2024. Next slide, please. Turning from deaths to hospitalizations reported to CDC from COVIDNet, similar patterns over these last 4 years, with an early 2025 winter surge that was of smaller magnitude than the summer-fall 2024 surge in the red trend line. This raises the question about what the rest of 2025 holds. Will there be additional surges occurring at similar or different times in late summer, early fall? And will additional surges be, how will they compare to the level of disease seen in early 2025? Next slide, please. In this slide, we have estimates from CDC on illnesses, outpatient visits, hospitalizations, and deaths due to COVID-19 on the middle row, and from influenza infection on the bottom row. And with the combination of decreased amount of COVID-19 disease compared to previous years, and an influenza season that appeared to be more severe or with higher level of disease than the 2023-2024 previous season, these estimates are generally larger for influenza than for COVID-19. However, looking at the more severe outcomes towards the right-hand side of the table, the lower estimate for deaths is comparable between the two diseases, reflecting that for a case of COVID-19, a severe outcome is more probable than for any given case of influenza. A couple of other observations: that even at lower levels, tens of thousands of Americans have perished with COVID-19, and that many of these are potentially vaccine preventable. And additionally, that this table covers many outcomes, but does not include post-acute sequelae or long COVID information. Next slide, please. Turning to vaccination coverage for the current formulation, in green, the 2024-2025 formulation, or the prior 2023-2024 formulation in blue. For both of these formulations, cumulative coverage for adults 18 years and older topped out by springtime at about 20% of the adult population in the United States, reflecting that there are a majority of adults in both years, including adults at older ages with higher risks of severe outcomes who have not been immunized. Next slide, please. Since the committee met last October, the work group has heard presentations on a number of topics to inform considerations for risk-based versus universal vaccine recommendations for the 2025-2026 COVID-19 vaccines. Topics including COVIDnet data for those with or without risk factors, mortality, vaccine hesitancy and uptake, vaccine safety and effectiveness, a new vaccine candidate from Moderna named mRNA-1283, seroprevalence of SARS-CoV-2 infections in the population, post-COVID conditions, multisystem inflammatory syndrome in children, and feedback from liaison organizations. Next slide. Today's session will include a presentation from Dr. Rizkallah of Moderna regarding its mRNA-1283 vaccine candidate, and from CDC presenters, Dr. Havers talking about epidemiology and risk factors for COVID-19 hospitalizations, Dr. Link Gellis on current vaccine effectiveness updates, and from Dr. Panayotopoulos, workgroup considerations for use of 2025-26 COVID-19 vaccines. Next slide. After today's presentations, a preliminary timeline for forthcoming 2025-26 COVID-19 vaccines includes an anticipated meeting of the FDA Vaccines and Related Biological Products Advisory Committee to review strain selection. At the next scheduled ACIP meeting in June, discussion and vote on recommended use. And by late summer or early fall, anticipated availability of the 25-26 COVID-19 vaccines. Next slide. Continued thanks to fellow ACIP members, ex officio and government members, liaisons and consultants who dedicate their time to these many meetings, and the review led by our intrepid CDC co-leads. Next slide. And gratitude as well to the large team of CDC participants who provide timely and detailed data to inform our deliberations. Thank you.
Thank you. Dr. Rizkallah, are you ready?
I am. Just give me one moment to share slides. Just confirming you can hear me okay and see the slides?
Yes, to both.
Excellent. Well, thank you for the opportunity to present this morning. My name is Bishoy Rizkallah. I am the Medical Affairs Lead for Moderna's infectious disease portfolio. Today, I will provide an update on our next generation COVID-19 vaccine, mRNA-1283. COVID-19 remains a leading infectious disease cause of hospitalization and death in the United States. When we consider where risk of severe disease is greatest, advancing age with the increasing impact of immunosenescence, and those with pre-existing medical conditions continue to be a key focus for public health. This is the basis for developing our next generation COVID-19 vaccine to enable optimal protection, particularly in those most vulnerable. While current COVID-19 vaccines present the entire spike protein, mRNA-1283 is designed to present specifically the N-terminal and receptor binding domains of the SARS-CoV-2 spike protein, which contain the key epitopes critical for eliciting potent neutralizing antibody and T-cell responses. By focusing on these important regions, mRNA 1283 achieves a streamlined vaccine design, substantially reducing the mRNA sequence length and enabling a lower dose of 10 micrograms, which is just 1/5 of the Spikevax dose. This innovation positions mRNA 1283 as the foundation for future combination vaccines, such as mRNA 1083, Moderna's investigational flu-COVID combination vaccine. For context, over the past 5 years, mRNA 1283 has been evaluated in a comprehensive clinical development program spanning phase 1, 2, and 3 studies. Today, I'll focus specifically on the pivotal phase 3 study, assessing its safety, immunogenicity, and efficacy. Study 301 is a randomized, blinded, active control phase 3 trial. Participants aged 12 years and older were randomized 1-to-1 into 2 groups to receive either mRNA 1283 or to receive mRNA 1273, which is commercially known as Spikevax. Both vaccines are bivalent formulations targeting the original SARS-CoV-2 strain and Omicron BA.4/5 variants, reflecting the updated vaccine recommendations at the time of enrollment in 2023. The study's primary objectives are threefold: to assess safety and reactogenicity, to demonstrate non-inferior neutralizing antibody responses, and to demonstrate non-inferior relative vaccine efficacy for the prevention of CDC-defined COVID-19. The demographics and baseline characteristics were well balanced between the groups across age, race, and ethnicity. The median age was 56, with approximately 29% of participants aged 65 years and older. The study demographics are largely representative of the United States, with 76% of the overall study population recruited here in the US. Nearly half of the study population had a chronic condition classified by the CDC as being associated with severe COVID-19 outcomes, including conditions such as diabetes, heart disease, and asthma. Prior COVID-19 vaccination and SARS-CoV-2 infection history was also balanced between the two groups. Approximately 3/4 of study participants had a prior infection, which is consistent with the epidemiology at the time of enrollment in 2023. Most participants had also received 3 or 4 prior COVID-19 vaccines, with the last dose being a median of 9.8 months prior to enrollment. Transitioning now to the results, starting with safety. Local and systemic reactions to both study vaccines were evaluated for 7 days post-vaccination. All unsolicited adverse events were monitored for 28 days. In addition, medically attended adverse events, serious adverse events, events leading to discontinuation, and events of special interest, including myocarditis and pericarditis, are monitored for the duration of the study, which is 1 year. The study was overseen by an external, independent, unblinded data and safety monitoring board. The median safety follow-up in this study was 8.8 months. Here are the solicited local events within 7 days of vaccination, with mRNA 1283 on the left in light blue and Spikevax on the right in dark blue. The most common local reaction was pain, which trended lower when compared to Spikevax. Local adverse reactions were mostly grade 1 and grade 2 and transient in nature, with a median duration of 1 to 2 days. Solicited systemic events were similar in frequency between the two groups, with fatigue noted as the most frequent event. Most events were grade 1 and 2 and transient, with a median duration of 1 to 2 days. Presented here are the unsolicited adverse events within the first 28 days after injection. Serious adverse events medically attended events, events leading to discontinuation, and events of special interest were balanced between the two groups. So to summarise safety through the median follow-up of 8.8 months in this analysis, we have not observed any imbalances in adverse or serious adverse events between the vaccine groups. There were no reports of myocarditis or pericarditis. No safety concerns were identified. Turning now to immunogenicity. This slide presents the primary immunogenicity endpoints for mRNA-1283 versus Spikevax at day 29. Neutralizing antibody responses and geometric mean ratios are shown at the top, while seroresponse rate differences are displayed at the bottom. This study achieved all pre-specified immunogenicity objectives. For geometric mean ratios, the lower bound of the confidence intervals were above 0.667, surpassing the non-inferiority threshold. In fact, the lower bound was above 1, indicating higher neutralizing antibody responses with mRNA-1283 compared to Spikevax. Likewise, the lower bound for the difference in seroresponse rates was above minus 10%, meeting the criteria for non-inferiority. Notably, the lower bound was above 0, which again indicates higher seroresponse rates with mRNA-1283. This slide presents the BA.4/5 neutralizing antibody responses for mRNA-1283 versus Spikevax at day 29, broken down by age groups. The bar graphs illustrate neutralizing antibody responses with the corresponding geometric mean ratios displayed above each data set. Both vaccines elicit strong immune responses in adolescents, with a geometric mean ratio of 1.0. Notably, the relative neutralizing antibody responses with mRNA-1283 versus Spikevax increases with age, with the highest geometric mean ratio observed in adults 65 and older, with a ratio of 1.8. mRNA-1283 consistently sustains higher neutralizing antibody responses compared to Spikevax over time. While this trend is evident in the overall study population, shown here are the neutralizing antibody responses against Omicron BA.4/5, specifically in adults aged 65 and older, a group at increased risk for severe COVID-19 outcomes. Geometric mean ratios and antibody levels are presented at day 29, month 3, and month 6 post-vaccination. As illustrated, mRNA-1283 elicited higher antibody responses than Spikevax at day 29 and sustained these higher responses through at least 6 months. Notably, antibody levels at 6 months with mRNA-1283 remained higher than those achieved by Spikevax even 3 months earlier at day 91. Up to this point, we've discussed data from our pivotal safety and efficacy study evaluating the bivalent BA.4/5 vaccine, which was the recommended formulation at the time of trial enrollment in 2023. Additionally, we assessed immune responses to a monovalent XBB 1.5 vaccine in a separate study conducted in Japan, which, like the pivotal efficacy study, included participants aged 12 years and older. In this study, the monovalent formulation met the non-inferiority margin. Notably, the lower bound of the confidence interval again exceeded 1, consistent with the pivotal efficacy study findings indicating higher neutralizing antibody responses elicited by mRNA-1283 compared to Spikevax. These results demonstrate that mRNA-1283 elicits consistent immune responses, whether formulated as a monovalent vaccine or as a bivalent vaccine. Turning now to the primary objective of relative vaccine efficacy. The primary relative vaccine efficacy objective was evaluated using the CDC case definition of COVID-19, requiring a positive SARS-CoV-2 PCR test and at least one clinical symptom consistent with COVID-19, as listed here on the slide. Surveillance was conducted using bi-weekly electronic diary prompts. Presented here are the relative vaccine efficacy results over a median follow-up of 8 months. The study met the pre-specified non-inferiority criteria for success, defined as the lower bound of the confidence interval exceeding minus 10% relative efficacy. mRNA 1283 demonstrated a relative efficacy of 9.3% compared to Spikevax for the prevention of CDC-defined COVID-19. This slide presents the relative vaccine efficacy of mRNA 1283 versus Spikevax across pre-specified age groups. In adults, we see a trend of increasing relative vaccine efficacy with advancing age, reaching the highest point estimate of 13.5% in those aged 65 and older. In adolescents, comparable immune responses between mRNA 1283 and Spikevax support the expectations of similar protective efficacy, although the smaller sample size, lower attack rate, and fewer cases led to an imprecise point estimate with wide confidence intervals. Overall, the efficacy data align closely with our earlier immunogenicity findings. Adults aged 65 and older showed the highest relative neutralizing antibody levels, and correspondingly, the highest point estimate for relative vaccine efficacy. Nearly half of the study population had at least one CDC-defined comorbidity associated with increased risk of severe COVID-19 outcomes. This slide presents a post hoc analysis assessing relative vaccine efficacy of mRNA 1283 compared to Spikevax in individuals at progressively higher risk due to underlying health conditions. The top row shows efficacy in participants with at least one CDC-defined comorbidity. Subsequent rows examine the combined effects of age and comorbidity together, highlighting their cumulative impact on COVID-19 severity. The relative efficacy of mRNA 1283 increases across these higher risk subgroups, with the greatest benefit observed among adults 65 and older that have at least one CDC-defined at-risk comorbidity. While this study was not powered to assess severe COVID-19, and there were too few cases to evaluate efficacy based on hospitalizations, we conducted a post hoc analysis using the FDA-defined criteria for severity. A total of 55 cases met the criteria for severe COVID-19, with approximately 93% classified as severe due to blood pressure or oxygen saturation abnormalities. mRNA 1283 demonstrated a relative vaccine efficacy of 38.1% for the prevention of severe COVID-19 compared to Spikevax. This suggestion of improved protection against severe COVID-19 and also the relative efficacy in those with comorbidity needs to be validated in future real-world effectiveness studies. So to summarize, the data presented today demonstrate that mRNA 1283 is generally well tolerated with no safety concerns identified. The study met its primary non-inferiority endpoints for immunogenicity and relative vaccine efficacy compared to a highly effective standard of care, Spikevax. While the study was designed to demonstrate non-inferiority, we observed higher immune responses with advancing age and a trend for higher vaccine efficacy with a positive point estimate in adults with advancing age and in those with chronic conditions associated with poor COVID-19 outcomes. Together, these findings underscore the potential of mRNA 1283 as a critical tool to further reduce the burden of COVID-19 particularly amongst those at highest risk. We present this data today to support the consideration of mRNA 1283 for the inclusion into future COVID-19 vaccine recommendations. The PDUFA date is anticipated by the end of May, and we plan to supply mRNA 1283 as an option for COVID-19 prevention this upcoming fall. The vaccine formulation will be updated to match the circulating SARS-CoV-2 variants when recommended by the FDA. With that, I'd like to thank you for your attention, and I'd like to thank all the individuals and colleagues who made these studies possible. We'll be happy to take any questions.
Thank you. Any questions? Dr. Asturias.
Yes, and thank you for that presentation. And this is probably an unfair question, but one that I still want you to sort of explore. Is the lower antigen in this vaccine sort of suggesting anything in terms of perhaps now that most of the population is naturally or vaccine protected and immunized, and a better sort of lower antigen in this vaccine, a better sort of a strategy than the higher dose Spikevax that we have used in the past. Perhaps now that most of the population is naturally or vaccine immunized, There was a lot of echo. I don't know if you want me to repeat the question.
That would be great. Thank you.
All right. So the question is, would you sort of try to explore the issue?
I'm sorry, we seem to be missing audio from the Zoom. Can you still hear me okay?
I can hear you fine.
We can hear you well.
Can you hear me? Yes. Dr. Asturias, can you hear us here?
I can hear you well.
Okay. Would it be possible to email Dr. Roscoe?
Yep, we can hear you.
Can you hear us now?
We lost you for a little while. Yes.
Okay, fantastic.
Okay.
Dr. Asturias was actually going to re-ask his question, so now that you have audio again, we'll let him start.
Yes, please. Thank you.
So again, my question was regarding the use of a fifth of antigen dose in this new formulation of the vaccine, and for you to give some perhaps a bit of an insight that is this now potentially a better strategy given the immunity, natural or vaccine induced, that we have had in most of the population, versus the traditional sort of a high dose antigen that you had previously. And the reason I'm asking this is because we have seen this with other vaccines where, boostering a lower dose may be much better than the traditional dose.
Thank you for your question. So the receptor binding domain and the N-terminal domain have been well described as really harboring the key epitopes that are critical for neutralizing antibodies and cell-mediated immune responses. What we've been able to demonstrate clinically is that at a fraction of a dose, we're able to achieve higher levels of neutralization with mRNA 1283 with this construct by comparison to a spike-based protein antigen design. Now, we've got a variety of clinical and non-clinical work that has gone to describe this further. So a variety of various compositions made up of various variants clinically. So original SARS-CoV-2, beta, we've looked at various Omicron variants, including BA1, BA45, XBB 1.5, and non-clinically, we've looked at recent variants as well, such as JN1 and KP2. Now, what remains consistent throughout all those investigations is this consistent pattern that mRNA 1283 outperforms Spikevax in terms of its ability to induce higher neutralizing antibodies. But ultimately, that's why we've conducted an efficacy study to show that this intrinsic relationship between neutralizing antibodies translates into efficacy and protection, which we've been able to demonstrate. So I would say we've now got an expansive body of evidence that supports a vaccine design with this construct.
Thank you. We're running a little behind, so I'm going to ask Dr. Shaw, Dr. Sinais, and Ms. Moser to ask their questions quickly. And then please, everyone else has their hand held. We're going to try to come back to this as long as Dr. Rizkallah can stay on the line. Dr. Shaw?
Okay, thanks. Thanks for that presentation. I'll do two questions. I think I saw there was one fatal event in the Spikevax group, if you wanted to comment on that. And I think my other question was if there are any inhomogeneities in either history of prior COVID or vaccination history in the groups, which we know both can affect immune responses. Thanks.
I'll answer the second question first, and then I'll ask my clinical colleague, Dr. Shalkas, to take your first question. So in terms of responses based on prior doses of COVID-19 responses, we were able to look at that through sensitivity analysis in our data set. We've looked at it both in terms of immune responses and efficacy. And what we've been able to show is that mRNA-1283 induces higher immune responses versus Spikevax, regardless of the number of prior doses that an individual has received. And that translates into a consistent efficacy, largely reflective of that immune response. And efficacy is maintained and in line with the primary analysis that was presented today. But in terms of your first question, Dr. Shalkas, do you want to take that question?
Yes, hi, this is First Shalkas from Moderna. Indeed, there were no fatal events in the 1283, the investigational vaccine group, and there was one fatal event in the Spikevax group. This pertains to a 77-year-old female with history of cardiovascular disease. It was a sudden death that happened within a week after immunization, and the investigator considered that event as unrelated and attributed the event most likely to the underlying cardiovascular illness. Thank you.
Thank you. Dr. Sinais.
Thank you. Your studies included patients with greater than one comorbidity. Did it include immunocompromised patients?
No, immune-compromised individuals were not included in the study. But we would expect largely, given a common platform with Spikevax and the immune responses that we see, that the vaccine will perform in a similar magnitude to Spikevax.
Thank you.
Ms. Moser.
Thank you. The potential for higher and more durable immune responses in older people is good to see. But I'm wondering if you could comment on the similar rates of adverse events, even though there was a lower dose used in the newer vaccine.
Yeah, so both vaccines really induce a robust immune response, and we wouldn't necessarily expect to see necessarily differences in systemic events with two robust immune response vaccines that induce robust immune responses. We do see, however, a trend for lower local reactions. That may be largely explained by two factors. One, the lower dose of mRNA-1283, but also a smaller injection volume with mRNA-1283. So it's 10 micrograms administered in 0.2 ml with mRNA-1283 versus Spikevax, which is 50 micrograms administered in 0.5 ml. That might be the reason why we see a trend for lower local events.
Thank you. We will continue with these questions after the last presentation of this session. So hang tight, I haven't forgotten you. We're going to move on to epidemiology and risk factors by Dr. Havers.
Thank you, Dr. Talbot. Next slide. Today I'll be discussing recent trends in the epidemiology of severe COVID-19, largely using data from the COVID-19 Associated Hospitalization Surveillance Network, or COVIDNet. COVIDNet is one of 3 ResMet platforms, in addition to RSVNet and FluServNet, that collect data using similar methods in catchment area on laboratory-confirmed COVID-19 RSV, and influenza-associated hospitalizations, respectively. COVIDNet is a population-based surveillance system that collects data on hospitalizations from more than 300 acute care hospitals in 98 counties across 13 states, and the catchment area covers about 10% of the U.S. population. Hospitalizations reported to COVIDNet include all those where a positive SARS-CoV-2 test result was reported within 14 days prior to or during hospitalization. And testing for SARS-CoV-2 is driven by clinical judgment and facility policies. We collect data, including basic demographic data for rates on all patients, while detailed clinical data, including outcomes and underlying medical conditions, are collected by trained surveillance officers from an age and site stratified random sample. Next slide. The next several slides will show hospitalization rates for COVID-19 in red, influenza in blue, and RSV in green. For ResMed, the surveillance periods extends from October through September of the following year. The inset, which shows rates since the beginning of the pandemic, is shown for context, and weekly rates for the last 2 seasons, from October 2023 through March 2025, the ongoing season, are shown in the main graph. COVID-19 hospitalization rates peak in both winter as well as during the summer, and as you can see, there was a large summer wave in 2024. This differs from RSV and influenza, which generally have a single peak in the winter. Next slide. You can see the impact of this year-round circulation in this figure, which shows cumulative rates of COVID-19, influenza, and RSV hospitalizations for the same period as the previous slide. Cumulative rates are the sum of consecutive weekly rates. Cumulative rates of COVID-19 hospitalizations for the ongoing 2024-25 season, shown in the solid red line, are lower than what was seen in the prior season, shown in the dashed red line. While cumulative rates of influenza for the ongoing 2024-25 season, shown in the solid blue line, are higher than rates of COVID-19 hospitalizations for the current season, they remain lower than last year's COVID-19 hospitalization rates. Next slide. This slide also shows that many COVID-19 hospitalizations occur outside the typical respiratory virus season of October through April, which is shown in dark red. Hospitalizations occurring May through September are shown in lighter red. In 2023-24, the period that we have the most recent complete season, a third of COVID hospitalizations took place outside the normal respiratory virus season. Based on previous patterns, we may see ongoing circulation of COVID-19 through the summer, while hospitalization rates for RSV and influenza may continue to trend down. Next slide. This figure is another way of putting recent epidemiology in context by showing cumulative rates of COVID-19 associated hospitalizations, but over multiple surveillance seasons and shown by age group, with the highest rates in infants less than 6 months on the far left and adults 75 years and older on the far right. For each age group, rates of the COVID-19 hospitalizations have decreased over time since the peak at the 2021-22 season, but cumulative rates among adults ages 75 years and older for the 2023-24 season remained higher than those experienced by any other adult age group for any previous season. Next slide. Note that different respiratory viruses affect different age groups in different ways, with the biggest collective impact at the extremes of age. This figure shows cumulative rates of laboratory-confirmed hospitalizations for COVID-19, influenza, and RSV. As you can see, RSV in green contributes to the highest burden of respiratory diseases in children less than 5 on the left. But here you can also see in red that COVID-19 has an outsized impact on older adults. This is data from the 23-24 season. Next slide. For the next several slides, I'm going to focus on the epidemiology of pediatric COVID-19 associated hospitalizations. Next slide. This figure shows the percentage of COVID-19 associated hospitalizations by age group by week from March 2020 through March 2025. For the most recent 12 months, pediatric hospitalizations, shown in green, comprised about 4% of all COVID-19 associated hospitalizations, the majority of which occur in children under 5. Next slide. This slide shows hospitalization rates by pediatric age groups for the last several seasons, starting in October 2022 through March 2025. Week after week, rates of COVID-19 hospitalizations are highest among infants less than 6 months of age, shown in the dark blue line. Next slide. So this figure is the same as the previous one, except that infants less than 6 months who are not eligible for COVID-19 vaccines are not shown, but the scale of the y-axis is preserved. Next slide. Finally, this figure is the same as the previous one, except the y-axis is adjusted to better see hospitalization rates among children 6 months and older and who are eligible for COVID-19 vaccination. The youngest children displayed, those ages 6 months to 4 years, have the highest rates of COVID-19 hospitalization among these age groups, shown in the blue line, followed by children ages 5 to 11, shown in red, and adolescents ages 12 to 17, shown in gray. Next slide. To put COVID-19 pediatric hospitalizations in the context of another vaccine-preventable disease, influenza, this chart shows historic seasonal cumulative rates of pediatric influenza hospitalizations, shown in blue, and COVID-19 hospitalizations, shown in red. Generally, for both pathogens, hospitalization rates are higher in children less than 5, shown in the left part of the chart, compared with rates of school-aged children and adolescents ages 5 to 17, shown on the right. Next slide. Looking more closely at the data from the previous slide, among children less than 5 years of age, for the two most recent seasons with complete data, COVID-19 hospitalization rates are comparable to influenza hospitalization rates. Next slide. However, among adolescents 5 to 17 years, in the two most recent seasons with complete data, influenza hospitalization rates have generally been higher than those due to COVID-19. Next slide. Not only do hospitalization rates vary widely by pediatric age group, but the clinical characteristics, including underlying medical conditions of infants, children, and adolescents who are hospitalized with COVID-19, also differed by age during recent seasons, as shown on this slide. Among children and adolescents aged 6 months and older hospitalized with COVID-19, 59% had one or more underlying medical conditions, but the proportion of hospitalized children with underlying medical conditions increased with increasing age. Among children 6 to 23 months of age, less than half had an underlying medical condition, and prematurity, shown in light blue, was the most prevalent condition. Among the three older age groups, asthma and reactive airway disease, shown in gold, and neurologic disorders, in light green, were the most prevalent conditions among children hospitalized for COVID-19. Next slide. Among children who are hospitalized for COVID-19, many continue to experience severe outcomes across all the pediatric age groups. From July 2023 through March 2024, approximately 1 out of 5 hospitalized children were admitted to the intensive care unit, 41% of whom had no underlying medical conditions, although the proportion with no medical conditions varied by age group. Also during this period, 7 children with COVID-19 associated hospitalization died in hospital in the COVID-net catchment area. Next slide. This slide shows the vaccination status of children hospitalized for COVID-19 during the 2023-24 season. Fewer than 10% of children and adolescents hospitalized with COVID-19 had received any vaccine within the 12 months preceding their COVID-19 hospitalization. And additionally, fewer than 5% of the hospitalized children and adolescents had received the recommended 23-24 COVID vaccine for that season, as shown in dark blue, suggesting that many of these hospitalizations were potentially preventable had the child received the recommended vaccine. Next slide. So in summary, for pediatrics, rates of COVID-19 associated hospitalizations are highest among the youngest age groups. Although among school-age children, hospitalization rates have been higher for influenza than COVID-19. More than half of children and adolescents hospitalized with COVID-19 had more than one underlying condition, and this increased with increasing age, but a substantial proportion of children had no underlying medical conditions. And the most common underlying conditions also varied by age groups. And again, as we saw, the vast majority of children who were hospitalized with COVID had not received the most recently recommended COVID-19 vaccine during the 2023-24 season. Next slide. I'm now going to turn my focus to COVID-19 hospitalizations in adults. Next slide. As noted previously, adults comprise the vast majority of COVID-19 hospitalizations, with older adults being most impacted. This figure shows the proportion of COVID-19 associated hospitalizations by adult age groups from March 2020 through March 2025. For the most recent period, highlighted by the red box, adults aged 65 years and older comprise more than 2/3 of all hospitalizations in adults. Among adults 75 years and older comprise nearly half, 48%, of all COVID-19 adult hospitalizations, despite the fact that they make up only 9.2% of the US population. Next slide. The outsized impact on adults 75 years and older is shown in this slide, which shows COVID-associated hospitalization rates cumulatively for the 2023-24 season by age group. At 1,410 hospitalizations per 100,000 populations, this means that more than 1 out of every 100 adults 75 years and older were hospitalized with COVID-19 that year. The table on the right indicates the rate ratios relative to this 75 years and older age group. So rates among adults 75 years and older were 3 times as high as those in adults 65 to 74, nearly 9 times as high as those adults 50 to 64, and 24 times as high as adults ages 18 to 49. And the rate ratios are similar to those that we're observing in the ongoing 2024-25 period. Next slide. So similar to the pediatric slides that I showed, this chart shows historical seasonal cumulative rates of influenza hospitalizations in blue and COVID hospitalizations in red among adults. So you can see that for the past seasons for which we have complete data, generally speaking, among older adults on the right, the rates of COVID hospitalizations have generally been higher than those due to influenza. Next slide. Certain underlying medical conditions increase the risk of COVID-19 associated hospitalizations in adults. This figure shows results from an analysis led by Sarah Hamid that shows the adjusted rate ratios comparing the risk for COVID-19 associated hospitalizations among adults with a condition compared to those without that condition, using COVID-19 hospitalization data and population data from the Behavioral Risk Factor Surveillance System. Chronic kidney disease, diabetes, and coronary artery disease were associated with increased risk in all age groups. In the presence of these conditions, increased the risk of COVID-19 associated hospitalization by anywhere from 1.6 to 8.8 times, depending on the age group. And other conditions such as stroke, COPD, severe obesity, and current smoking were also associated with increased risk in some age groups. Except for COPD, the relative risk of COVID-19 associated hospitalizations in adults with and without select chronic conditions declined with age. Next slide. As with children, significant proportions of adults hospitalized due to COVID-19 experience severe outcomes, with the proportion experiencing ICU admission shown in tan, invasive mechanical ventilation shown in blue, and in-hospital deaths shown in red. Approximately 1 in 5 patients in all adult age groups were admitted to the ICU, while in-hospital death was more common among adults 50 years and older. I do want to note that the proportions on these slides are only in-hospital deaths. We've shown from previous analyses that deaths after discharge from COVID-19 associated hospitalization are common among older adults, with a significant proportion occurring within 30 days of hospital discharge, and including among those discharged to hospice. Next slide. This slide is similar to the vaccination status slides shown for pediatrics, and it shows the proportion of COVID-19 associated hospitalizations by vaccination status among adult age groups for the 23-24 season. Among adults 65 years and older, highlighted in the box on the far right, 50% of those who were hospitalized had received neither the 22-23 vaccine or the 23-24 vaccine. About 26% of adults 65 years and older who were hospitalized with COVID had received the recommended 23-24 vaccine prior to admission, but the majority had not. Next slide. One particularly vulnerable group that I want to highlight is nursing home residents. In the 23-24 season, nearly a quarter of adults 75 years and older who were hospitalized with COVID were long-term care facility residents, indicating that they're at much higher risk of severe COVID-19 disease. However, as these data from an MMWR published by the National Healthcare Safety Network was published during this season, only 30% of nursing home residents had received the 2024-25 COVID-19 vaccine. Next slide. So in summary, rates of COVID-19 hospitalizations are highest among the oldest age groups, with adults aged 75 years and older accounting for about half of all adult hospitalizations. COVID-19 associated hospitalization rates have decreased over time, but we've seen for the most recent season that we have complete data that in adults 75 years and older, they still remain very high and were higher for all other adult age groups, even compared to previous seasons. In addition, the risk of hospitalization with COVID-19 remains during the summer months. And most patients that were hospitalized for COVID-19 had not received the most recent vaccine prior to hospitalization. Next slide. There are some underlying conditions that increase the risk for COVID hospitalization among adults. with chronic kidney disease, diabetes, and coronary artery disease increasing risk in all adult age groups. But in general, the relative risk of COVID-19 hospitalizations among adults with or without conditions declined with age for most but not all conditions examined. So with that, I will conclude my talk, and I think we were taking questions later, so I'll hand it back to Dr. Talbot.
So Dr. Lynn Gellis will talk about vaccine effectiveness updates.
Thank you. Today I'll be presenting COVID-19 vaccine data to inform the policy questions under consideration by ACIP for the 25-26 season. I'll start with some context for interpretation of VE and information on the 24-25 COVID-19 vaccination coverage. I'll then present VE methods for 2 CDC vaccine effectiveness platforms included in the presentation, and then interim estimates of 24-25 COVID-19 VE. Patterns of prior infection can impact measured vaccine effectiveness. This graph provides some context specifically for interpreting VE of 24-25 COVID-19 vaccines by showing the proportion of persons with infection-induced immunity by age group during October to December 2023, that is about 8 months before introduction of the 24-25 vaccines. During this period, all adult age groups had high rates of infection-induced immunity, above 70% for all age groups and close to 90% for those aged 16 to 64 years. Past infection can provide some protection from future infection, and VE findings should therefore be interpreted as the added benefit provided by COVID-19 vaccination in a population with a high prevalence of infection and vaccination-induced immunity. Here we see data on uptake of 2023-24 and 2024-25 COVID-19 vaccines through the fall of each year. The light blue line shows coverage during the fall of 2023 for the 23-24 vaccines, and the dark blue line shows coverage during the fall of 2024 for the 24-25 vaccines. In the left-hand graph, we have uptake for all adults aged 18 years and up, in the middle for adults aged 65 to 74 years, and on the right for adults aged 75 years and up. Note that vaccines were available about 3 weeks earlier for the 24-25 season compared to 23-24. We can see that coverage was similar across years for all adults, but slightly higher in older adults for the 24-25 season. Coverage for the 24-25 vaccine topped out at just under 25% for adults 18 and up, and at about 41 to 47% for the older adult age groups. I'll now go through some high-level methods for COVID-19 vaccine effectiveness. First, a note here on how we measure vaccine effectiveness. When COVID-19 vaccines were first released, we measured absolute VE, which compares the frequency of health outcomes in vaccinated versus unvaccinated people. Absolute VE has most often been used to measure VE during the era of original monovalent and bivalent COVID-19 vaccines. During the bivalent era, however, we also measured relative VE, which compares the frequency of health outcomes in people who received one type of vaccine to people who received a different vaccine. For example, people who received a bivalent dose versus those who only received the original monovalent COVID-19 vaccine. Generally, for the 24-25 COVID-19 vaccines, we've combined absolute and relative VE and measured protection as the frequency and disease in those who received a 24-25 vaccine to those who did not, regardless of past vaccination or infection. In other words, the comparison group for the 24-25 VE analyses that I'll share today includes people who were unvaccinated, as well as those who received original monovalent, bivalent, and 23-24 COVID-19 vaccine doses. Of note, this is similar to how seasonal influenza vaccine effectiveness is measured each year. The first VE platform included today is the VISION network, a multi-site network of electronic health records at over 300 emergency departments and urgent cares and over 200 hospitals. VISION uses a test-negative design and includes eligible adults with COVID-like illness and a clinical test within 10 days before to 72 days after their encounter. Adults age 18 years and up with COVID-19-like illness are included in the analyses presented today. Cases are those with a positive NAT or antigen for SARS-CoV-2 and no positive RSV or influenza test result. Controls are those with a negative NAT test for SARS-CoV-2 and no positive NAT test for influenza or RSV, depending on age. Vaccination is documented by electronic health records and state and city registries. The second platform included today is the Ivy Network, a multi-site VE platform in 26 hospitals in 20 U.S. states that, like Vision, uses a test-negative design. Unlike Vision, Ivy uses an active enrollment design with patient interviews and swabbing of enrollees. Participants were adults aged 65 and up, hospitalized with COVID-19-like illness. Cases have a SARS-CoV-2 positive NAT or antigen test, and controls were negative for SARS-CoV-2, influenza, and RSV by RT-PCR. Vaccination history is ascertained through EMRs, state and local vaccine registries, and self-report, and specimens are collected for central testing and sequencing. I'll now present results from these two VE platforms. This slide shows the patient populations included in the analyses I'll present. First, above the top, you can see each of the three analyses: Vision, emergency department and urgent care encounters in adults aged 18 years and up, Vision hospitalizations in adults ages 65 years and up, and IV hospitalizations in adults aged 65 years and up. First, you can see that the median age for emergency department urgent care encounters was lower in the mid-50s compared to the hospitalization analyses in both platforms, which had median ages in the high 70s. Keep in mind that the only analysis we'll share today that included adults aged 18 to 64 was the Vision emergency department urgent care analysis. Younger adults were excluded from the hospitalization analyses for both Vision and IV because of lack of statistical power, due to both lower baseline hospitalization rates and lower COVID-19 vaccine uptake in this age group. The Vision hospitalization analysis also includes VE for adults aged 65 years and up with immunocompromising conditions. This slide shows VE of the 24-25 COVID-19 vaccines against COVID-19 associated emergency department and urgent care encounters by age group. The top block shows VE for all adults aged 18 and up during those 7 to 119 days after the dose and split by time since dose, 7 to 59 days and 60 to 119 days. The middle block shows the same information for adults aged 18 to 64 years and adults aged 65 years and up. The first column shows COVID-19 cases. The second data column shows COVID-19 controls. The third column shows median time since the last dose among those vaccinated. And then finally, the last column and forest plots show the VE estimates. Note that among the referent group, those who did not receive a 24-25 COVID-19 vaccine, it's been almost 100 days or almost 3 years since receipt of their last COVID-19 vaccine dose for all adults. VE among all adults against COVID-19 associated ED-UC encounters was 33% for the 7 to 119 days since receipt of a dose, 36% for the 7 to 59 days, and 30% for the 60 to 119 days since receipt of a 24-25 COVID-19 vaccine dose. VE among younger and older adults was similar. This slide shows VE against COVID-19 associated hospitalization among adults aged 65 years and up without documented immunocompromising conditions in the Vision and IV networks. This slide is laid out the same as the previous slide, except instead of age groups, it shows Vision adults in the top block and IV results in the bottom block for ages 65 years and up for both platforms. VE was almost identical across the two networks, providing reassurance of the results. During the 7 to 119 days since a dose, the point estimate was 45% in Vision and 46% in IV. VE was 42% during the 7 to 59 days since a dose in both networks, and 48% in Vision and 47% in IV for the 60 to 119 days since a dose. Finally, this slide shows VE against COVID-19 associated hospitalizations among adults aged 65 years and up with immunocompromising conditions in Vision. There was not enough statistical power to estimate VE by time since dose for this group, But for the 7 to 119 days since a dose, VE was 40%, close to that in immunocompetent adults, and providing reassurance the vaccine is working in immunocompromised adults. 2024-2025 COVID-19 vaccination provided additional protection against COVID-19 associated emergency department and urgent care visits and hospitalizations compared to no 24-25 COVID-19 vaccine dose. 24-25 COVID-19 vaccination also provided additional protection against COVID-associated hospitalizations among adults aged 65 years and up with immunocompromising conditions. Finally, just a reminder that VE should be interpreted as the added benefit of 24-25 COVID-19 vaccination in a population with high levels of infection-induced immunity, vaccine-induced immunity, or both. Prior SARS-CoV-2 infection contributes protection against future disease, though protection wanes over time. An increase in SARS-CoV-2 circulation in the United States during late summer 2024, just before 24-25 COVID-19 vaccines were approved and authorized, may have resulted in higher population-level immunity against JN1 lineage strains, which could have resulted in lower measured VE than in a population with less recent infection. I'd like to thank the numerous colleagues from CDC and collaborators with the Vision and IV networks who contributed to this presentation. Thank you.
Thank you. And we're going to stop for questions. These are questions just for Dr. Havers and Dr. Link-Gellis. Any questions that came from the talks before, we'll wait till after. And my Zoom just crashed, and so I'm going to ask Dr. Wharton to see if she can pull up so I can see the names of people who have questions. All right. Dr. Asturias, please start.
Thank you, and appreciate these two presentations. And I'm very encouraged that we are focusing more on children, as I think one of the major myths that we have to debunk is that young children do not have a risk of severe disease and hospitalization from COVID-19. And I think your data show that these trends are not decreasing. So it's consistent that as we have new cohorts of unprotected infants being born every year, we probably have to adjust our current recommendation, given that they don't specify the importance of vaccinating young infants and children to avoid this morbidity and mortality. I have to point out that 70% of your hospitalizations in children are occurring in less than 4 years of age, and half of them don't have any associated medical conditions. So I know that we're going to move to a presentation where we're going to be discussing this, but I think it's so important for all of us to sort of make sure that we value children as a prime, group that needs to be protected better than what we are doing so far. So, over.
Thank you, Dr. Lair.
Thank you for this presentation. I'm always interested in how chronic kidney disease has a high risk of getting severe COVID disease. Can you comment on how they defined chronic kidney disease? Was it by creatinine clearance? Was it class 3 or class 4? Thank you.
Yeah, that's a good question. As I've mentioned, without going too much into the details of how this analysis was done, we do think that the sort of relative risk of chronic kidney disease may be slightly exaggerated in this analysis because of the way the data is collected in the behavioral risk factor surveillance system. It's based on self-report, and that could skew potentially the denominator there. So I do think there is a real increased risk of having chronic kidney disease. The magnitude of the risk compared to other underlying medical conditions may be a little bit challenging to compare. I don't know if that question makes sense, but it's based on, for the COVID-19 hospitalizations, it's based on medical chart review. If chronic kidney disease is noted in there, there's not a strict criteria. And then for BRFSS, it's based on self-reported medical conditions.
Thank you.
Dr. Camboge?
Thanks very much for the excellent presentations. I was wondering, do we have any data to show that the uptake of additional doses in immunocompromised patients has improved nationally since the last data that was shared? And the second question specifically for Dr. Gellis, slide 13. I understand the sample size was not large enough to examine time since vaccination, and it would make sense that it wasn't large enough to even look at the number of doses, but I just wanted to see if it was examined that way. Thank you.
Yeah, I think I'll defer your first question to our colleagues from Immunization Services, which should be on the line. For your second question on vaccine effectiveness, we did look at additional doses. Generally, we've seen that there's relatively low uptake within our VISION population of additional doses. And just given the timing of when the analyses were completed, there wouldn't have been too terribly many people in the population that were eligible for a second dose or subsequent doses during the analyses. It's something that we'll continue to monitor over the rest of the year, though.
Dr. Hoag?
Yeah, just a really quick comment on the fact that 90% of the children hospitalized with COVID-19 were unvaccinated is not actually really going to tell us much about the effectiveness of the vaccine, considering almost 90% of children in general are unvaccinated. I believe it's 87%. Most recently, 86% the year before, and that the same applies to adults. So it's important to adjust for the baseline rate of vaccination among the population.
Just as a comment to that, I think we were just showing the vaccination status of hospitalized children, but that slide was not intended to reflect any vaccine effectiveness. I think for those data, I would defer to Dr. Link-Ellis's approach and the data that she showed.
Yeah, sure. And we didn't include children here because of the lower baseline rates of disease, but we'll continue to monitor that over the rest of the year. And I would just add that the design of our vaccine effectiveness studies is what allows us to control for baseline coverage. So the referent group is the unvaccinated population, which gives us the number or rate or risk of disease in unvaccinated people. And then the comparison there is that rate or risk of disease in the vaccinated versus the unvaccinated populations.
Thank you. And Dr. Joseph, you have the last one before we move on.
Thank you so much. This is Naiva Joseph with the American College of Obstetricians and Gynecologists, and I appreciate the data presented today. I just wanted to highlight again, as has been mentioned by others, the high rate of hospitalization in young children, and especially, the previous CDC data has shown a really high rate of infants 6 months and younger who are ineligible for vaccine, which small studies have shown a benefit for boosting in pregnancy as a way to protect those infants who are not otherwise eligible for vaccination, and would look forward to further data that might demonstrate the effectiveness of vaccination, of maternal immunization against infant protection. Thank you. Over.
Yeah, thank you for that comment. This is Dr. Havers. I do want to emphasize in this presentation we were largely focusing on children and infants who are older than 6 months, but you are correct in that the hospitalization rates for infants less than 6 months who are protected through maternal vaccination during pregnancy are by far the highest among all the pediatric age groups. So that is a very important point that I hadn't emphasized. Thank you.
Thank you. And now we're going to move on to our work group considerations.
Hi, everyone. My name is Lakshmi Panayotopoulos. I'm one of the co-leads of the ACIP COVID-19 work group. I'll be presenting work group considerations for use of the 2025-26 COVID-19 vaccines. In this talk, I will briefly review the current recommendations for 2024-25 COVID-19 vaccines, policy options for the 2025-2026 COVID-19 vaccine recommendations, supporting data and workgroup interpretations, and pose discussion questions for the committee. As a reminder, in October 2024, ACIP voted to recommend an additional dose of 2024-25 COVID-19 vaccine for adults ages 65 years and older, and for everyone ages 6 months and older with moderate and severe immunocompromise. People who are immunocompromised are also eligible for additional doses under shared clinical decision-making. The April 2025 meeting agenda is listed and no votes are scheduled. And the proposed schedule for June 2025 includes votes on the 2025-26 COVID-19 recommendations, including additional dose recommendations for eligible groups. Now I will briefly review the 2024-25 COVID-19 vaccine policy. This is an overview of the routine COVID-19 vaccine schedule, which is straightforward for the majority of the population. As a reminder, children ages 6 months to 4 years who are unvaccinated should receive a multi-dose initial series with the 2024-25 COVID-19 mRNA vaccine. Those who have previously completed an initial series should receive 1 dose of a 2024-25 mRNA vaccine from the same manufacturer as the initial series. People ages 5 to 64 years should receive 1 age-appropriate dose of the 2024-25 COVID-19 vaccine, and people ages 65 years and older should receive 2 doses of any 24-25 COVID-19 vaccine spaced 6 months apart. People who are moderately or severely immunocompromised and unvaccinated should receive a multi-dose initial vaccination series with an age-appropriate 2024-25 vaccine and receive 1 dose 6 months after completing the initial series. Those who have previously completed an initial series should receive 2 doses of an age-appropriate 24-25 COVID-19 vaccine spaced 6 months apart, and they may receive additional doses under shared clinical decision-making. Now we will discuss policy considerations for the 2025-26 COVID-19 vaccine. When considering the policy options for the 25-26 COVID-19 vaccine, one important consideration is whether to maintain the current multi-dose initial series for people ages 6 months to 4 years and people with immunocompromise. Another consideration is whether to maintain the universal recommendation for everyone ages 6 months and older or move to a risk-based recommendation. A third option is a combination of a risk-based and universal vaccine recommendation. An example of this is a risk-based recommendation for people ages 6 months to 64 years and a universal recommendation for people ages 65 years and older. There are also considerations for groups who are currently recommended to get more than 1 dose a year. Most people ages 65 years and older are recommended for 2 doses a year. Some may need more, specifically those that are previously unvaccinated and receiving Novavax or are immunocompromised. And people ages 6 months and older who are moderately or severely immunocompromised are recommended to get an initial series followed by 2 doses a year and may receive additional doses. If a risk-based recommendation is to be considered for 2025-26, defining who is at risk could be complex. How much increased risk is sufficient for a recommendation? There are certain groups at increased risk of severe outcomes based on age, underlying conditions, and pregnancy status, and groups at increased risk of exposure, including healthcare workers and people living in long-term care facilities and other congregate settings. The CDC's current list of conditions that conclusively increase the risk of severe COVID-19 is extensive and predominantly based on pre-Omicron data. The list of conditions brings up the question, how much of the population has one of these conditions? An analysis of U.S. adults with conditions that put them at higher risk of severe illness due to COVID-19 was carried out using medical claims data, consumer data, the Behavioral Risk Factor Surveillance System, and the National Health Interview Survey to enumerate the U.S. population with conditions that put them at increased risk of severe illness from COVID-19 using multi-level regression modeling. Notably, the conditions highlighted by the red boxes were not included in the analysis. The analysis showed that the population of U.S. adults with at least one condition that puts them at higher risk of severe illness from COVID-19 generally increases with age. Approximately 74% of all U.S. adults 18 and older had at least one condition. And as a reminder, this analysis did not include people with Parkinson's disease, physical inactivity, and steroid use or other immunosuppressive medications, which is expected to lead to larger percentages across all age groups. Now I will present a summary of supporting evidence that has been presented to the work group. We will start with a review of current COVID-19 epidemiology. This slide shows the current weighted and model-based projected nowcast estimates for SARS-CoV-2 circulation in the United States, showing that the XEC and LP.8.1 strains from the JN1 lineage are predominant. Weekly rates of COVID-19 hospitalizations peaked in January and appear to be decreasing. Looking more closely at pediatric hospitalizations, we see that children ages 0 to 17 during the fall and winter of 2024-25, rates of RSV and influenza hospitalizations represented by the solid purple and blue lines were higher than the rates of COVID-19 hospitalizations represented by the solid magenta line. Additionally, the rates of COVID-19 associated hospitalizations this winter were lower than they were during the corresponding months in 2023 to 2024, seen in the dotted magenta line. COVID-19 associated deaths are also decreasing and remain lower this winter than they were in late summer and fall of 2024. When looking at the leading causes of death among children 0 to 17 years old, COVID-19 has decreased from number 8 in 2021 and 2022 to number 12 in 2023. When looking at the leading causes of death among adults, COVID-19 has decreased from number 3 in 2021 to number 4 in 2022 and number 10 in 2023. This graph shows the total number of COVID-19 deaths between September 23 and August 2024 by age group. The majority of deaths occur in adults ages 65 years and older. This graph shows the number of COVID-19 and influenza deaths among people ages 0 to 17 years between September 2023 and August 2024. For children less than 1, the number of deaths from COVID-19 were higher than the number of deaths from flu. However, for children ages 1 to 17, there were more deaths from influenza than from COVID-19. Looking at trends from the 2023 to 2024 year to the 2024-2025, there was no difference in vaccine recommendations, and there was similar vaccination coverage for children and adults. Vaccine coverage in people ages 65 years and older increased, while vaccine effectiveness in adults 18 and older was similar. And finally, cumulative hospitalization rates decreased overall. This slide shows the most recent data available on seroprevalence among children from September 2021 through the end of 2022 based on blood collected by commercial laboratories. A large increase was seen with the emergence of Omicron starting in December 2021, with smaller increases seen by the end of 2022. By the end of 2022, approximately 90% of children aged 2 and above, 82% of children aged 1 to 2, and 64% of infants less than 1 year old have been infected. To evaluate population immunity, a study looked at spike antibody levels in a nationwide cohort of over 100,000 blood donors ages 16 years and older. The study showed that a higher number of cumulative SARS-CoV-2 infections and COVID-19 vaccinations lead to higher antibody levels, but with smaller incremental increases in antibodies with each exposure, especially after 4 cumulative events, as shown in the graph. Now I will discuss long COVID, which remains a significant public health threat. National surveys in 2023 estimated approximately 9.2 million adults and 0.3 million children in the U.S. had long COVID. Among adults, 3.6% reported long COVID symptoms, and 8.4% reported ever having long COVID. Among children, 0.4% reported long COVID symptoms, and 1.4% reported ever having long COVID. COVID-19 mRNA vaccination is associated with a reduced risk of long COVID following COVID-19. Among children 5 to 17 years, completion of the primary vaccine series prior to infection was associated with a reduced likelihood of long COVID symptoms by 57% for one or more symptoms, 73% for two or more symptoms, and 72% for respiratory symptoms. Among adults, 3 doses of the original monovalent vaccine prior to infection was associated with a reduced likelihood of long COVID symptoms by 63% for GI symptoms, 44% for neurologic symptoms, and 52% for other nonspecific symptoms. Here we show estimates of multisystem inflammatory syndrome in children, or MISC incidence per 1 million person years, done using population estimates from U.S. Census data. You can see that the incidence per 1 million person years was 6.8 in the pre-Delta period and had decreased to 0.08 in 2024. You can also see there was a brief shift in MISC cases to younger children in 2022 and has since increased back up to 9 years old in 2024. Similar decreases in MISC incidence and a transient shift to younger age groups in 2022 were observed in other countries as well, including England, Australia, and Israel. This table shows COVID-19 vaccination status for children with MISC in 2023 and 2024. Although 95% of children with MISC in 2023 and 99% in 2024 were eligible to receive a COVID-19 vaccine prior to their illness, only 19% in 2023 and 26% in 2024 received any vaccine dose. Of these vaccinated children, 65% in 2023 and all in 2024 received their last vaccine dose greater than 12 months prior to their MISC. Now I will present data on COVID-19 vaccine and myocarditis. As a reminder, all 3 COVID-19 vaccine brands have warnings and precautions about myocarditis and pericarditis. This graph shows data from the Vaccine Safety Data Link to illustrate the trend in the observed rate of myocarditis following mRNA COVID-19 vaccination from 2020 through 2025. A statistically significant increased risk of myocarditis was observed with the original monovalent vaccine, primary series, and booster doses. There was no increased risk observed with the doses administered in subsequent years. This table shows details of VSD's vaccinated concurrent comparator analysis for the 2024-2025 vaccine. The incidence of myocarditis and pericarditis in the post-vaccination risk interval is not different than the incidence in the comparison group, and the VSD has not detected a statistical signal for myocarditis and pericarditis following the 2024-25 COVID-19 vaccine to date. The Vaccine Adverse Event Reporting System also continues to monitor reports of myocarditis after COVID-19 vaccines. Among people ages 12 to 39 years, there have been 4 verified cases reported with the 24-25 vaccine. The reporting rates are similar to the expected background rates of less than 2 cases per million doses. Now, some of the clinical aspects of myocarditis following COVID-19 vaccine. The MOVING study assessed cardiologists and healthcare provider assessments of recovery in 385 persons ages 12 to 29 years old in the 90 days following myocarditis after COVID-19 vaccine, and found that 81% of patients were considered fully or probably recovered. In the same study, 50% of patients self-reported at least one lingering symptom at 3 months. A large study comparing post-COVID-19 vaccine myocarditis to post-COVID-19 myocarditis and conventional myocarditis found that the complications with post-vaccine myocarditis were lower than in the other 2 categories. To summarize the myocarditis data, an increased risk of myocarditis following COVID-19 vaccines was observed during 2020 to 2022 following the primary series and first booster doses. No increased risk was observed in the VSD and VAERS with the 2022-23 and 2023-24 vaccine or the 2024-25 vaccine to date. The acute clinical picture following myocarditis after COVID-19 vaccine tends to resolve quickly, and post-COVID-19 vaccine myocarditis associated with less severe cardiovascular events than post-COVID-19 myocarditis and conventional myocarditis. Now I will discuss data on risk-based versus universal vaccine recommendations and how this may impact vaccine coverage. The work group raised concerns about moving to a risk-based only vaccine recommendation and how this would impact COVID-19 vaccination coverage among people with high-risk conditions. Because influenza vaccine was initially recommended for people with high-risk conditions and moved to a universal recommendation in 2010, it was used as an example of what could potentially happen to coverage among people with high-risk conditions if COVID-19 vaccine recommendations were to be risk-based. For influenza vaccine, coverage among 18 to 49-year-olds with high-risk conditions increased approximately 2 percentage points between 2008 to 2009 and 2010 to 2011, but plateaued thereafter. No significant changes were seen among people with high-risk conditions when vaccine recommendations targeted people with high-risk conditions only compared to a universal vaccine policy. The work group also considered other vaccines that may provide information on how a universal versus risk-based recommendation could impact vaccine coverage. Hepatitis B vaccine coverage among adults with risk factors remained below pre-pandemic coverage after moving from a risk-based to a universal recommendation in 2022. And a comparison was also made between zoster vaccine, which is universal for ages 50 and older, and pneumococcal vaccine, which was previously recommended for risk groups among the same ages. Vaccine coverage among adults universally recommended for zoster vaccine was approaching pneumococcal vaccine coverage among high-risk adults by 2023, despite a long-standing pneumococcal vaccination recommendation for high-risk adults. It's unclear how a change from universal to risk-based recommendations may impact COVID-19 vaccine coverage among people with risk conditions. So now I will go through some parental vaccine confidence data. Among children ages 6 months to 17 years, vaccination rates are approximately 12% this year, which is similar to last year. And given the low vaccination coverage among children, the work group reviewed data on parental vaccine confidence to understand barriers to vaccine uptake in children. Survey data showed that only 22% of parents of children 0 to 17 years old were asked, when asked what actions they would take to prevent their child from getting a respiratory illness, said they were very likely to get their child vaccinated for COVID, which was lower than the other options presented to prevent respiratory illnesses. Out of the parents whose children previously received 1 dose of COVID-19 vaccine, most reported the same amount of confidence in safety and effectiveness to when vaccines first came out. However, 15% of these parents reported less confidence. Among parents of children whose children have never received a COVID-19 vaccine, approximately 45% reported less confidence in vaccine safety and vaccine effectiveness compared to when the vaccines first came out. Parents of children who have never had any COVID-19 vaccine were more likely to have gotten, parents of children who have had any COVID-19 vaccine were more likely to have gotten or are planning to get the 2024-25 COVID-19 vaccine for their children compared to parents of children who have never been vaccinated against COVID-19. And finally, when comparing reasons for not getting vaccinated for COVID-19 by prior vaccination history, parents of children who were never vaccinated were more likely to report concerns about safety, effectiveness, and having a bad reaction. Of note, 15% of parents of children who have had a prior vaccine dose reported that their children has received enough doses of COVID-19 vaccine. Now I will briefly review COVID-19 vaccination recommendations from other countries. Regarding booster recommendations or doses for people who have already completed an initial series, most countries have recommendations for older adults to get vaccines every 6 to 12 months. The age cutoff for these recommendations range from 50 years to 80 years old. For otherwise healthy adults, the United States is the only country with a routine recommendation. Other countries vary on whether they have no recommendation, a discretionary recommendations, or recommendations specific to pregnancy status. For high-risk adults, most countries have a routine recommendation for a yearly vaccine. However, in Australia, this population has a discretionary recommendation. For immunocompromised adults, most countries have a recommendation to get the vaccine every 6 to 12 months. The US is the only country that allows additional doses beyond a twice-a-year recommendation. Besides the United States, most countries do not recommend routine vaccination of children. Canada allows for healthy children to receive a vaccine every 12 months. For high-risk children, the UK, Canada, and US recommend the vaccine every 12 months, while Australia and the WHO do not. For immunocompromised children, most countries recommend vaccination every 6 months. However, Australia does not recommend vaccination for children less than 5 years of age. And in Australia, children ages 5 to 17 with immunocompromising conditions may get the vaccine yearly. Now I will discuss workgroup interpretations of the data. When initially presented with the 25-26 COVID-19 vaccine policy options in November 2024, the workgroup appreciated pros and cons of both a risk-based and universal vaccine recommendation. There was not yet consensus at the time on what the recommendation should be, and the workgroup did request additional information to help inform the decision-making process on risk factors for severe COVID-19, transmission and immunity, vaccine implementation and access, and cost effectiveness. Based on the information presented to the workgroup as of February 13, 2025, which included data on risk factors for hospitalization, trends in mortality, risk-based versus universal vaccine coverage, vaccine hesitancy, and COVID-19 and myocarditis, the majority of the workgroup supported a risk-based recommendation for 25-26 COVID-19 vaccination. Among workgroup members who selected a non-universal policy recommendation, almost all supported a risk-based recommendation by conditions and exposures, a universal recommendation for certain age groups, as well as permissive language to allow anyone who wanted protection from COVID-19 vaccine to get a vaccine. Following this poll, additional data on vaccine effectiveness, seroprevalence, long COVID, vaccine coverage, and MIS-C were presented to the workgroup, and the workgroup also received feedback on the recommendations from liaison organizations. Between March and April 2025, the AAFP, AAP, AIM, ACP, APHA, and ACOG provided feedback on moving to a potential risk-based COVID-19 vaccine recommendation. Concerns were raised regarding implementation, communication, confidence in the recommendation, and equitable access to vaccination with a potential risk-based recommendation. The workgroup was re-polled on April 3rd, and the majority of the workgroup still supported a risk-based recommendation for 2025-2026 COVID-19 vaccination. Among workgroup members who selected a non-universal policy recommendation for everyone, on April 3rd, almost all supported a risk-based recommendation by condition or exposure, a universal recommendation for some age groups, as well as permissive language to allow anyone wanting protection from COVID-19 vaccination to receive one. And this slide is a quick reminder from Dr. Havers' presentation on risk conditions in adults. We saw that some underlying medical conditions increase the risk of COVID-19 hospitalization for adults of all age groups, including chronic kidney disease, diabetes, and coronary artery disease, while some conditions such as asthma, history of stroke, COPD, severe obesity, and current smoking increase the risk among adults in some age groups. Having none of the underlying medical conditions examined decrease the risk of COVID-19 associated hospitalizations among all adult age groups. And finally, these are the questions we'd like to pose to the committee today. As far as general thoughts on universal versus risk-based recommendations for COVID-19 vaccination, are there groups that clearly should not be recommended for vaccination with the 2025-26 COVID-19 vaccine? What data would be helpful in your decision-making? Is it still helpful to have a risk-based recommendation if most of the population is considered at risk based on the current risk criteria? Should people at higher risk of infection and transmission, such as healthcare workers, be included in a risk-based recommendation? Will stable universal recommendations increase uptake with time? Are there concerns about implementation challenges with risk-based recommendations? Are there any potential unintended implications or consequences of a recommendation change? And are there key decision points that we have not captured here? So thank you to everyone who contributed to this presentation, especially my co-lead, Lauren Roper. And now we can go back to the previous slide to get some thoughts from the committee. Thank you.
Thank you. And Dr. Jameson was on the button. Dr. Jameson.
Thank you so much. Thanks for your excellent presentation. I guess with the very high proportion of adults with risk factors that you mentioned, 74%, and COVID, although it's dropped, is still a leading cause of death among both adults and children. I guess I'm surprised that we're considering a risk-based recommendation, which in general we have not had a lot of success with implementing in the US. The other thing is you mentioned hepatitis B as an example where universal recommendation did not increase, but to me it's not really a relevant comparison. A relevant comparison is flu, and to decouple flu and COVID, people are just starting to understand the importance of getting their COVID and flu vaccine every year. I worry about implementation. I also worry about the feasibility of a permissive recommendation. Given healthcare financing, it may be very difficult for people to find a way to get the vaccine paid for if it's permissive. So I would, at this point, with the information presented, I would be in favor of a universal rather than a risk-based recommendation. Thank you.
Thank you, Dr. Asturias. Oh, wait, did I skip?
Dr. Laurie was before. So.
Dr. Lair.
No worries. Thank you so much for this presentation. I'm very happy that we're seriously considering a risk-based recommendation. I'm glad that we're taking this as a reasonable possibility. If you could go to around slide 14, this is the most of the population considered at risk. You have the 18 to 50-year-olds in the 60% range for the people at risk, and this just does not compute with my experience with 18 to 50-year-olds. If you go back one slide here, I don't have 60+% of 18 to 50-year-olds with any of these diagnoses, and so that just seems incredibly high. I could buy maybe 50-year-olds, definitely the elderly, but I don't think that's accurate for probably ages 5 through 50. I also, even though I'm very much in favor of considering a risk base, I am concerned about the feasibility of it and the message it might be sending. COVID is still a fairly dangerous disease and very, very common. We're not talking about 10 cases of Mpox. We're talking about thousands of hospitalizations and deaths. And so even though I'm in favor of a risk base, I still have my hesitations. So thank you very much.
Dr. Asturias.
Thank you. And a wonderful presentation. And I'm just going to concentrate on what data will be helpful. I think, given that I'm very much concentrating in the young infants and children who I think we have not taken care as we should to protect them against COVID, data on the current transfer of maternal antibody will be useful. I think most of the data that we have comes from the previous years where basically we were trying to understand if that was offering of protection, but if there was any possibility of getting current data, given that most women now have been either infected or vaccinated, will be interesting. And then more granular data on the hospitalization of children in the first year of life, especially, why are these kids getting hospitalized? I think some of our data from influenza shows that they get hospitalized mainly for fever and irritability. And even though some of them end up in the ICU, it will be interesting to sort of see what the causes of hospitalizations are. So, over. Thank you.
Dr. Brooks.
Yes, first I think it'd be helpful to go back to the slide. As Dr. Sturris referenced, that's what we're looking for, more data. I think that was that last slide, 68, something like that. No, not that one, all the way back to the end. And what I would want to see is modeling around long COVID. I mean, it was shown that there's about a 3% prevalence incidence of 8%. The slide where you were asking for questions, so I think I want to say the last slide. And even though, let's say, the rate of COVID among, let's say, a healthy 30-year-old is low, if they have the potential to get long COVID, which again was lower numbers, but still the absolute numbers may be high versus the percentages. I am concerned about that. My primary concern through all of this at this point now is still long COVID. So what I would like to see is some modeling regarding the absolute numbers of long COVID related to the lower age groups may not receive a recommendation to get vaccinated.
Dr. Brewer?
We received some feedback just in one of the questions that there's a concern about implementation with a risk-based approach. This committee, and I can't remember if it's in the work group or if this general committee, has seen data that show that, well, I mean, maybe it doesn't show, but there's not clear evidence at all that risk-based approaches are less effective. It's certainly something we've all talked about and something that some of the companies have shared for many years, but the data supporting that claim are not really there. And so I used to believe that risk-based approaches were problematic, but based on the data that I saw, I don't know that I can support that conclusion. It may be true from our best guess, but it's not an evidence-based conclusion.
Thank you. Ms. Moser.
Thank you. I have two points. One related to the question at hand, which is that I am in support of the risk-based idea. I'm glad we're exploring that. I do think when we think about which groups and age was mentioned, that we should, I agree with Dr. Asturias, make sure that we're keeping the youngest of children on our radar, because they represent a new group of large group of susceptibles to this virus every year. And if we can vaccinate those kids, we may decrease that under 1-year-old hospitalization rate. And we may also protect them against long COVID on their first exposure to the virus, albeit those data aren't as strong. And I think it's that vaccinating those kids in the younger time period also gets us away from the concerns that we had about vaccinating adolescents around myocarditis. So those are my comments on this slide. While we're on the COVID topic, I did want to acknowledge the many members of the public who took time to submit comments for this week's meeting. And in particular, there were a significant number of comments that people submitted regarding the change in licensure status for Novavax that was anticipated to occur a few weeks ago. And since I know that's not something that our committee has on its plate, but it's something that the FDA does, I wondered if, and there are no, as far as I saw on the agenda, no ex officio reports this week. So if I missed that, I apologize. But I was wondering if, while we're talking about COVID, maybe our FDA liaison would be able to offer an update for the members of the listening public who have questions about what's happening with Novavax.
Dr. Hogue, do you have a moment?
Yes, that is a good question. I actually I don't know to what extent I'm allowed to give an update on that, but there will be an update coming out publicly very soon.
Great, and Dr. Freihofer, don't go anywhere. I have one quick question also for Dr. Hogue. We get lots and lots of comments regularly about why have we not approved or why do we not recommend Novartis for kids less than 12? No, Novartis. Novavax. Oh, never mind. I've just been corrected. We're going to Dr. Freihofer.
Sandra Freihofer, the American Medical Association. Speaking as a practicing physician, I see patients in the office every day. I'm an internal medicine physician, so a lot of my patients are older and fragile. As a new grandmother, I also worry about the very young. And I go back to that slide that you showed that 74% of patients have at least one risk factor. And then I go to what it's like to be in practice. And you might have heard the expression KISS, KISS, keep it simple. I'll let you figure out what you want the second S to be. But the reality is most of these vaccines, certainly for adults, are being given in pharmacies. The risk-based recommendations are more difficult for pharmacists because patients have to self-declare their illnesses, or the pharmacists have to check their medication list. And patients may not feel comfortable with that. So I am on the COVID vaccine work group, and I was one of the 19% that did suggest a universal recommendation, and that is why.
Thank you. Dr. Lair.
Thank you. I'd like to comment on Dr. Brewer's comment. In the pneumococcal work group, we've been showing data that it's pretty clear that the risk-based recommendation for 50 to 65 was actually only about 20% of uptake, whereas the age-based recommendation for 65 and over was about 65% uptake. So for me, that does suggest that a risk-based recommendation actually does not have as much uptake as a universal recommendation or age-based. It still doesn't mean that I don't agree with the risk-based, but I did want to at least put that comment out there. Thank you.
Any other questions? Fantastic. Okay, we will come back at 1:30. Oh, sorry, we didn't do pneumococcus. I'm going to get some caffeine at the next break. Can we go back and let's go back. Don't run away, y'all. We're going to talk about the pneumococcal vaccine. And Dr. Kobayashi, could you...
Before we do that, do you want to see if there's any residual questions from the earlier discussion?
Oh, yes. Actually, Dr. Wharton also reminded me, were there any residual questions left over from the original conversation about the Moderna mRNA? Oh, wow. Dr. Cambodge.
Thanks very much, Dr. Talbot. Dr. Rescala, could you comment on if there were any comparisons on T-cell responses between 1273 and 1283? Thank you.
Thank you for your question. Just making sure you can hear me okay.
Can't hear him.
Yep. Okay. Excellent.
Yeah.
Testing if you can hear okay.
Perfectly.
Okay, excellent. Thank you. So thank you for the question. So we have looked at T-cell responses following in our phase 2 study. We looked at mRNA 1283 at the dose that was tested in the phase 3, and also compared that to the T-cell responses for 1273 or Spikevax. We showed comparable responses between mRNA 1283 and Spikevax in terms of CD4 and CD8 responses that persisted for the duration of the study, which was 366 days. So comparable responses.
Wonderful. Thank you.
Thank you, Dr. Schechter.
Thank you. I had a question around the seeing the age risk groups in the last presentation for myocarditis risk. And on slide 6 of the of the presentation, I think there was age breakdown for adolescents and then 18 to 64. I'm just wondering if not now, over the next days, could get a breakdown of sort of the 18 to 30 or 18 to 40 sample size in terms of the population that might have been at higher risk for myocarditis in the trial. Thank you.
Okay. So there have been no cases of myocarditis or pericarditis observed throughout the program, but we'll be happy to come back to the work group and share a breakdown of the demographics in that 18 plus population.
Thank you.
Thank you. Dr. Kurilla. Dr. Kurilla, we can't hear you. Dr. Kurilla, I'm going to go to Dr. Hogue, and then hopefully we can come back and you'll be able to hear you.
Yes, thank you. So this is a question about the Moderna study for Mr. Rizkallah. My question is, I was interested that this was a non-inferiority study and wondering how you were able to determine the efficacy of the Spikevax vaccine, which you were comparing mRNA 1283 to at the time of the study, considering the amount of underlying population immunity prior infection, if you were relying on real world data, which tends to be biased by healthy vaccine A bias, or just neutralizing antibodies, which have not been clinically validated in people with prior infection. I'm just curious how you got your efficacy versus of Spikevax versus like hospitalization, COVID death, and long COVID, or if you were able to estimate that.
So the phase 3 study was comparing the relative vaccine efficacy between the two arms,
right, yeah.
Based on CDC-defined COVID-19.
So I guess my question is, how do you know if the Spikevax vaccine is effective and how effective it is if you're doing a non-inferiority study? Like, how can we determine what the new the mRNA 1283 efficacy is if we don't know the efficacy of what you're comparing it to?
Yes, hi, this is Darren Edwards. I'm the program lead for our COVID vaccines. So each season, as we update our strain composition for our Spikevax product, we do measure vaccine effectiveness over the course of that season. So we have established and continue to establish the vaccine effectiveness profile each season for each variant composition, including the one that was included in this trial.
Thank you very much. Dr. Kurilla? Okay, we're gonna have to try again later. Hopefully we get your question answered. All right, we're going to move to the pneumococcal vaccine discussion. And Dr. Kobayashi, I believe it's actually your turn this time.
Okay. Thank you very much, and good afternoon. On behalf of the pneumococcal vaccines work group, I will present our proposed work plan and next steps. Okay, first, I'd like to introduce our current work group members, led by Dr. Jamie Lear, who has been serving as the chair. Additionally, ACIP voting members on our work group include Dr. Minnie Kamboj, Dr. George Kuchel, and Dr. Robert Schechter. We have also the following ex officio members, liaison representatives, and consultants, and I would like to thank all the work group members for their valuable contributions and dedication. And here are the CDC contributors who support the work group activities. The pneumococcal work group's terms of reference are to review evidence to inform the use of new pneumococcal conjugate vaccines in U.S. adults and children. In the past 40 years, there have been multiple updates to the U.S. pneumococcal vaccine program, especially within the past 5 years. during which 3 new pneumococcal vaccines were licensed for use. The most recently licensed vaccine was the 21-valent pneumococcal conjugate vaccine, or PCV21, for adults, which was last year. However, the work group acknowledges that there are gaps in current pneumococcal vaccine recommendations. One such gap concerns pregnant women. This table from the adult immunization schedule shows that there is currently no guidance for use of pneumococcal vaccines in pregnant women who have underlying conditions or risk factors that increase the risk of pneumococcal disease. Additionally, ACIP has never specifically voted on pneumococcal vaccine use among hematopoietic stem cell transplant recipients. The clinical guidance for pneumococcal vaccine use was last updated in 2023 after PCV15 and PCV20 were licensed. Currently, there's no guidance regarding PCV21 use in this population. Since a formal review of literature regarding pneumococcal vaccine use in pregnant women and hematopoietic stem cell transplant recipients has not been presented to ACIP, we have been conducting such a review. And we plan to present a summary of our findings and propose language for updated clinical guidance for the committee's review and feedback at the June 2025 ACIP meeting. Thank you. That is the end of my update.
Fantastic. Okay. Just a second. Okay. So 2 o'clock. All right. So we're going to have a nice long break till 2 o'clock. I'm going to go get some more caffeine, and I'm looking forward to seeing everyone at 2 o'clock. Welcome back, everyone. It is 2 o'clock, and we will be moving on to HPV vaccines. And I believe Dr. Oliver Brooks is going to get us started.
Yes, thank you very much, Dr. Talbot. Let's see, next slide. All right, good morning to a few, good afternoon to most. So HPV vaccines, so this is the work group intro, and we will have discussion and presentations after this. So HPV vaccine is a critical public health tool, just looking at the bird's eye view, the overall perspective. HPV can cause and does cause cancer of the cervix, vagina, vulva, penis, anus, and oropharynx. HPV vaccine provides lasting protection against the HPV types that most commonly cause cancer. In the 19 years since HPV vaccine licensure, we have seen high vaccine efficacy in clinical trials, high population impact in real-world settings, strong herd effects of vaccination programs. Next slide. So in terms of a little background regarding the work group, an HPV vaccine work group met previously for many years, but had been inactive since 2019. HPV vaccine work group was reformed and meeting monthly since July of last year. The first presentation of the new HPV work group to ACIP was the last meeting, which was October of 2024. Next slide. So let's look at the current HPV vaccination recommendations. So these are the current recommendations in the US, which include routine, catch-up, and shared clinical decision-making recommendations. Routine vaccination is recommended at age 11 or 12 and can be started at age 9. Catch-up vaccination is recommended through age 26 years. Shared clinical decision-making is recommended regarding vaccination for persons 27 to 45 years of age. Click, please. So the number of doses recommended depends on the age the series was initiated, with 2 doses recommended for those starting the series before the 15th birthday, and 3 doses recommended for those starting on or after the 15th birthday, or for those with immune compromising conditions. Next slide. So our work group is examining 2 policy issues. The first is the wording of the age for routine HPV vaccination. Some of our stakeholders are interested in starting vaccination at age 9 years, which is consistent with the current ACIP recommendations. However, modification of the wording to HPV vaccination is routinely recommended at age 9 to 12 years could allow more flexibility. Next slide. So the second policy issue we are examining is the number of doses in the recommended HPV vaccination series. There's been accumulating evidence on the efficacy of HPV vaccination with fewer doses. Our work group is reviewing data on 2 doses for persons aged 15 years and older, and data on 1 dose for persons 9 years and older. Next slide. So in 2022, the WHO, World Health Organization, recommended a 2-dose schedule for ages 9 and older, with an option for a 1-dose schedule in girls and boys, both genders, aged 9 to 20 years. Although it was expected that low to middle income countries would be the first to adopt a 1-dose schedule, some of the first countries that changed to a routine 1-dose schedule were the UK and Australia. Other countries that considered the data did not change to a 1-dose schedule, but changed from a 3-dose to a 2-dose schedule for persons older than 14 years, including the Netherlands and Sweden. Recommendations for 1 dose were made by some regional immunization technical advisory groups, including PAHO, which is the Pan American Health Organization, and AFRO, the WHO African region. in 2024. As of now, as of April 2025, in some age groups, 67 countries have adopted 1-dose and 77 countries have adopted 2-dose HPV vaccination schedules. At the October ACIP meeting, we presented an intro to reduced number of HPV vaccine doses during a summary of evidence on 1-dose vaccination, an introduction to the wording of the age for routine HPV vaccination, including the interest in vaccination at age 9 years, and a systematic review and narrative summary of literature about HPV vaccination at ages 9 to 10 years to increase coverage. Next slide. So we have 6 presentations today to provide the first, a reduced number of doses for HPV vaccination from Dr. Carla De Silva, then the Kenshi trial, very important data in terms of this determination, by Dr. Ruan Barnabas. HPV vaccination covers by Cassandra Pingali, modeling of reduced number of doses for HPV vaccination by Dr. Jane Kim, a modified ETR, wording for age of routine HPV vaccination from Dr. Ruth Stefanos, and next step and work group considerations by Dr. Lori Markowitz. Next slide. So I'd like to acknowledge those in the work group, the voting members as noted here, and especially the co-leads, Dr. Carla DeSisto and Lori Markowitz, who have really shown leadership and hard work in pulling the data together. Also the liaison members, the ex officio members, and the consultant members. And then lastly, the work group CDC staff, which are listed here. So at this point, I'd like to turn it back over to Carla DeSisto for the first presentation, the reduced number of doses for HPV vaccination. Thank you.
Good afternoon. My name is Carla DeSisto, and I serve as co-lead for the HPV Vaccines Work Group. Today, I will share our work group's PICO and outcomes, provide a brief introduction to our systematic review, share updated data from studies of interest, briefly describe some issues related to observational studies of vaccine effectiveness, and review the outstanding questions for reduced number of HPV vaccine doses. I'll begin with our PICO and outcomes. Our work group has decided on 2 policy questions. The first policy question is, should 1 dose of HPV vaccine be used for prevention of HPV infection and HPV attributable disease instead of the currently recommended vaccination schedule? You'll notice that there are 2 populations in comparisons for this question. For persons aged 9 to 14 years, we are examining 1 dose of HPV vaccine versus the currently recommended 2 doses in this age group. For persons aged 15 and older, we are examining 1 dose of HPV vaccine versus the currently recommended 3 doses. Our second policy question is, should 2 doses of HPV vaccine be used for prevention of HPV infection and HPV attributable disease instead of the currently recommended vaccination schedule? In this instance, we are examining 2 doses of HPV vaccine versus the currently recommended 3 doses for persons aged 15 and older. Of note, we will also review data on 1 versus 2 doses in persons aged 15 and older, but we're focusing our PICOs on comparing to current recommendations. The upper age of the population is going to be discussed by the work group after we finish reviewing the data. We are not intending to change the recommendation of shared clinical decision-making for persons aged 27 to 45 years, although the number of recommended doses in this age group may change. We are also not planning to make any changes to the recommendation that persons with immunocompromising conditions receive 3 doses of HPV vaccine. This is a list of our outcomes and the level of importance the work group agreed upon. These apply to both policy questions. We have 4 critical outcomes: HPV-associated cancers, precancers, serious adverse events related to vaccination, and incident persistent HPV infection. We also have 6 important outcomes: prevalent HPV infection, incident HPV infection, immunogenicity, anogenital warts, low-grade histological abnormalities, and recurrent respiratory papillomatosis. I'll now provide a brief introduction to the systematic review our work group has conducted. Cochrane reviewed the literature on HPV vaccination schedules with reduced number of doses in 2022 for WHO. 73 publications on 59 studies were included in the review. 49 studies were later excluded due to serious risk of bias. All of the excluded studies were observational studies. We are starting with Cochrane's review, but putting it into US context by only including studies of vaccines that are licensed in the US, which are the bivalent vaccine, quadrivalent vaccine, and 9-valent vaccine, although we only currently use the 9-valent vaccine. We are including 18 publications from Cochrane's systematic review. We've conducted 2 updated literature searches covering January 2022 through December 6th of 2024. Our librarians searched 4 very large databases for RCTs and observational studies capable of providing data on the efficacy, effectiveness, or immunogenicity of reduced number of HPV vaccine doses. After screening 6,700 abstracts, we ended up with 22 additional publications in our review. However, we excluded 3 from non-randomized studies at serious risk of bias, which brought our number of total publications included to 37. Those 37 publications represent a total of 16 studies contributing data to our systematic review. On this slide, the studies are listed in alphabetical order, and we can see the study design, the population at the time of vaccination, and which vaccine was studied. You'll notice in the 3rd column that 13 of the 16 include only females. The majority of these studies only include 1 publication. However, some studies, like the Costa Rica vaccine trial and the IARC India trial, have resulted in numerous publications. This table summarizes the data available for each of our 4 critical outcomes listed in the 1st column. The 2nd column shows the total number of studies with data on each outcome. The remaining columns show the study designs. We list which study contributes data to each outcome by study design, and the time since vaccination is found in parentheses. I'd like to draw your attention to the bottom row of the table. Our only harm of interest was serious adverse events related to vaccination. Favorable safety profiles for HPV vaccines have been well established. There is no evidence that adverse events increase with fewer doses, and we are summarizing these data in a narrative review. This table summarizes the data available for each of the 6 important outcomes. It's organized the same way as the previous slide. You'll notice here that we have data from 11 studies on immunogenicity. This is the outcome for which we have far and away the most data available. I'd like to draw your attention to the final row of the table. At this time, we do not have any data on recurrent respiratory papillomatosis by number of HPV vaccine doses. I just listed the universe of studies included in our systematic review, but now I'll share some updated data from a few of these studies which are of particular interest. At the October ACIP meeting, Dr. Markowitz presented this slide, which summarizes the 4 trials that were part of the evidence considered by WHO when they made their recommendation for a 2-dose schedule for ages 9 and older, and an option for a single-dose schedule in girls and boys aged 9 to 20 years. Today, I will share recently published updates from the Costa Rica vaccine trial, or CVT, IARC India, and DORIS. After my presentation, we are privileged to have Dr. Ruan Barnabas share an update from the Kenshi trial. I'll begin with the Costa Rica vaccine trial. Women aged 18 to 25 years were randomly assigned to receive 3 doses of bivalent HPV vaccine or hepatitis A vaccine. Some women did not receive all 3 doses due to pregnancy, colposcopy referral, a medical condition, participant refusal, or missing a study visit. Reasons for receiving fewer doses were balanced within each dosage group between women receiving the HPV and control vaccines. Therefore, data are being evaluated as a cohort study of women who received 1, 2, or 3 doses. At the October meeting, we reviewed data on protection against prevalent infection and immunogenicity through 11 years. In their November 2024 publication, the authors found that 16 years after vaccination, HPV 16/18 seropositivity was very high at greater than 98% in the 3-dose and 1-dose groups. As you can see in the figure, antibody levels are lower in the 1-dose group, which is in blue, compared to the 3-dose group, which is in red, and this is expected. During years 11 to 16 after vaccination, small but statistically significant declines in antibodies were observed in women who received 1 dose and 3 doses. Next, we'll look at the IARC India trial. Unmarried girls aged 10 to 18 years were randomly assigned to receive either 2 or 3 doses of quadrivalent HPV vaccine. A ministerial decree to halt vaccination in trials resulted in the creation of cohorts of women who received 1, 2, or 3 doses. Cervical screening with an HPV test was initiated at age 25 years for married participants. Those with a positive screening were referred to colposcopy, and those with a negative screening were asked to repeat in 5 years. Age and site-matched unvaccinated married women were recruited as controls. At the October meeting, we reviewed data on protection against persistent infection through 10 years. In their November 2024 publication, the authors reported results with a median follow-up time of 12 years and time since study began of 15 years. This means that the women in the study were aged 25 to 33 years. Vaccine effectiveness against persistent HPV 16/18 infection was 92% with 1 dose, 94.8% with 2 doses, and 95.3% with 3 doses. Please note the overlapping confidence intervals on the slide for these estimates. No CIN2+ cases associated with HPV 16/18 were detected among vaccinated participants, compared with 8 cases among unvaccinated women. There were no cases of invasive cervical cancer associated with HPV 16/18 in this study. And next we have Doris from Tanzania. Girls aged 9 to 14 years were randomly assigned to 1, 2, or 3 doses of bivalent HPV vaccine or 9-valent HPV vaccine. All participants were followed until month 36, and 1 and 2 dose groups were invited to join a long-term extension. The primary outcome was non-inferiority of HPV 16 and 18 specific seropositivity following 1 dose of HPV vaccine compared with 2 or 3 doses of the same vaccine. The trial had a co-primary immunobridging objective to demonstrate non-inferiority of HPV 16 and 18 antibody GMC after 1 dose of vaccine compared with 1 dose in studies that evaluated efficacy. In October, we reviewed data on immunogenicity and immunobridging to Kenji through 2 years. For our purposes, we'll focus on the results of the 9-valent HPV vaccine because this is the vaccine used in the United States. Regarding seropositivity, for HPV 16, 100% of girls were seropositive in the 1-dose and 2-dose arms. For HPV 18, 93% were seropositive in the 1-dose arm, and 98% were seropositive in the 2-dose arm. Even though seropositivity was high, non-inferiority of HPV 18 was not met. And regarding GMCs, in the figure, the 1-dose titers are in blue and the 2-dose titers are in green. Again, we see that 1-dose titers are lower, as expected. In the 1-dose arm, titers plateaued at month 12 and remained relatively constant through month 60. In the 2-dose arm, titers declined after the peak at month 7. As I noted earlier, 49 of the 59 studies identified by Cochrane were excluded due to serious risk of bias. All of the excluded studies were observational. I'll now briefly discuss observational studies of vaccine effectiveness. A previously published systematic review of HPV vaccine effectiveness by number of doses in observational studies found that many studies had a serious risk of bias. The most important sources of bias were differences between dose groups in the risk of prevalent infection at the time of vaccination, differences between dose groups in the risk of HPV acquisition during the follow-up period, and the potential impact of the interval between the first and second dose on vaccine effectiveness. The biases rated as serious would likely result in lower effectiveness observed with fewer doses. The ways investigators attempt to control for biases in their studies include using buffer periods to exclude outcomes caused by prevalent infections at the time of vaccination, stratifying results for age at vaccination or restricting the population to younger ages, adjusting for indicators of sexual activity and socio-demographic characteristics as proxy for sexual activity, and stratifying results for 2 doses by the interval between the first and second dose. Our systematic review only identified one observational study with less than serious risk of bias that has data on any of our critical outcomes. So we wanted to summarize this study's methods and results. The study was recently published by Wu and colleagues from Sweden and was assessed as having moderate risk of bias. It's a cohort study of 2.2 million females aged 10 to 35 years who were residents of Sweden between 2006 and 2022. The authors linked several registries, including vaccination and cervical screening registries. The time-varying exposure of interest was number of doses of quadrivalent HPV vaccine received. The outcome was CIN 2+. The authors used Poisson models to estimate incidence rate ratios, or IRR. They adjusted for several confounders and introduced a 12-month buffer period between vaccination and case counting. The median follow-up time was 8.4 years in the unvaccinated group and 12.4 years in the vaccinated group. The authors stratified their results by age at vaccination. We often focus on the youngest group, in this case, girls vaccinated at ages 10 to 14 years, making it less likely they were sexually active at vaccination, and therefore helping to eliminate the bias of differences in prevalent infection at the time of vaccination. The authors found that among girls initiating vaccination before age 15, which is found at the top of the figure, observed IRRs were 0.42 after 1 dose, 0.54 after 2 doses, and 0.5 after 3 doses. The confidence intervals are all overlapping, suggesting no difference in CIN 2+ by number of doses. Looking at the bottom of the figure, we can see that in women initiating vaccination after age 21, the only statistically significant IRR is among those who received 3 doses. The comparison here is unvaccinated females and therefore does not directly align with our PICOs. However, this study provides a nice example of an observational study that looks at effectiveness by number of doses. We plan to provide more data at the June ACIP meeting during our ETR presentation. However, I will close today by addressing some outstanding questions for reduced number of HPV vaccine doses. At the October 2024 ACIP meeting, Dr. Markowitz presented this slide highlighting the outstanding questions for reduced number of HPV vaccine doses. Based on the systematic review we've conducted, I'll summarize the status for each of these. At this point, the study with the longest efficacy data is IARC India at 15 years since vaccination, and the study with the longest immunogenicity data is the Costa Rica vaccine trial with 16 years since vaccination. We expect more data over time on longer-term efficacy and immunogenicity. We do not have any data on protection at anatomical sites other than the cervix. Related to this, of our 16 studies, 13 include only females. The Bornstein, Klein, and Zhang papers include immunogenicity data from girls and boys, but the Klein paper does not stratify by sex. We do not have any efficacy data on males at this time for reduced number of HPV vaccine doses. There is some evidence of lower antibody titers in adolescent males versus females after one dose. And there are important outstanding questions about immunogenicity in males, including whether differences in antibody response between males and females are clinically meaningful. As a reminder, the correlate of protection is unknown. We also have very limited data on efficacy and immunogenicity in immunocompromised persons. At this time, we are not planning to make any changes to the recommendation that immunocompromised persons receive 3 doses of HPV vaccine. And finally, we have limited data on efficacy and immunogenicity in older age groups. The studies we're relying most heavily on are India, which vaccinated at ages 10 to 18, and Costa Rica, which vaccinated at ages 18 to 25. The majority of participants in the other studies were vaccinated during adolescence. The work group will be deciding on the appropriate upper age for our PICOs. Dr. Markowitz will provide more details about the options our work group is exploring at the end of today's session. Thank you for your time, and I'd be happy to take any questions.
Thank you so much. I would love to open this session to questions. Wow, you were very, very clear and thorough. All right, we'll move on to the next. Let's go through the Kenshi study. Dr. Barnabas?
Good afternoon, everyone, and good morning for a few people. It is a real honor to be here at ACIP to present the Kenshi study results. And I love the name Kenshi. It asks the question, can she eliminate cervical cancer? And as we saw in the previous presentation, observational evidence supports that HPV vaccines are highly effective at preventing cervical cancer. And in this example, an 88% lower incidence among people vaccinated compared to those not vaccinated. We also know that HPV vaccination for all and catch-up vaccination to young adulthood accelerates the time to cervical cancer elimination. And in this modeling graphical illustration, we can see in the teal line here that with a higher coverage of HPV vaccination, we can bring forward the time to cervical cancer elimination. To evaluate the efficacy of single-dose HPV vaccination, we conducted a rigorous randomized trial, the Kenshi study, and found that single-dose HPV vaccination is highly efficacious, with 98% vaccine efficacy for HPV 16 and 18. And today I will present the methods and the results from the Kenshi study over 2 time periods, 36 months and 54 months. And I'll start with the 36-month results. And this is the randomized part of the study with a control group. Young women aged 15 to 20 were recruited from 3 clinical trial sites in Kenya. We recruited 2,275 participants, and they were randomly allocated to one of 3 study groups: immediate non-valent HPV vaccination, or immediate bivalent HPV vaccination, or immediate meningococcal vaccination. And this was the control group. There were 758, 760, and 757 participants in each of those 3 groups. And I will describe this as the primary endpoint period. The endpoint for the study was incident persistent vaccine type-specific infection among participants who are HPV naive at vaccination. And that is a salient point because HPV vaccines have no therapeutic properties. They are entirely prophylactic, and thus all the licensure studies report HPV vaccine efficacy among the HPV naive population. Participants were followed over 36 months, we excluded from the per protocol analysis participants who had evidence of infection at enrollment on month 3, and this is to account for the buffer period, as we heard in the previous presentation. Participants had 6 monthly visits where physicians collected cervical swabs for HPV DNA to determine the endpoint of persistent infection. And we'll present the results now for month 36. And I want to highlight that the retention was high throughout the study and at 96% 4 or more swabs at month 36. We excluded participants with prevalent HPV infections at enrollment. And here we can see for the modified intent to treat HPV 16-18 cohort, we excluded 29% of participants. And for the 7 high-risk type cohort, types 16 to 58, we excluded 52% of participants. And these 2 cohorts are important because 16 and 18 cause 70% of cancers, and 16 through 58 cause 90% of cancers. At 3 years, single-dose HPV vaccine efficacy remained high and durable. And you can see here in this Kaplan-Meier curve, the cumulative incidence of HPV over time. In the non-covalent group, 1 case, and in the bivalent group, 2 cases, 72 cases in the control group, a clear separation of the lines. HPV non-covalent vaccine efficacy of 99%, and for the bivalent vaccine and HPV vaccine efficacy of 98% for HPV 16 and 18. When we look in the non-covalent vaccine group against the 7 high-risk types, there were 5 cases in the non-covalent group and 84 cases in the control group, a vaccine efficacy of 96%. And I want to highlight here the lower bound of the confidence interval, greater than 89% for all these analyses. We hypothesized that single-dose vaccination would be effective and durable over 54 months based on sustained antibody levels over 10 years in the IARC India trial and over 16 years in the Costa Rica vaccine trial. Participants in the KENCHI study were crossed over at month 36 while maintaining the study blind to evaluate the durability of HPV vaccination. Participants who originally received the HPV vaccine were crossed over to receive delayed meningococcal vaccination, and participants who initially received the immediate meningococcal vaccine were crossed over to receive the delayed non-covalent vaccine, and this was done in a blinded fashion. And so we will describe the results in 3 time periods: the primary endpoint period, and you have seen those results already, the crossover period, during which time participants were receiving the crossover vaccination, and then the all single-dose HPV vaccinated period. And this is the time at which everyone had been vaccinated against HPV. This schematic shows the same information in a different form, and I'm showing this schematic because this is how we will present the results. The 3 groups with the original randomization, crossover vaccination, and then the all single-dose HPV vaccinated period. I want to share that we estimated durability over the entire 54 months with vaccine efficacy as a function of time since vaccination. And then I will show the case numbers pre-crossover and post-crossover. So this represents all the time post-crossover. To evaluate effectiveness of single-dose HPV vaccination for the participants now aged 18 to 23, we compared the cumulative incidence of persistent HPV using Kaplan-Meier or cumulative incidence curves and incident rate estimates for the immediate and delayed vaccine groups. And this I will show as a graphic illustration. To assess durability, vaccine efficacy was evaluated as a function of time since vaccination using a Cox regression model, accounting for time and time variable covariates, the most important of which, of course, is time since vaccination. The endpoint is unchanged, incident persistent vaccine type-specific HPV infection measured at two time points 6 months apart, and both analyses use the original per protocol or MITT cohorts. There were no differences in baseline characteristics between study groups. And here is a slide that summarizes those findings. Retention was 90% for 3 or more swabs, and the median time between endpoint swab collection was 6 months. And this is a busy slide, but I will just draw your attention to the high retention at each step of the study. 91% retention for 5 or more swabs pre-crossover, 95% of participants received crossover vaccination. Retention was 90% for 3 swabs post-crossover and 96% for 2 swabs post-crossover. And the time between swabs was almost exactly 6 months in all the groups. This table shows the incidence of persistent non-vaccine HPV types, and that was stable across time periods and between the study groups. And this is important because it shows that HPV exposure to the non-vaccine types was the same throughout the study and in all the groups. Thus, the only difference between the 3 study groups is the vaccine received at the time of randomization. And I'll move on now to the durability and vaccine efficacy results. This plot shows the cumulative incidence of HPV 16 and 18. And we can see here in the blue line, the number of cases in the immediate HPV vaccine group over time. There were 4 cases pre-crossover and 4 cases post-crossover, so no change in the number of cases. And we can see here that the cumulative incidence is the same over time as well. When we look at the delayed HPV vaccine group, we can see the number of cases steadily increasing over time. Once we start crossover vaccination, we see a leveling off of the number of cases and then really a plateau post-crossover. There were 89 cases pre-crossover and 7 cases post-crossover. And you can see here also a leveling off of the cumulative incidence of HPV. Let's now look at the incident rates. This figure shows in gray the non-vaccine types, and you can see that there's no change in the non-vaccine types, and that incidence remains the same. HPV exposure is the same. And in this insert, we zoom in to look at the incidence in the 2 study groups. Here in the blue, the immediate HPV vaccine group, you can see that the incidence remains steady pre and post crossover, and notably it's quite low. And here in red, the incidence among the delayed HPV vaccine group, starting at 7.5 and then decreasing to have overlapping confidence intervals with the immediate HPV vaccine group. Using Cox regression, we estimated that vaccine efficacy at 54 months for HPV 16 and 18 vaccination is 99.2%, with a lower bound of the confidence interval of 96%. When we zoom in here on this insert, you can see that over time, the lower bound of the confidence interval is tighter, and this is as expected and as discussed in the previous presentation seen in other studies. Looking at the non-valent vaccine group, you can see here in green the number of cases pre and post crossover over time, 5 cases pre-crossover and 5 cases post-crossover. So no change in the number of cases. When we look at the delayed HPV vaccine group, we can see that there are 98 cases pre-crossover and 9 cases post-crossover. And you can see here that the cumulative incidence levels out with vaccination. Let's look now at the incidence of persistent HPV per 100 women years. Again, in gray, you can see the background non-HPV vaccine types, and that is steady over time. And in this insert, you can see the incidence in the 2 studied groups. No change here in green in incidence for the 7 high-risk types in the immediate HPV vaccine group, and a decrease in incidence for the delayed HPV vaccine group. Pre-vaccination, almost 15, decreasing down to just above 4 with vaccination. When we estimated the vaccine efficacy for the non-valent vaccine against the 7 high-risk types, vaccine efficacy was 98.9%. And again, we can see in this insert and narrowing of the confidence interval, the lower bound of the confidence interval, now 94.9%. In sum, we found single-dose HPV vaccination effectively protected adolescent girls and young women from incident persistent HPV infection over the first 54 months post-vaccination through this rigorous design, high fidelity to the protocol, high retention, clear ascertainment of outcomes. We have strong evidence for single-dose HPV vaccine efficacy for up to age 23 years. Single-dose HPV vaccine efficacy for both 16 and 18 and the 7 high-risk types at a lower bound of the confidence interval of more than 94% in keeping with licensure trials for 3 doses. And importantly, there was no evidence of waning of this protection. I didn't share our insights from exploratory analysis, which we did for the ITT analysis, the intention to treat analysis, but we did find that HPV vaccination confers high protection once infections prevalent at vaccination have cleared. And we presented this information at a scientific meeting. This adds to the growing body of evidence supporting the efficacy of single-dose vaccine efficacy, and will go on to evaluate clinical endpoints. I want to leave the last words of this presentation to patients. As a physician, I want to highlight the role of patients. This is our 11-year-old daughter who is benefiting from HPV vaccination and the data on single dose presented today, and we are thrilled that she will be protected. And this picture is a reminder of a patient who I recently saw on the inpatient service with infectious complications for advanced cervical cancer. She was in her early 20s when the vaccine was licensed, and that could have had a protective effect and prevented this admission. I want to thank the really outstanding Kenshi study collaborators, the incredible team that does this work. Thank you for your attention. I'm very happy to take questions.
Thank you so much for a wonderful presentation. We're running a little behind, so I have time for one question. Okay.
Might be some later.
I think there will be because it was really good. Okay, let's go on to HPV vaccination coverage. Dr. Pingali.
Good afternoon. My name is Cassandra Pingali, and today I'll be reviewing coverage estimates for the routine vaccines recommended for adolescents with a particular focus on HPV vaccination using the 2023 National Immunization Survey teen data. A summary of the 2023 NIS teen data was published in MMWR on August 23, 2024, and these data are also available on CDC's TeenVaxView webpage. I'll start with a high-level summary of the methods of the National Immunization Survey Teen, or NIS Teen. The NIS Teen survey consists of 2 phases. The first phase is a random digit dialed telephone survey of households with teens aged 13 to 17 years, and the second phase is a mailed survey of vaccination providers. The household survey collects sociodemographic information and requests permission from the parent to contact the teen's vaccination provider. If permission is granted, then a mailed survey is sent to all vaccination providers identified by the parent. The provider survey collects data on when vaccinations were received, which types of vaccinations were given, and how many doses the teen has had. Vaccination providers can be any place that has administered the teen a vaccine, including primary care offices, pharmacies, or health departments, for example. Vaccination coverage estimates reported in NIS Teen are based on the provider-reported data. The 2023 NIS Teen surveyed 16,568 parents or guardians of teens who were born between January 2005 and December 2010. Now we will review the 2023 coverage estimates among adolescents aged 13 to 17 years. This line graph shows the trend in coverage with vaccines recommended for adolescents from 2006 to 2023 among adolescents aged 13 to 17 years. 1 or more doses of Tdap is the red line, and 1 or more doses of MenACWY is the dark blue line at the top of the graph. Coverage with these vaccines has been high and stable since about 2018. HPV initiation is the yellow line, and HPV up to date is the green line. Coverage for HPV initiation and HPV up to date plateaued in 2022, and it is still lower than the other routine vaccines, with the exception of the men ACWY booster dose noted in purple. In this table, we compare vaccination coverage in 2023 versus 2022 among adolescents aged 13 to 17 years for the vaccines routinely recommended for adolescents. There are no significant differences in coverage from 2022 for any of the routine vaccines. In 2023, 89% of adolescents aged 13 to 17 years had received a Tdap vaccine, 88.4% had received a men ACWY vaccine, 76.8% had received an HPV vaccine, and 61.4% were HPV up to date. This is the second year that HPV coverage has not increased among adolescents aged 13 to 17 years. Here we describe the simultaneous administration of the HPV vaccine with other vaccines recommended for adolescents, including Tdap, men ACWY, and flu vaccine from the 2023 NIS teen data. We used adolescents who had received an HPV vaccine in the 2023 sample as the denominator, and the numerator was the number of adolescents who received different combinations of the vaccines recommended for adolescents in a single visit. In 2023, about 77% of adolescents received an HPV vaccine. The HPV vaccine is commonly given with other vaccines, with 69.5% of adolescents receiving the HPV vaccine and one or more other vaccines recommended for adolescents in a single visit. In 2023, among adolescents who received an HPV vaccine, 47.8% received the HPV vaccine, the Tdap vaccine, and the men ACWY vaccine in a single visit. Next, we'll look at coverage stratified by sociodemographic factors and access to healthcare. This figure compares routine vaccination coverage by metropolitan statistical area or MSA status. MSA principal city or mostly urban areas is the reference group for comparisons. Coverage with one or more doses of HPV vaccine and the percent of adolescents HPV up to date is lower in mostly suburban and mostly rural areas compared to mostly urban areas. There were no differences by MSA status for Tdap and men ACWY. This slide compares coverage with routine vaccines by health insurance status. Privately insured adolescents are the reference group for comparisons. Overall, vaccination coverage was lower among uninsured adolescents than privately insured adolescents for all vaccines, as we've seen for many years. Historically, about 2 to 3% of the NIS teen sample is uninsured, so this represents a very small group of adolescents. Those with other insurance had a lower percent HPV up to date than privately insured adolescents. In 2023, adolescents with private and any Medicaid insurance had similar vaccination coverage, including coverage with the HPV vaccine. We will investigate this finding more closely on the next slide. In this line graph, adolescents insured by any Medicaid insurance are shown in blue, and privately insured adolescents are shown in gray. HPV vaccination has historically been higher among Medicaid-insured adolescents compared to privately insured adolescents, as seen from 2015 to 2021. In 2022, coverage with one or more doses of HPV vaccine among Medicaid-insured adolescents declined 3 percentage points. Subsequently, we found in 2022 and 2023 that coverage with one or more doses of HPV vaccine was now similar between Medicaid-insured adolescents and privately insured adolescents. This figure shows routine vaccination coverage stratified by race and ethnicity groups. We use white adolescents as the reference group for comparisons. This year, there were not many differences in coverage by race and ethnicity. Although historically Black and Hispanic adolescents have had higher coverage with one or more doses of HPV vaccine than white adolescents, in 2023, only Hispanic adolescents had higher coverage. Coverage with one or more doses of men ACWY was higher among Asian adolescents compared to white adolescents. HPV vaccination coverage continues to vary widely by state. This map shows coverage with one or more doses of HPV vaccine split into quartiles. Overall U.S. coverage with one or more doses of HPV vaccine was 77%. Mississippi had the lowest coverage at 60%, and Rhode Island had the highest coverage at 93%. Finally, we will look at initiation of the HPV vaccine by age. This graph looks at HPV initiation by age among those aged 9 to 10 years, age 11 to 12 years, age 13 to 17 years, and those who never initiated HPV vaccination. Data from the 2018 NIS Teen Survey are shown in gray, and data from the 2023 NIS Teen Survey are shown in blue. HPV vaccination initiation has increased from 2018 to 2023, and over time, more adolescents have initiated the series at the recommended age. In 2023, about 23% of adolescents were unvaccinated for HPV, compared to 32% in 2018. In 2023, HPV vaccination initiation was most common at ages 11 to 12 years. 57.1% of adolescents initiated the HPV vaccine series at ages 11 to 12 years. 5.7% of adolescents initiated the HPV vaccine at ages 9 to 10 years, and 14% initiated the HPV vaccine at ages 13 to 17 years in 2023. I will now recap the key points on HPV vaccination coverage from the 2023 NIS Teen data. In summary, while 76.8% of adolescents had initiated the HPV vaccine and 61.4% were HPV up to date in 2023, this was the second year that HPV coverage had not increased from the previous survey year, and HPV vaccination coverage remains lower than coverage for Tdap and men ACWY vaccines. In 2023, adolescents most commonly initiated the HPV vaccine at ages 11 to 12 years, and 47.8% of adolescents received the HPV vaccine, Tdap vaccine, and men ACWY vaccine in a single visit. HPV vaccination coverage continues to vary by sociodemographic factors, access to healthcare, and by state. Finally, I'd like to thank my team and my colleagues at CDC, and I'd be happy to answer any questions. Thank you.
Thank you. Any questions? Y'all are very thorough today. And Ms. Moser.
Thank you. Thank you for that presentation. I always appreciate the NIS teen and the NIS infant data for the important work that the important data it provides, showing us how we're doing on a national scale. So I just wanted to ask, can we expect this data moving forward, or have any of the changes affected our ability to collect this information?
As far as we know, we are continuing to collect the NIS teen and NIS child information. Thank you.
Thank you.
Dr. Asturias.
Thank you for those very well put together presentations. But the last slide that you showed on the initiation of HPV vaccine, do you see any differences by geographic region in the US? Over.
So we likely don't have the sample size to look at that very youngest age group, those 9 to 10. In the national sample, less than 5% were initiating at ages 9 to 10 years. But we could take a look and see, by state, if we can see some stable estimates and see if there's any differences there.
Yeah, and perhaps I'm more interested in rather than the younger group, also the late group, the 13 to 15 years of age.
Certainly, we can definitely take a look at that and provide those data. Thank you.
Dr. Brooks.
Yes, again, thank you very much, Ms. Bengali. When you said up to date on the slide where you showed it over time, I think from 2015 forward, when it said up to date, would that be considered up to date if you were 9 to 14 and only needed 2 doses? Because there was also one that said greater than or equal to 3 doses. I want to clarify what up to date was defined as on that graph.
Thank you for that question. So in NIS Teen, we define HPV up to date as those who received 3 or more doses and those who received 2 doses when the first dose was initiated at less than 15 years, and there was greater than or equal to 5 months minus 4 days between the first and second dose.
Very good. Thank you.
Dr. Schechter.
Thank you, and thanks for these presentations. I was wondering if you saw any effect of that was seen for other vaccines or and other ages for disruption in provision of primary care, disruption or delays in administration within the 13 to 17-year-old cohort, if there's any evidence of that during the pandemic. And I was wondering what your thoughts were about the equalization of the Medicaid and private pay adolescents, whether that reflects catching up on the private side or loss of progress on the Medicaid side, or any thoughts about that? Thank you.
Thank you for those great questions. The first one is a big one, and I'll just say we didn't have time today to get into too much of the pandemic effects on vaccination coverage. But to quickly summarize, we did particularly see drops in vaccination coverage for the routine vaccines for those born in 2008. So those are children who would have been 12 years of age during the pandemic, and so it looks like their vaccinations were heavily affected by the pandemic. The 2009 birth cohort, who would have been 11 in 2020, we didn't see as many effects on coverage for that age group. And then for the 2010 birth cohort, which was the youngest birth cohort in the 2023 data, their vaccination coverage was similar to pre-pandemic coverage, with the exception we did see a drop in HPV up-to-date coverage for the 2010 birth cohort. So we did see some drops in coverage due to the pandemic, and they were mostly confined to the 2008 birth cohort. For your second question about what was happening with the changes in coverage among privately insured adolescents and those insured by Medicaid, we did see a 3 percentage point drop from 2020, I think it was 2021 to 2022 in HPV coverage. So definitely a drop there, and not really sure, why we were seeing that in the data, other than perhaps Medicaid-insured adolescents are eligible for the VFC program. So we did wonder if perhaps there was change to the access of the VFC program, or maybe some other pandemic effect going on there. Thank you.
Thank you very much. Next will be Dr. Kim, who will look at the modeling of a reduced number of doses for HPV vaccination series.
Hello, everyone. It's a pleasure to be here to present on the population-based health impacts of single-dose HPV vaccination in the United States. This work was led by my modeling team at Harvard University, as well as Marc Bresson's team at the University of Laval. And I'd like to acknowledge our funding sources, as well as colleagues at the CDC and New York University for their contributions to related work. We have no conflicts of interest. For this analysis, we used 2 independently developed mathematical models adapted to the US population to project the long-term health effects of single-dose HPV vaccination, taking into account historical HPV vaccination coverage in the US population, and to explore key uncertainties of single-dose HPV vaccine efficacy and duration on the population-level effectiveness. The Harvard and Laval's HPV advised models have been independently developed, but share some common features. Both models are individual-based sexual transmission models of HPV, and therefore include herd immunity from vaccination. They are both full population-based models reflecting multiple birth cohorts of females and males by single-year age, and they both capture heterosexual mixing among 4 age-stratified risk groups. There are also some notable differences between the models, namely the way that HPV genotypes are reflected. Both model the 7 high-risk HPV types included in the 9-valent HPV vaccine separately. The Harvard model pools the other high-risk types as well as low-risk types, while HPV Advise models additional low and high-risk types separately. HPV transmission is modeled by Harvard as a probability per month of partnership duration, whereas in HPV Advise, HPV transmission is a probability per sexual act. And while the health states in our models are mostly similar, HPV Advise includes an additional low-grade precancerous lesion state of CIN1. Both models have been used for other policy decisions by ACIP. Because we don't have time to go deep into these models, I thought it would be helpful to show how our models reproduce some of the epidemiological data that are observed in the US population. Here's a slide showing the prevalence of HPV-16 by age in the years before HPV vaccination was available or widespread in the US, with the red line indicating Harvard's model-based outcomes and the black dots indicating data from NHANES from years 2002 to 2008. On the right, we have the same comparison a few years after HPV vaccination was introduced from years 2013 to 16. And you can see that the Harvard model fits well to the prevalence data, both pre and post-vaccine, tracking with the NHANES data in terms of magnitude and age-specific patterns. Here are similar graphs showing model fit of HPV Advise to HPV 16 and 18 prevalence by age in years pre and post-vaccine in the US. The blue line and shaded areas show the uncertainty in their model against the uncertainty in the NHANES data shown in red. And again, we see a close correspondence of the model outcomes to the data. One more slide shows the projections of both models against the median lifetime partners of males and females by age. The US data are from 2 CDC national surveys, and we plotted data from 2 other high-income countries, Canada and the UK, which report a higher number of lifetime partners. You'll see that both models, shown by the colored lines and shading, overestimate the lifetime partners against the US data, but have a closer fit to the data from other countries. This overestimation of the models compared to the US data implies a higher exposure of HPV in the models, especially in the older age groups. And this becomes important as we look at a scenario of potential waning of a single-dose vaccine, which I'll come back to later. For our analysis, both models simulated US vaccination policy, which, as Dr. Brooks just presented, has included changes in terms of vaccine type, target population, and ages and doses over time. In this analysis, we assume there's a switch to single-dose HPV vaccination in year 2025 with the 9-valent HPV vaccine for all ages. The scenario of 1 dose through age 45 years is for illustrative purposes only, to show the maximum possible difference between 1 dose and the current strategy. And for vaccination coverage, we use data from the NIS-TEEN, which was just presented, to inform our historical coverage assumptions by age and over time. For the older age groups, we made assumptions of lower vaccine uptake that were used in prior analyses conducted for ACIP. Our vaccine assumptions were grounded in the existing data from clinical trials and studies, including the KENCHI trial that was just presented. For vaccine efficacy, we assumed a base case scenario of 98%, which implies a non-inferior 1 dose compared to 2 doses, and a worst case scenario with a vaccine efficacy of 90% for 1 dose, which represents a lower bound of the published KENCHI data, though Dr. Barnabas just presented data that suggests a more optimistic lower bound. For vaccine duration, in our base case analysis, we assume lifelong protection, which is equivalent to what we assume for the 2 doses of the vaccine. And our worst case scenario is an average duration of 25 years, assuming the waning function is normally distributed with a standard deviation of 5 years. This means that we expect 1 dose to provide stable efficacy for an average of 25 years, followed by a steep drop in protection. This distribution function implies that waning starts at 15 years after vaccination for some individuals, that there's no protection for 50% of individuals 25 years after vaccination, and no protection for virtually all individuals 40 years after vaccination. And we assumed in this analysis that both vaccine efficacy and duration are the same for all vaccine-targeted HPV types. Here is a visualization of these assumptions against data from two studies, a prospective cohort study in India and the Kenshi clinical trial. And on the left, we see the base case model assumption of vaccine efficacy equal to 98%, shown by the gray line, which also assumes no waning protection. And on the right is the assumption of 90% vaccine efficacy, shown by the orange line. Here's a display of our vaccine duration assumptions of percent protected against infection by years since one dose vaccination, compared to data on the HPV-16 antibody levels in the Costa Rica vaccine trial over a 16-year period, indicated by the orange symbols. On the left is the assumption of lifelong protection, shown by the straight gray line. And on the right are two scenarios. The red shows the more pessimistic assumption of average duration of 25 years following a normal distribution. And the blue line shows a more optimistic average duration of 35 years. Again, in this presentation, I'll focus on the worst case 25-year scenario, which still remains theoretical, as we've not yet observed waning in any of the studies. Now I'll move on to our results. This first set of slides will show the model-based projections of switching to one-dose HPV vaccination in year 2025 under the assumption of a non-inferior one-dose vaccine. That is, vaccine efficacy is 98% and duration of protection is lifelong, equivalent to what is assumed for 2 doses. On the left is relative incidence of HPV-16 among females by year. And on the right is cervical cancer relative incidence, and this is cervical cancers associated with all HPV types. The red line shows the projections from the Harvard model, and the blue line shows the projections from HPV Advise. And while there are some differences between the two model projections, both models estimate similar timing and magnitude of reductions in both HPV-16 and cervical cancer incidence over time. In fact, when we overlay the uncertainty bounds from the HPV Advise model, we see more overlap between the two models, especially in cervical cancers on the right. And in summary, with continued 2-dose or a switch to non-inferior 1-dose vaccination, both models project near elimination of HPV-16 infections and roughly 90% reduction in cervical cancers by year 2070. Now, given the closeness of the two model results, we combined our estimates, and I'll now show the mean projections from the two models for ease of presentation. Here's the scenario of lower vaccine efficacy for 90% for 1 dose, shown by the purple line, and this is still assuming that duration of protection is lifelong. And under this worst-case scenario of vaccine efficacy, 1-dose vaccination is projected to produce similar population impacts as 2 doses or non-inferior 1-dose vaccination. Next, we look at the impact of duration of 1-dose protection, assuming the scenario of 25 years. And here we are back to the base case vaccine efficacy of 98% for 1 dose. And again, the models found that even with waning 1-dose protection occurring on average after 25 years, switching to 1-dose vaccination is projected to produce similar population level impacts as 2-dose or non-inferior 1-dose vaccination. Our final analysis assumed both lower 1-dose vaccine efficacy of 90% and duration of 25 years. So I guess this is our worst case scenario. And here we see a small level of HPV-16 incidence rising, roughly 1 to 2% by year 2045, and later in cervical cancer incidence by year 2060. But as you saw, these increases are likely within the range of uncertainty in the models. This graph provides a summary of results across the 4 scenarios, and our overall findings are that all scenarios result in similar reductions in HPV-16 and cervical cancer incidence over time. Next, I'd like to address how these findings compare against previously published results. Now, this graph shows results from HPV Advise under similar scenarios that I just presented that was recently published in JNCI by our teams and presented to the ACIP HPV Working Group last December. Unlike the current analysis, HPV Advise projected here a rebound in both HPV-16 infection and cervical cancer incidence when assuming a vaccine duration of 25 years. And the primary reasons for these differences are twofold. First is a difference in sexual activity in the HPV Advise model used for the two analyses. The JNCI analysis was meant to reflect high-income countries and therefore used both the US and Canadian versions of HPV Advise. And as I showed in the earlier slide of lifetime partners, Canada has higher sexual activity and therefore higher exposure among older individuals, which leads to a greater rebound once vaccine protection wanes. The second is a difference in vaccination coverage assumptions. And for JNCI, we assumed 85% routine coverage at age 10 years, with a catch-up to age 19 years in the first year of vaccination only. In contrast, the current analysis simulates observed US coverage, including not only routine, but also continual catch-up vaccination spanning ages 9 to 26 years, starting in the first year of vaccination. The implication here is that the average age of vaccination is at least 5 years later in this current analysis than the analysis that you see presented here. So with a 25-year duration, waning is happening when individuals are less sexually active. In other words, there is a higher percent directly protected at older ages and stronger herd effects when those with one dose begin to lose protection. Other scenarios that were explored in prior analyses include the impact of one-dose vaccine efficacy in males. And in a pessimistic scenario of lower one-dose vaccine efficacy of 70% for males only, the HPV Advise model showed a similar population-level impact as non-inferior one-dose for all individuals. And this is because herd effects would mitigate a lower vaccine efficacy for males if gender-neutral vaccination coverage is high and vaccine efficacy for females is high and long-lasting. However, they acknowledge that rebound in HPV infections and other HPV-related cancers, could be greater for men who have sex with men if one-dose vaccine efficacy or duration is lower for men. Prior analyses have also explored the impact of one-dose vaccination on non-cervical HPV-related cancers. It's important to preface that more work is required to better understand the natural history of these cancers and the potential impact of one-dose vaccination on their epidemiology and the transmission dynamics of the related HPV types. But prior analyses suggest more limited and delayed rebound for other HPV-related cancers for all pessimistic one-dose scenarios, given slower progression from infection to cancer. And the question of mitigation strategies to offset potential rebounds in infection and cancer have been explored in several analyses in both high-income and low-income, high-burden settings. Both models have shown that if ongoing trial data were to signal waning protection, let's say in the next 10 years, switching back to a two-dose regimen would mitigate any rebounds in HPV-16 and cervical cancer. And these analyses also found that the mitigation strategies could be population level, meaning they would not require revaccinating those who received one dose in order to be successful. So in conclusion, our model suggests that switching to one-dose HPV vaccination is projected to have similar reductions in HPV and cervical cancer incidence as continuing with two doses in the US. Under the pessimistic assumptions of vaccine efficacy and duration, a switch to one-dose vaccination is projected to have limited rebound in HPV infection and cervical cancer incidence. And this is because switching to one-dose vaccination would occur when HPV prevalence is low due to the already high two-dose vaccination coverage in the US population. And individuals would be protected during their peak ages of sexual activity, providing direct protection and herd protection among unprotected adults. Continuing Monitoring of one-dose protection over time is required to rapidly detect any potential signs of waning protection and introduce mitigation strategies if needed. And under pessimistic assumptions of one-dose duration of protection, switching back to two-dose vaccination has been projected to mitigate losses in cervical cancer prevention. And I'll close by saying this comparative modeling exercise using two independent models showed very consistent results, adding to the robustness of our conclusions. Thank you, and I'm happy to answer any questions.
Thank you so very much. It's very impressive to me how effective this vaccine is in preventing cancer. It's just unbelievable. Dr. Asturias.
Yeah, thank you so much, Jane. And again, I concur with Dr. Talbot. This is one of the most effective vaccines that we ever have developed as humans. And I think one question, and I think models, as we know, are as robust as the assumptions, but I think I just want you to sort of provide me with some insight, but it seems to me that the question, given your model, what I see that the question is not really the immunogenicity and efficacy of the vaccine, which we know over and over that has been very good, doesn't matter the number of doses we use, but that a lot of the population impact that we see in the model is being driven by indirect effects. Am I correct on that? So it doesn't matter really the immunogenicity that we are reaching, is really how many people we get protected, which is going to drive the whole population effects. Over.
Absolutely. And this is, and we're already observing the strong indirect or herd effects in the population from vaccination in the U.S. So it's both the direct protection that we're seeing, but that provides a resilience in the population through the herd effects that it is providing to unvaccinated individuals. Thank you.
All right, Dr. Brooks, right quick.
Yeah, real quick. So first of all, excellent presentation, and quick question. In your modeling where there's a potential rebound, did it model in the fact that it may take a delay of a number of years to even notice the rebound, and then maybe another couple of years before the mitigation effects, kick in?
Well, what we're expecting is that we would have information from clinical trials well before we would detect any epidemiologic signals in HPV prevalence resurging. And so, we know that we have ongoing clinical trials that are tracking the efficacy over time. And so, and then if you saw in the previous slide with from the published analysis in JNCI, we do see the kind of rebound happening, several years later, and then even later for cervical cancer. So we would expect to see delays in the rebound in the cancers. But again, reinstituting any kind of mitigation strategies, reverting back to a two-dose schedule would really offset any of those losses in health.
Great. And we're talking many, many years down the line. So you're right. You'd have a lot more data at that point. Thank you.
Correct. Thank you.
Thank you, Dr. Kim, so much. We're going to switch over to modified ETR wording of the age for routine vaccination.
Today, I will be presenting on some of the domains of the Modified Evidence to Recommendations framework regarding the policy question concerning the wording of the age for routine HPV vaccination. For this policy question, we will not be using grade. The systematic review that was presented at the last ACIP meeting in October evaluated benefits of vaccination at ages 9 to 10 years. We did the systematic review since there was a growing body of evidence evaluating vaccination at age 9, but we are not considering changing the age at routine vaccination. As you all are very familiar with, HPV vaccination is routinely recommended at age 11 or 12 years. Vaccination can be given starting at age 9 years. Since 2006, when ACIP and CDC made the first HPV vaccination recommendation, there have been no substantial changes to this wording around timing of initiation. Since its introduction, HPV vaccination has been considered part of the adolescent platform. As a quick review, in 1996, the adolescent platform at 11 to 12 years was established as a new strategy to improve the delivery of vaccination services to adolescents and to integrate recommendations for vaccination with other preventive services. In 2006, the Society for Adolescent Health and Medicine endorsed 3 distinct platforms: one at 11 to 12 years of age, another at 14 to 15 years of age, and a third at 17 to 18 years of age, to integrate and emphasize the role of vaccination in already recommended comprehensive health care screening and provision visits. The adolescent platform has continued to evolve. This slide reviews some key adolescent vaccination recommendations. In 1995, a tetanus diphtheria booster was routinely recommended for children at age 11 to 12 years. In 2005, this recommendation changed to Tdap for this age group, and men ACWY was also added in 2005 to this visit. In 2006, HPV was recommended for this age group as well. There are additional meningococcal recommendations in later adolescence shown on this slide. The depiction of the adolescent platform and the HPV vaccine recommendations on the immunization schedule has also evolved. I'm going to review some examples of how this has changed. This slide shows how the immunization schedule was depicted in 2007 after HPV vaccine was first recommended. As you can see, 11 to 12 years was bolded on the schedule to support the adolescent platform. The "can be given starting at age 9 years" language was not depicted on the schedule. This slide shows how the schedule was depicted in 2017. The "can be given starting at age 9 years" language was at that time represented by a blue box to indicate individual clinical decision-making, which is now known as shared clinical decision-making. Also note in this schedule, the adolescent visit headers of 11 to 12 years and 16 years are grayed to reflect the evolving adolescent platform. Since 2022, the depiction of the HPV vaccination recommendation wording of "can be given starting at age 9 years" is represented on Table 1 of the immunization schedule by a yellow and brown checkered color pattern, which is uniquely used for HPV. Table 1 shows the recommended schedule by age. Other parts of the schedule, including the notes, have information on the HPV vaccination schedule. Note that the adolescent platform visits are not distinguished by different header colors. Given the interpretation issues with the current wording, the policy question that we are reviewing is, should the ACIP recommendations state that HPV vaccination is routinely recommended at age 9 to 12 years instead of the current wording of HPV vaccination is routinely recommended at age 11 or 12 years, vaccination can be given starting at age 9 years? We are considering changing the wording to improve clarity. The full ETR consists of these domains, which are guided by the questions shown on the right. I will now walk you through the modifications we made for this policy question. We will not be performing grade, and therefore will not be evaluating the certainty of the evidence of benefits and harms. However, we will describe the desirable and undesirable anticipated effects. In addition, we will consider acceptability and values in one discussion. Acceptability to stakeholders and values of the target population are intertwined topics. Lastly, the resource use domain is not directly applicable to this policy question. In the resource use domain, cost-effectiveness analyses are usually presented, which are relevant when introducing a new vaccine in additional age groups or additional vaccine doses to a population. For this policy question, cost-effectiveness analyses will not be done. Of note, health economic analyses would show that if vaccination occurs at a younger age because of this change in wording, vaccination would be slightly less cost-effective, all else equal. This is because the costs of the vaccination would be incurred sooner and therefore be greater in terms of present value. Therefore, this is how we plan to approach the ETR. Today, I will be presenting the first half of the ETR. I will be presenting the public health problem, the benefits and harms, and the acceptability and values domains. The first domain I will present on is the public health problem. I will review burden of HPV infection and disease and briefly review vaccination coverage that you already heard about in a previous presentation. HPV is the most common sexually transmitted infection. Persistent infection leads to precancers and cancers. This slide summarizes the most recent data from the cancer registries from 2017 to 2021 and shows the burden of HPV attributable cancers. In total, an estimated 37,800 HPV attributable cancers are diagnosed each year. As shared in the earlier presentation, this graph shows data from the National Immunization Survey Teen and includes vaccination coverage for HPV, Tdap, and meningococcal vaccines from 2006 through 2023. As you can see, HPV vaccination coverage has increased since vaccination introduction, but continues to lag behind coverage for the other adolescent vaccines. The next few slides show data on burden and impact of the vaccination program on a variety of HPV outcomes. We have monitored HPV infection prevalence through the National Health and Nutrition Examination Surveys. Since the introduction of the HPV vaccination program in 2006, we have seen declines in HPV prevalence. This graph shows data from NHANES from the pre-vaccine era to the most recent years for which we have data on, and shows overall quadrivalent HPV vaccine type prevalence among sexually experienced females aged 14 to 24 years. The prevalence declined from 18.5% in 2003 to 2006, the pre-vaccine era, to 2.8% in 2015 to 2018. This is a decline of 85%. Quadrivalent HPV vaccine type prevalence declined among sexually experienced females from different racial ethnic groups as well. Compared to the pre-vaccine era, quadrivalent HPV vaccine type prevalence declined 82% among non-Hispanic white females, 86% among non-Hispanic Black females, and 100% among Mexican American females. This graph shows the estimated number of cervical precancer cases by age group in 2008 and 2016. These data are from HPV Impact, a 5-site population-based cervical precancer and cancer surveillance project. In the 2 youngest age groups, there was a large decrease in the estimated number of cases. This is likely due to a combination of changes in screening and vaccine impact. In most older age groups, a larger number of cases were diagnosed in 2016 than in 2008, which is unrelated to vaccination and is probably due to screening changes. This slide shows more clearly the declines in cervical precancers due to vaccination in young women. These graphs show trends of CIN2+ and CIN3+ among screened women from HPV Impact from 2008 to 2022. Declines are seen in women aged 20 to 24 years since 2008 and in women aged 25 to 29 years since 2016. We also see declines in cervical cancers in young women. Of note, cervical cancer has been declining for several decades in the U.S. due to cervical cancer screening, which allows for detection and treatment of precancers before progression to cancer. Shown here are some published data on squamous cell carcinoma trends in young women through 2017. Continued declines in this age group now are likely a combination of both changes in screening recommendation and vaccination impact. CDC has estimated the annual direct medical costs associated with screening for and treating HPV attributable diseases in 2020 US dollars. The annual total cost of HPV attributable diseases is over $9 billion, with over $4 billion due to treatment. In summary, 37,800 HPV attributable cancers are diagnosed annually in the U.S. HPV vaccine has decreased the burden of diseases, but as you heard in the earlier presentation, HPV vaccination coverage lags behind other adolescent vaccinations. HPV vaccination has led to decreases in infection prevalence and cervical precancer incidence, and there are early signs that vaccination has decreased cervical cancer incidence in young women. Total cost of HPV-related disease is over $9 billion. The work group was asked, is HPV-related disease of public health importance? The work group members unanimously answered yes. The next domain I will present on is the benefits and harms domain. The potential benefits of changing the wording of the age for routine vaccination to 9 to 12 includes increased clarity and flexibility. The potential harms include separating HPV vaccine from the adolescent platform, or at a minimum, the perception of doing so, and possible negative pushback from getting prompts at age 9 from some providers who may prefer to give the vaccine at age 11, or for some parents for various reasons. In the next few slides, I'll review these points more. Even though ACIP wording currently allows for vaccination at age 9, the current wording has led to some confusion for some partners. Changing the wording to age 9 to 12 years as proposed here would increase clarity around this issue. Some partners are interested in vaccinating at age 9. One of the implementation issues raised by some who would like to vaccinate at age 9 is that electronic health records don't provide prompts at age 9. This is a result of the current wording interpretation into clinical decision support for immunization resources. Simplifying the wording to ages 9 to 12 would hopefully address this concern for those who are interested in vaccinating at age 9. In CDSI resources, the minimum age for HPV vaccination is 9 years, and the earliest recommended age is 11 years. Additionally, there is administrative guidance included in the CDSI resources that state the vaccination can be given starting at age 9 years. Some systems are able to reflect this recommendation wording in their prompts, but in general, clinical decision support tools use the earliest recommended age for all age-based vaccine recommendations. For HPV, this results in electronic health records and other CDS engines prompting providers at age 11 for HPV vaccination. Changing the wording of the age for routine vaccination would lead to changes in CDSI resources. If the wording of the recommendation is changed to 9 to 12 years, the earliest recommended age will be changed to 9 years in CDSI tools. This would result in prompts for HPV vaccination at age 9 years. As shown earlier, this is how the current HPV recommendation wording is depicted on the immunization schedule. If the wording were to change, the graphical depiction of HPV recommendations on the immunization schedule would change as well. The combined child, adolescent, and adult immunization schedule work group is responsible for creating the immunization schedules. There would no longer be a need for the yellow and brown checkered color pattern or the purple color. This is one way in which this may be reflected on the immunization schedule pending the work group and ACIP decisions. The policy question that is being considered is changing the wording of the recommended age to 9 to 12 and not changing the recommended age to 9 to 10. However, we conducted a systematic review of studies evaluating vaccination at age 9 to assess those data. These were presented to ACIP in the October meeting. In brief, the retrospective cohort studies included in this review do show higher vaccination series completion by age 13 when initiating at age 9 to 10 years versus 11 to 12 years. But study limitations preclude a cause and effect interpretation because it is not clear if associations found in these studies are due to the age at vaccination or to other factors. Only a small percentage of children had initiated vaccination at ages 9 to 10 years. There may have been differences in children and families who initiated at ages 9 to 10 years versus 11 to 12 years, or differences in providers who vaccinated at ages 9 to 10 years versus at ages 11 to 12 years. Due to multi-pronged interventions and the QI intervention studies in the review, it is unclear if the component that focused on initiation at ages 9 to 10 years was responsible for increases seen in initiation and completion. In regard to potential harms, some have raised concerns that changing the wording may affect the adolescent platform. As a quick review, at the time HPV vaccination was first recommended in 2006, the adolescent platform had been established for a decade. Currently, the adolescent platform at age 11 to 12 years consists of HPV, Tdap, and meningococcal vaccines. We don't have data on what the potential harm would be, but we do know that HPV vaccine is commonly given with other vaccines. As shared in the previous presentation, among adolescents who received the HPV vaccine, 70% received it at the same visit with at least one other vaccine. And in 2023, among adolescents who received an HPV vaccine, 48% received the HPV vaccine and Tdap vaccine and men ACWY vaccine in a single visit. Another potential harm to consider is the wording change may lead to system changes or prompts at age 9, and vaccination at age 9 may not be acceptable to some providers. We will review acceptability to stakeholders, including providers, in the next domain, but as it relates to possible harms, there are 2 surveys that suggest this wording change may not be acceptable to some providers. A national sample of primary care professionals who completed an online survey in 2021 showed that the most commonly perceived disadvantage of recommending HPV vaccine at age 9 was parents' lack of readiness. In another survey, primary care providers and clinical staff were randomly assigned to consider the perceived benefits of HPV vaccination at age 9 versus age 12. Providers were less likely to identify that parents are ready to talk about the HPV vaccine as a perceived benefit for vaccination at age 9 versus age 12. In summary, changing the wording of the age for routine vaccination to 9 to 12 may provide clarity and flexibility for those providers who are interested in vaccination at age 9. While not our policy question, the systematic review did show that vaccination at ages 9 to 10 years was associated with increases in completion by age 13, but due to limitations in these studies, it is unclear if this association is causal. Also, the QI intervention studies were difficult to interpret since multiple interventions were implemented simultaneously. Currently, about half of adolescents who initiated HPV vaccine are receiving this vaccine as part of the adolescent platform, and 70% of those who initiate are receiving it with at least one other vaccine. And changing the wording of the age for routine vaccination may negatively impact the adolescent platform. In addition, changing the wording of the age for routine vaccination may result in system changes or prompts at age 9 for vaccination, which some providers may not find acceptable. The work group discussed the desirable and undesirable anticipated effects of this wording change. Concerns around diluting the adolescent platform were raised, where not only vaccinations are given, but key preventive care is provided to adolescents, while others on the work group saw the wording change as possibly increasing opportunities for vaccination. A majority of work group members felt that the desirable anticipated effects were moderate, and a majority of work group members felt that the undesirable effects were either minimal or small. Lastly, a majority of work group members felt the desirable effects outweigh the undesirable effects and favors change in wording. The next 2 domains will be the last 2 that I will present on today: acceptability to stakeholders and values of the target population. There are many stakeholders to consider with this policy question, and I will provide a brief review in the following slides. The target population for this policy question would be the parents of children and adolescents who are eligible to receive HPV vaccination. An important stakeholder is the American Academy of Pediatrics, which beginning in the 2018 Red Book changed their language to recommending starting the series between the ages of 9 and 12 years. This slide shows the current recommendation. Other stakeholders to consider are the National HPV Vaccination Roundtable and the American Cancer Society. The Roundtable and ACS have supported the dissemination of evidence to support HPV vaccination at age 9. CDC has reviewed the data on this topic as presented previously in the systematic review and does not feel that the data are conclusive regarding the role of the strategy for improving vaccination coverage. The Society for Adolescent Health and Medicine supports adolescent vaccination platforms as a successful strategy to improve health and vaccination coverage for adolescents. Concerns have been raised in reaction to the growing interest in vaccination at age 9 and its potential negative effect on the adolescent platform. Now, I'll highlight findings from the systematic review that captured 5 studies that evaluated providers' perspectives on vaccination at age 9. One study interviewed providers and nurses who participated in an intervention that included vaccination at age 9, and overall, these providers had a positive experience. Interviewees in another small qualitative study in a rural setting had mixed opinions. There were 3 clinician surveys. One survey found that of those not currently recommending at age 9, 61% were willing to do so. Surveys found that provider recommendations differed by specialty, by age group of patient, and by recommendation framing. The work group also reviewed preliminary results from an ongoing RCT that showed that vaccination at age 9 was acceptable to providers and parents. If the wording of the age for routine vaccination were changed to age 9 to 12 years, this may lead to more parents being offered the vaccine for their child at the 9-year-old well child check. We identified only 2 studies in the systematic review that examined parents' perceptions of vaccination at ages 9 to 10 years. While few parents reported receiving recommendations to vaccinate their child before age 11, most reported a willingness to do so. In summary, the AAP recommendations use the wording 9 to 12. Some stakeholders and advocacy groups are interested in vaccination at age 9, and changing the wording will clarify that vaccination at age 9 is consistent with ACIP recommendations. Other stakeholders have raised concerns that changing the wording will erode the adolescent platform. Lastly, in a limited number of studies, vaccination at ages 9 to 10 years was acceptable to providers and parents. Workgroup members felt that changing the wording of the age for routine vaccination to 9 to 12 was acceptable to stakeholders and answered probably yes or yes to this question. For the values of parents, there were few data that the workgroup had available to review. As a result, a plurality of workgroup members responded don't know to the first question. And for the second question regarding uncertainty or variability, a plurality of workgroup members indicated probably not important uncertainty or variability, and a minority indicated probably important uncertainty or variability. So that concludes the ETR presentation for this ACIP meeting. I presented on the first half of the ETR today, and will be presenting the second half of the ETR in the summary workgroup interpretation at the next ACIP meeting. Thank you.
Thank you. I think we have time for one quick question. Dr. Lair.
It's less a question and more a comment. I've never found the adolescent platform to be useful. In New York State, the 6th graders need Tdap, the 7th graders need meningitis. I mix in HPV. Most parents don't want pre-vaccines at once. So I guess if someone wants to defend the adolescent platform for me to understand why they're recommending it, I'd be open to hearing that. Thank you.
Thank you, Dr. Lair. It looks, Dr. Asturias, do you want to respond to that? Or do you...
No, I don't want to respond. I want to, in fact, first to congratulate the working group. I think we have heard a tremendous amount of evidence, and in this area of efficiencies, one dose would almost, half the cost of this program and expose children to less doses of vaccine to get the same protection. And I will concur with Dr. Lauer that I will discourage us from using the word platform. Our job as ACIP members is really to look into the evidence and recommend vaccine at ages when they produce the best benefit at a lower number of doses and always ensuring the safety. So I concur with him in that projection.
Thank you. Ms. Moser?
I think there were data that showed that a lot of the time the HPV vaccine is being given with other vaccines. So even if in certain practices they're not being given together, that doesn't seem to be what was shown in those data. I also think the undesirable effects are being a little bit underappreciated because providers are saying in the surveys that were shown that parents aren't ready for that discussion at age 9. And the data, and this was presented, were limited as to the support that parents were giving related to getting their kids vaccinated earlier. And then I think some of those potential benefits, like better addressing this vaccine on the schedule, could be addressed. And the CDSI question, it seems to me, we should lean on those people to develop CDSI tools that could work with institutions that have different approaches to whether they want to regularly recommend this at 9 or at 11. So I'm not sure that some of those benefits were as hard and fast either.
Thank you. Ms. Moser?
That was Ms. Moser. I think Ms. Lyons had her hand up.
There was another hand up, and I thought they must have dropped off. My apologies.
It was Ms. Lyons.
Thank you. I put my hand down, but yeah, I feel like the adolescent platform is going to be reviewed anyway with meningococcal, so I'm going to caution that that might not be a harm because it's going to be re-reviewed anyway on the basis of another vaccine.
Thank you very much. All right, moving along, we will move to work group next steps. Dr. Markowitz.
Okay, to end the session, I will provide a brief overview of next steps and considerations regarding both of the policy questions under discussion by the work group. The two policy questions being considered, as you heard today, are wording of the recommendation for age at routine vaccination and number of doses in the recommended HPV vaccination series. Regarding the wording of the age for routine HPV vaccination, to review, in October we introduced this topic to ACIP, the historical context, and presented a review of data regarding programmatic aspects of vaccination at age 9 to 10. And the work group's interpretation of the data is that there's no strong evidence of benefit of vaccination at age 9 to 10 compared with vaccination at 11 to 12 for achieving higher coverage. The work group's plan is to modify the wording of routine age to 9 through 12, so it is clear that age 9 is included in the recommended age for those providers who want to start at age 9. And today, Dr. Stefanos presented part of the modified ETR for changing the wording. Because the work group is proposing a minor wording change to the recommendation and not a change to the recommended age, we are not using grade, and the ETR is a modified framework, and in June, part 2 of the ETR will be presented. Regarding the number of doses in the recommended HPV vaccination series, in October we introduced this topic as well and reviewed the main studies providing evidence for reducing the number of doses available at that time. We also reviewed the status of global adoption of HPV vaccination, including one-dose recommendations. And today there were several presentations, including the updated review of data focusing on the main studies providing data, a presentation from Kem Shi, the randomized controlled trial of one-dose vaccination, U.S. HPV vaccination coverage and modeling. And the work group plans to focus on this policy question between now and June and to be able to present additional data to ACIP at that time. Plans for the June meeting include presentation of data from Escudo, a randomized trial of 1 versus 2 HPV vaccine doses. We will also review and present any additional data information requested by ACIP and a full ETR framework, including grade. And if we are ready, we plan for ACIP votes on both of our policy questions at the same meeting. I want to briefly review the study designed for Escudo, the study being conducted in Costa Rica, sponsored by the U.S. National Cancer Institute. This randomized double-blind trial was designed to evaluate non-inferiority of 1 dose compared with 2 doses of bivalent and 9-valent vaccines for prevention of new cervical 16-18 infections in girls aged 12 through 16 years. And to evaluate 1 dose compared with those unvaccinated, there will be surveys of unvaccinated women to allow comparisons of persistent infection in unvaccinated women from the surveys with the vaccinated trial participants. The first data from this trial will be available before the June meeting. And as I mentioned, we plan to consider these data in our deliberations and present them to ACIP. Dr. DeSisto reviewed outstanding questions regarding number of doses, particularly these 3. And to review regarding duration of efficacy and immunogenicity of 1 dose, we have data on efficacy and immunogenicity through 16 years with no evidence of waning protection, and we will have further data from these studies in the future. We do not have any data on efficacy and immunogenicity on protection, I should say, at anatomic sites other than the cervix. And regarding efficacy and immunogenicity of 1 dose in males, of the 16 studies in our review, 13 include only females, and we do not have 1 dose efficacy in males at this time. There is some evidence of lower antibody levels in adolescent males versus females after 1 dose, but the clinical relevance of this finding is not known. At the October 2024 ACIP meeting, We mentioned that Merck's plans for one-dose HPV vaccination evaluation that had been announced in March of 2024. 2 international randomized double-blind efficacy clinical trials are planned, 1 in males and 1 in females. The planned trials include elements that regulators have deemed necessary as listed on this slide. Since 2024 to the present, Merck has been in discussions with FDA and EMA regarding trial design, and regulatory feedback is expected in the second quarter of 2025. If there is an ACIP recommendation for 1 dose at any age or 2-dose vaccination for persons aged 15 years or older, the recommendation would be off-label. The definition of off-label includes recommendations for anything not stated in the FDA package insert or something different from what is explicitly stated in the package insert. And manufacturers can only promote and provide education on FDA-licensed indications. Of note, ACIP has made many off-label recommendations over the years, and at least 46 licensed vaccine products in the U.S. have some off-label recommendation, although most are for specific situations or subgroups. And in the next slide, I will give some examples. We have categorized some types of off-label recommendations here for ease of description. These include recommendations that are off-label because the age is outside of the licensed age range. And examples include recommendations for hematopoietic stem cell transplant patients and other special groups. And there are several vaccines that have off-label recommendations in this category. Recommendations for travelers or in special situations such as outbreaks, where vaccine is recommended at ages younger than the licensed age range, and for catch-up or shared clinical decision-making. There are also modified dosing schedules which are off-label, such as those for persons with immunocompromising conditions, in the case of hepatitis B vaccine, where higher doses are recommended. And there are also modified standard schedules, such as those for rabies vaccination pre-exposure prophylaxis, where the standard recommendation is 2 doses instead of the licensed 3-dose schedule. There are off-label recommendations for inactivated influenza vaccine for use in persons with egg allergy, which is not in the label, and Tdap use in pregnancy to prevent pertussis infection in infants, while no longer off-label, was for over 10 years. The HPV vaccines workgroup is considering options for modification to the current recommendations, and various options are still being discussed as data are reviewed. Regarding 2 doses, one option is expanding a 2-dose recommendation from 9 through 14 to 9 through 26, or through an older age. Alternatively, the workgroup is discussing recommending 1 dose for some age groups. This could be for those aged 9 through 14, 9 through 20, or through an older age. Next slide. And just to get a bit more specific about these so the ACIP members know what's being discussed, if there's an expansion of a 2-dose recommendation, the recommendation could be a simple 2-dose schedule for everyone aged 9 through 26 years, with 3 doses still recommended for older ages, or 2 doses for all ages. If there is a 1-dose recommendation, the recommendation could be 1 dose for 9 to 14-year-olds and 3 doses for older ages, 1 dose for 9 to 14-year-olds with 2 doses for older ages, or 1 dose for 9 to 14-year-olds with various combinations of 2 or 3 doses for older ages, and one example is listed on the slide. The upper age for these different recommendation options would be based on available data, expert opinion, and programmatic considerations. And if there's a recommendation for 1 dose for 9 to 20-year-olds, the upper age in Kenshi, there could be 3 doses for all older ages, 2 doses for all older ages, or various combinations of 2 and 3 doses for older ages. And again, one example is listed on the slide. or 1 dose could be recommended through age 26 with 3 doses or 2 doses for older ages. All workgroup members are in favor of some change to the number of doses in the HPV vaccination schedule. Workgroup members have different opinions about expanding the 2-dose schedule and or moving to 1 dose in some age groups. The workgroup continues to review data and discuss the upper age range if there's a 1-dose recommendation and or if the 2-dose schedule is expanded beyond age 9 through 14 years. So I want to end by asking ACIP members if they have any questions or comments regarding the policy questions to be addressed, and what additional information would ACIP like to see before potentially voting at the next meeting beyond what we've already outlined will be presented. Thank you.
Thank you very much. Dr. Milliman, you've been very patient.
Thank you very much for recognizing me. I just wanted to make sure I made a comment about the importance of platforms for adolescents. We have platforms for young babies and children that we have not touched and have allowed to become really strongly ingrained in the anticipatory guidance and comprehensive healthcare for children. And I think they really strongly speak to the care that we give our children. I think the same is true for adolescents, and I will give you some data. I don't want to rely on anecdotal data if someone does or doesn't feel that the platform works. If you look at the NCQA data from the State of Healthcare Quality Report from 2007, you can see that immunization rates for adolescents from 1998 to 2006 went up from 10.5% for the combination of vaccines before the new adolescent medicine vaccines were recommended, from 10.5% among commercial payers to 57.7% by 2006. This is 4 years after the Omnibus VFC program was provided, and I think it shows that the actual formation of the platform really helped us improve immunization rates significantly for adolescents. There's also some new data from ZIMIT, which will probably be published soon, hopefully, that shows that a lot of parents actually do feel that the anticipatory guidance and the understanding and expectation of vaccines at specific times is meaningful for them. So I look forward to seeing those data published. So I just want to make sure that when we discuss the platforms, we really discuss them both in the context of the data that exists. It's really hard. Obviously, we don't have a randomized controlled trial of no platform versus platform, but I would like to look at them in the context of data that exists and also look at them in the context of what we know works for younger children. So I really appreciate you letting me speak. So thanks so much.
Absolutely. Thank you, Dr. Middleman. Ms. Arthur?
Thank you so much, Dr. Howitt. I think just a few comments with regard to some of the things Dr. Markowitz presented around the fact that the company itself is, just like it did for the change from 3-dose to 2-dose, pursuing as well the FDA indication, which is so important in terms of alignment between the different agencies that oversee vaccines, right? Between the FDA and the ACIP CDC process. So I think that it's important to note the company is pursuing a lot of data that came up during the conversation today, particularly looking at efficacy in males of 1 dose and some of the other issues that would be important for decision making. So I think it's just important to note that consistency in the evidentiary standards is important, and that we hope that folks will look over some of the different comments that were made about the importance of using all the best evidence in making this decision. Thank you for the opportunity to comment.
Thank you, Ms. Lyons.
Thank you. I would just like to encourage the work group to review the very few number of states that require HPV, just to make sure that going to a 1-dose series or any other changes will not impact any school laws.
Thank you. Dr. Lair?
Thank you. To answer the questions on the screen here, My sense is that I'm comfortable that the dosing at a younger age provides better protection. There is a slide in the first presentation on that. I'm also comfortable that a one-dose schedule has a lower seropositivity rate, but what I don't know is whether that's clinically relevant. And Dr. Kim implied that the herd effects are more important than the seropositivity. So I guess I would be more comfortable moving towards fewer doses, even though it might have lower seropositivity, if I was comfortable and there is any evidence that that was less relevant and less clinically relevant. So that would be what I would like to see, if that could be, information on that could be found. Thank you.
Absolutely.
I just wanted to clarify, this is Lori Markowitz. I think what Dr. Kim meant was, she was talking about the efficacy estimate, that because herd protection is so strong, if there's a small decline in efficacy, it will be compensated for by this very strong herd protection that we see in HPV vaccination programs. The issue about seropositivity or the antibody titers, we don't really have a minimum antibody titer that we have identified as being protective, so that even though the GMTs, the geometric mean titers, or the concentrations are lower with one dose than with 2 or 3 doses, the clinical relevance of that is really questionable, because we have efficacy data, which you saw today from Kenshi, and also we have from the Costa Rica vaccine trial and from the IARC India study showing that efficacy is very high with 1, 2, or 3 doses. So I just wanted to move away from the antibody titers for a minute.
Thank you.
Thank you. It's very helpful. It's an amazingly complex issue. Dr. O'Leary.
Yeah, thanks. I just wanted to respond to my friend Dr. Middleman's comments on the platform. As you mentioned, the American, and I represent the American Academy of Pediatrics, and as you mentioned, the American Academy of Pediatrics does recommend vaccination at 9 to 12. And I still am yet to see any compelling evidence supporting this concept of the platform. And really, as I've come to think about it, and I would say I think there is a lot of observational evidence that, or observational data suggesting that it may be a good idea to do it, to at least allow for vaccination at age 9 to 10. But ultimately, the way I've come to think about this policy question is this is really the only circumstance that I'm aware of where the wording in the ACIP recommendation represents a barrier to vaccination, by not really emphasizing the flexibility of age 9 to 12. Over.
Thank you very much. Dr. Middleman.
Sorry, I just wanted to add, I think that what the Society for Adolescent Health and Medicine, at least, is most concerned about is following the evidence. So I think if the evidence is strong in one way or the other, then it would make sense to consider a change. But the concern is that the evidence isn't quite there yet, and the potential detrimental effects, I guess that it's hard to prove that either. So I think that while I appreciate my colleagues' concerns, and I do too, I think that I obviously want more people to get HPV vaccine. So I just want to make sure that we're not creating a problem that could affect not just HPV vaccination, but weaken the platform for the other vaccines, and also make sure that we're following the evidence, because I don't think the wording that exists currently in any way discourages anyone from getting vaccinated. I'm sorry, that was very long-winded, but thanks again for letting me talk.
Thank you, Ms. Moser, and then we'll close this out.
I think what everybody's saying is the same thing, and we need to remember when we're framing this conversation that we're not talking about changing the recommendations. We're talking about changing the wording of the recommendations, which means fundamentally this is a communications question. And if we change this wording on a vaccine that has already had some pushback because parents aren't comfortable with the fact that it prevents against a sexually transmitted disease, we could be doing ourselves a disservice in the larger scope of HPV uptake. So I think it's less about the platform, albeit there are data that show people are getting that vaccine when they get the other vaccines. But it's more a consideration that everybody needs to consider, what do they think parents and providers are going to say when we have a wording that's different that says that 9-year-olds should be getting this vaccine. They already can do that. So it's more what is going to be the impact of the change in wording beyond to the uptake.
Thank you, greatly appreciated. We have 2 more sessions to go, and I appreciate everyone hanging in there. We are going to start talking about CMV vaccines, and Dr. Jameson is going to introduce the topics.
Great, thank you so much. I assume you can hear me?
Perfectly.
Okay, great. So on behalf of our work group, we're really excited to launch this group and set the groundwork for what we hope is a forthcoming CMV vaccine. Next slide. So we just wanted to acknowledge the work group members. Thanks to the my co-chair, ACIP member, Dr. Maldonado, who can't be on today. Thanks to the liaisons, the ex officio members, the consultants, and a very special thanks to the CDC staff. Dr. Lanzieri and Sugarman are incredibly knowledgeable and enthusiastic about this topic, so thank you. And I actually misspoke. Dr. Maldonado is my co-ACPI member, work group member. Next slide. And thanks to the CDC staff on the next slide. Thanks to the additional CDC staff as well. So the outline for today's presentation, Dr. Lanzieri is going to talk about the epidemiology and disease burden of CMV. Dr. Paris from Moderna is going to talk about vaccine safety and immunogenicity data. And then turn it back over to Dr. Lanzieri for the work group considerations for CMV vaccine policy, and then we'll have some time for discussion. So with that, I will turn it over to Dr. Lanzieri.
Thank you, Dr. Jameson. Good afternoon. I'm Dr. Tatiana Lanzieri, and I am the co-lead for the CMV vaccine work group. It's not going. Today, I will begin with a review of the epidemiology and disease burden of CMV and CCMV. Congenital CMV, or CCMV, is the most common infectious cause of birth defects in the United States, with more than 16,000 children born with CCMV infection each year. Yet, most people have never heard of it. CCMV is also the leading non-genetic cause of hearing loss in children. And based on a meta-analysis of 30 studies with newborn screening and follow-up of infected infants identified, we estimate annually CCMV causes 80 neonatal deaths and nearly 3,000 cases of CCMV disease, which includes long-term outcomes such as sensorineural hearing loss, cognitive or motor impairment. Congenital CMV disease may manifest with neonatal signs at birth, such as a rash, an enlarged liver or spleen, or a small head. CCMV is diagnosed mainly by PCR or culture on urine, blood, or cerebrospinal fluid collected within 21 days of life.
However, most newborns with CCMV infection have no clinical signs at birth and are not diagnosed. To increase identification of newborns with CCMV infection and at risk of neurodevelopmental disabilities, some U.S. states have implemented targeted or universal screening for CCMV. And this figure depicts the U.S. landscape on newborn screening and surveillance for CCMV. Shown with a dotted blue outline are the states with universal newborn screening, Minnesota since 2023 and Connecticut to begin this year. 11 states outlined in black conduct targeted hearing screening, which began in Utah in 2013. Additionally, 3 of these states, Utah, Florida, and Virginia, also conduct symptom-based screening, shown with a red circle around the state initials. In the U.S., 13 states are currently conducting CCMV surveillance, and these states are shown in yellow. Although we don't have data from newborn screening or surveillance from all states, we estimate that CCMV prevalence likely varies across states due to differences in distribution of the live births by maternal age and other demographic characteristics, as well as population-specific CMV seroprevalence. Highest CCMV prevalence is estimated for states represented in yellow. This slide shows data from the U.S. National Health and Nutritional Examination surveys from multiple years. Overall, the graph shows that CMV IgG seroprevalence increases with age. Data from the 90s and early 2000s in blue and orange bars showed that seroprevalence among persons 6 to 49 years of age had no significant changes over the 2 decades. In contrast, more recent data show that from 2011-2012 to 2017-2020, CMV seroprevalence among children 1 to 5 years increased from 21 to 29%. To understand current CMV seroprevalence in all age groups, serological testing for persons 6 to 59 years in the NHANES 2017-2020 pre-pandemic is ongoing. This graph now shows CMV IgG seroprevalence by race and Hispanic origin. Seroprevalence is higher among non-Hispanic Black and Hispanic women as compared to non-Hispanic white women. Among women 20 to 29 years, CMV seroprevalence is 36% in non-Hispanic white and 77% to 81% in non-Hispanic Black and Hispanic. And why is this important? Seronegative women are susceptible to primary infection during pregnancy, and seropositive women might experience a higher rate of infection and reinfection. The risk of vertical transmission and CCMV disease varies with the type and timing of maternal infection. In this table, the second column shows the risk of vertical transmission. With primary infection, the risk of mother-to-fetus transmission increases by trimester, while the likelihood of symptoms at birth, hearing loss, or other abnormalities, shown in the third column and fourth columns, drops as pregnancy progresses. Maternal infection in the first trimester can result in fetal infection in about 37% of cases, but has the highest risk of symptomatic disease and related abnormalities if transmission occurs. Non-primary infection in seropositive women seems to have a much lower transmission rate, but data are scarce. In one study, vertical transmission was 3%. However, if transmission occurs, especially in the first trimester, non-primary maternal infection can also result in CCMV disease and related abnormalities. These data imply that a CMV vaccine would need to be given before pregnancy to provide protection against vertical transmission following primary infection, particularly those occurring in the first trimester, which are associated with more severe outcomes. Protection against non-primary infections is also desirable. So how often do primary and non-primary CMV infections occur? In the US, primary infection rates range from 0.4 to 7% and reinfections up to 10%, depending on the population and how it was assessed. Primary infections are typically diagnosed by IgG seroconversion or low avidity IgG, but serological screening is not recommended during pregnancy. In highly seropositive populations, such as in Brazil, the annual rate of primary infection is 20% and reinfections 9 to 35%, much higher than the US and other countries. Non-primary infections are challenging to diagnose. Assessment of IgG seroconversion to new strains in people who were already CMV IgG positive has been mostly done in research studies. And consistent with high infection rates leading to high maternal seroprevalence, high infection rates also lead to higher CCMV prevalence at birth. That's why CCMV prevalence is typically higher in populations with higher maternal seroprevalence. This table contrasts data from France and Brazil. In France, where maternal seroprevalence is about 60%, CCMV prevalence was 3.7 per 1,000 live births. In Brazil, with almost 100% maternal seroprevalence, CCMV prevalence was higher at 5.7 per 1,000. Although in both studies the risk of delivering an infant with CCMV was higher among women who were CMV seronegative before pregnancy, as shown in the fourth column, 4 times in France and 6 times in Brazil, non-primary infections contributed a much higher proportion of congenital infections when maternal seroprevalence is high. Factors such as maternal age and number of children also influence CCMV epidemiology. Modeling U.S. data on CMV IgG, IgM, and low IgG avidity seroprevalence, live birth distribution by maternal age and parity, and transmission rates by pregnancy trimester, we estimate about 12,000 or 75% of the cases of CCMV infection to be attributable to primary maternal infections. Now, let's shift to how women acquire CMV infection. Young children have a critical role in CMV transmission. They shed large amounts of virus in saliva and urine for months after primary infection in infancy. CMV excretion in children peaks at 1 to 2 years of age, and this time coincides with a second pregnancy for about 1/3 of first-time mothers in the U.S. Thus, based on modeling, a vaccine with short duration of protection given to infants could impact transmission to pregnant mothers and decrease CCMV transmission, CCMV infections by 85%. And as you can see in the last column, predictions vary widely depending on the population to be vaccinated, vaccine efficacy, duration of protection, and coverage. We plan to present a critical review of these models in the future. And in summary, the epidemiology of CMV and CCMV is complex, and there are several unknowns. In the United States, we estimate nearly 75% of CCMV infections are due to primary maternal infection, whereas globally, most CCMV infections are due to non-primary maternal infection. An effective CMV vaccine could prevent or reduce the CMV disease burden. If given to women, it would require long-lasting immunity to ensure protection before pregnancy and throughout childbearing years. If given to toddlers, vaccination could provide indirect protection to pregnant women, thereby reducing the burden of CCMV. And I'd like to thank the ACIP work group for the discussions we have had, and thank you for your attention.
Thank you. I think we have time for one question before we move on. All righty. Hang in there, y'all. You're doing great. So we're going to move to CMV vaccine safety and immunogenicity data by Dr. Paris.
So good afternoon. My name is Rob Paris, and I'm the therapeutic area head for Moderna's latent virus portfolio, which includes our CMV vaccine. I really appreciate the opportunity to review our program with you today. I will speak briefly about the unmet medical need. Sorry, I'm still waiting for our slides to show up. Sorry, just give us a minute. We're on slide 2, Stephanie.
Okay, thank you.
So I will speak briefly about the unmet medical need for a CMV vaccine and an overview of our clinical development program. The focus of today's discussion will be the safety, reactogenicity, and immunogenicity data from our phase 2 trial. I will also finish with describing the phase 3 trial design and provide an update on its current status. Our rationale to develop a CMV vaccine is ultimately to impact the global burden of congenital CMV. As just reviewed by Dr. Lanzieri, CMV is the most common congenital viral infection and the most common infectious cause of childhood deafness and hearing loss. It is also a major under-recognized cause of miscarriage, stillbirth, and preterm birth and infant death. Globally, the annual estimated incidence birth prevalence of congenital CMV ranges from 1 in 70 to about 1 in 208 births, while in the US, congenital CMV occurs about 1 in 200 births, which results in an annual healthcare cost of about $6 to $7 billion. Management of CMV is challenging due to the limited prevention, screening, and treatment options available. Therefore, congenital CMV remains a major unmet medical need and a high priority for vaccine development, as recognized by the WHO, the U.S. National Academy, and others. Among infants with congenital CMV, 10 to 15% are clearly symptomatic at birth. Of these, about 5% will die during that neonatal period. About half of them will go on then to develop a long-term disability. In addition to hearing loss, this can include cognitive impairment, developmental delay, and seizures. Even among infants with no clear signs and symptoms of CMV at birth, 10 to 15% will also develop long-term disability, most commonly hearing loss. Overall, this results in about 1 in 5 infants with the congenital CMV who will develop a long-term disability. The current focus of our clinical program is to demonstrate efficacy for the prevention of CMV infection in CMV seronegative women. To that end, we will vaccinate women of childbearing age prior to pregnancy, since there is a high risk of viral transmission to the baby when the mother is infected during pregnancy. Vaccination to prevent CMV infection prior to pregnancy is important because the risk of long-term complications in the baby is highest in this first trimester. However, the relatively low incidence of congenital CMV, particularly these longer-term clinical outcomes, would require the conduct of a lengthy phase 3 trial with a very large sample size, which makes this approach somewhat impractical. Based on these observations, we have chosen to seek an initial indication to prevent CMV infection in females 16 to 40 years of age, regardless of their CMV serostatus at the time of vaccination. Moderna's CMV vaccine was designed to elicit humoral and cellular immunity to prevent CMV infection, a virus which has broad cellular and tissue tropism. mRNA 1647 is composed of 6 mRNAs, 5 of which encode proteins that assemble intracellularly to form the pentamer, which is required for CMV infection of many cell types, but primarily epithelial and endothelial cells. A single mRNA encodes glycoprotein B, which mediates fusion of the virus during cell entry and is required for viral infectivity in all cell types. Both humoral and cellular immune responses to these antigens have been observed in CMV infection. In addition, 43 to 50% vaccine efficacy was observed for a primary infection endpoint in separate adolescent and adult female phase 2 studies for an adjuvanted recombinant GB vaccine. With the addition of the pentamer glycoprotein in our vaccine composition, we expect to see improved efficacy compared to these prior studies. Clinical development was initiated with a first-in-human dose-ranging trial in healthy adults in 2017. This was followed by a phase 2 dose selection study. Both of these studies have been completed. In the interest of time, I will summarize our phase 1 trial and then provide an overview of our phase 2 results, which will include more recent data from an ongoing extension study to assess the durability of immune responses. The phase 1 trial was a randomized, double placebo-controlled study assessing dose levels between 30 and 300 micrograms and was conducted in healthy 18 to 40-year-old female and male adults. 154 participants were enrolled, with a little over half CMV negative. mRNA 1647 was generally well tolerated and no safety concerns were identified. Neutralizing and binding antibody responses were observed in both CMV negative and positive participants, as well as cell-mediated immune responses. Overall, the phase 1 trial results supported further development of mRNA 1647 and enabled dose selection using a narrower dose range. In the phase 2 study, participants were randomized 3-to-1 to receive either mRNA 1647 or placebo on a 0 to 6 month schedule. We enrolled 315 18 to 40-year-old adult participants with about 70% CMV negative and who were followed for approximately 12 months after their last vaccine dose. Based on the phase 1 results, we assessed 50, 100, and 150 microgram dose levels in part 1 of the study. Part 2 of the study was conducted to capture additional safety and immunogenicity data for the 100 microgram dose level. The primary objectives were safety and neutralizing antibody responses. I will focus on the results for the 100 microgram dose level today, which was the dose selected for testing in the phase 3 efficacy trial. Solicited local reactions were self-reported by participants within 7 days for each injection. The most common local symptom was injection site pain, which was reported by a little over 80% of participants. Axillary swelling and tenderness in the vaccinated arm was the second most common local reaction. Reactions were mostly grade 1 or 2 and lasted between 1 and 3 days on average. For systemic reactogenicity, headache, fatigue, and myalgia were the most commonly reported reactions. Symptoms were reported more frequently for the second and third doses compared to the first. Similar to the local reactogenicity results, symptoms were mostly observed within 1 to 2 days after vaccination and lasted 1 to 2 days. For unsolicited adverse events, the overall incidence of AEs was similar for vaccine and placebo groups within 28 days after dosing. Please note that the data were combined for all dose levels on this slide. As I speak to the slide, you will also see the applicable row highlighted in yellow. There was one serious adverse event in the vaccine group that was considered unrelated to study injection. this participant was unfortunately diagnosed with cancer about 1 month after the first study vaccination. There were no deaths in the study. There were more medically related attended and grade 3 AEs in the vaccine recipients, the majority of which were injection site associated conditions, which were self-limited. There were 7 participants in the vaccine group and 1 placebo participant who discontinued from further vaccination due to an adverse event, but remained in the study with safety follow-up. No participant discontinued from the study due to an adverse event. Neutralizing antibody assays for CMV vaccines have historically used a fibroblast cell-based assay. However, this assay does not effectively measure antibodies responses specific to the pentamer, since fibroblast cell lines don't express the key cellular receptor which captures pentamer-mediated viral entry. Therefore, we chose to utilize 2 different neutralizing antibody assays to assess the responses to the 2 vaccine antigens: an epithelial cell assay, which captures pentamer-mediated entry, and the fibroblast assay to assess the response to GB. Cell-mediated immunity is also likely important for an effective vaccine. However, CMI analyses are ongoing at this time, and no data will be presented today. On this slide, we show neutralizing antibody results for the CMV negative participants. Neutralizing antibodies against epithelial cell infection are on the left, and fibroblast infection is on the right. Data for the vaccine recipients are shown in blue and placebo in gray. The horizontal dotted line is the geometric mean titer for each of these assays of the entire seropositive cohort at the start of the study, which we included as a benchmark for comparison. For epithelial neutralizing antibodies, administration of mRNA 1647 resulted in a response after the first dose that was boosted after each subsequent injection. GMTs exceeded the seropositive benchmark after the second and third doses and persisted above this benchmark through month 18. For fibroblast infection on the right, peak response was after the second dose and did not seem to increase substantively after the third dose, but did persist well above baseline through 18 months. On this slide, we show the results for the CMV seropositive participants. On the left, again, antibodies against epithelial cell infection increased approximately 17-fold over baseline after the first dose. On the right, neutralizing antibodies against fibroblast infection increased about 2.4-fold over baseline. The second and third doses did not appear to substantially increase antibody titers over what was observed after the first dose. However, neutralizing antibody GMTs remained above the seropositive baseline GMT through the end of the study. Demonstration of durable immune responses will be key supporting data for vaccine implementation. As such, we are assessing long-term immune responses in follow-up studies for both the phase 2 and the phase 3 trial, which will also assess the durability of efficacy. Participants completing the phase 2 trial were offered enrollment in an extension study that will provide an additional 3 years of follow-up for immunogenicity. We recently conducted an interim analysis on data generated up to 36 months after vaccination. Here we show the results for the epithelial cell neutralizing antibody levels in the seronegative cohort. As you can see in the figure, a durable immune response was demonstrated through 3 years after their first vaccination. The left side of the figure shows phase 2 data through the month 18 as shown on the previous slides, with the additional data shown at the 24, 30, and 36-month time points. Importantly, the GMT remains stable from 18 to 36 months. This figure shows the neutralizing antibody response to fibroblast infection in seronegative individuals. As with epithelial cell infection, persistence was demonstrated through 3 years of after vaccination as GMTs remained largely unchanged from 18 to 36 months. Similar results were also observed for the seropositive cohort, which are not shown. In summary, the results of the phase 2 trial showed mRNA 1647 is immunogenic and generally well tolerated with no safety concerns. Vaccination elicited or boosted neutralizing antibody responses in both CMV negative and CMV positive vaccine recipients. In addition, both epithelial and fibroblast neutralizing antibodies were durable through 3 years after vaccination. The phase 3 pivotal efficacy trial is a randomized observer-blind placebo-controlled study in enrolled females 16 to 40 years of age. CMV negative and positive participants were enrolled at approximately a 4-to-1 ratio based on sample size calculations for the primary objective endpoints. CMV positive participants were enrolled to assess safety and immunogenicity to support our initial indication for vaccination. Regular contact with at least one child under the age of 5, which is known to increase the risk of CMV infection, was also an inclusion criteria for CMV negative participants who were 20 years and older. A positive pregnancy test at screening was exclusionary, and participants were tested for pregnancy before each vaccine or placebo administration. Participants were randomized 1-to-1 to receive either 100 micrograms of mRNA 1647 or placebo with the same 0 to 6 month schedule, with 2 years of follow-up after the third dose to ascertain efficacy endpoints. The primary objective of this trial is to assess vaccine efficacy against primary CMV infection in the seronegative cohort. The primary endpoint is established by seroconversion from a negative to a positive serum CMV IgG result. Participants have periodic serology testing every 3 months, starting 28 days after last vaccination through the end of the study. Immunogenicity is a key secondary objective and will use the same endpoints and assays as utilized in previous studies. In addition, we are assessing the frequency of CMV shedding after seroconversion based on the detection of CMV DNA by PCR in longitudinal urine samples. CMV shedding will also be assessed in the CMV positive cohort throughout the study, starting after the first vaccine or placebo dose. The study is being conducted in 16 to 40-year-old females in 290 sites in 13 countries, as shown here on the map. Enrollment began in October of 2021 and was completed in October of 2023. Almost 7,500 participants are enrolled and with vaccine or placebo administration completed. About 80% of participants are CMV negative, in line with the study design I mentioned previously. The study has 2 planned efficacy analyses. The predefined criteria for meeting the study primary endpoint is to demonstrate that the lower bound of the confidence interval for vaccine efficacy is greater than 25%. An interim efficacy analysis was completed after a pre-specified number of primary endpoints was reached. This unblinded data was reviewed by an independent data and safety monitoring board in December. The DSMB did not identify any safety concerns and reported that the primary endpoint was not met at this interim analysis and recommended the study to continue as planned. The final efficacy analysis is anticipated by the end of this year, the timing of which will depend on the rate of primary endpoint accrual. In summary, just to highlight, Moderna and study investigators remain blinded to all study data in the phase 3 trial. In summary, we have observed mRNA 1647 to be generally well tolerated with no safety concerns identified in our phase 1 and 2 studies or by our independent phase 3 DSMB. mRNA 1647 has elicited strong functional antibody responses that persist through 3 years after vaccination. Our phase 3 pivotal efficacy trial in CMV negative and positive female participants is ongoing, with the final efficacy analysis anticipated by the end of this year. I want to thank you very much for the opportunity to present today. I would also like to thank everyone who has worked tirelessly on this program with the goal of developing a safe and effective vaccine for this potentially devastating disease. Most importantly, I would like to thank the trial participants. My colleagues and I would be happy to take any questions that you have at this time.
Thank you. Do we have any questions? Dr. Shaw?
Yeah, thanks very much. Really interesting presentation. I had a question in that I believe that there have been previous studies utilizing kind of a subunit vaccine, not an mRNA vaccine, containing a pentameric complex and glycoprotein B ectodomain in a non-human primate model for CMV infection where despite very high neutralizing antibody levels, there was still substantial horizontal transmission. So I was wondering if you could comment on that, whether the hope is that the mRNA platform will, or having this in humans will work better. And I guess the second question I had is related is that, do you know which of these antibody responses are required to prevent vertical transmission to the infant? Thanks.
Let me start with the second question first, because that's the easiest to answer. And I think, in short, I don't think we understand what is the appropriate antibody response or the dominant antibody response to prevent vertical transmission. With respect to comments on the non-human primate study, I'm familiar with that study that was performed. I believe it was performed by Pfizer, if I remember correctly, where they assessed a recombinant pentameric vaccine with GB. And I think that there was some limitations of the study design being the type of transmission model, but perhaps let me call on we have a virology expert who's quite familiar with the study here, Kai Wu, who might be able to comment further.
Yeah, in that study, preclinical study, rhesus macaque CMV was used. Despite rhesus CMV is similar, belonging to the same beta herpes virus family, the pathogenesis of rhesus CMV may be somewhat different than the human CMV. The challenge in the CMV scientific community is that we cannot use human CMV to infect animals. Therefore, that study was conducted using the rhesus-specific CMV. So that's one of the major challenge in the scientific community when evaluate the animal data to the human.
Okay, thanks.
Thank you, Dr. Zucker.
I think, okay, thank you. So thank you for the presentation. I think my question maybe has more to do with sort of trying to understand the immunology of CMV. And from what I'm hearing, it sounds like there's no correlate of protection. Is that correct?
That is correct.
Okay. And so given women who are seropositive, right, can get reinfected. So I'm trying to understand what the expectation is, because if women who are already seropositive are vaccinated, is that expected to prevent further reinfection, or they would be just, at risk again if they were re-exposed of another infection?
Right. So we've chosen deliberately to include seropositive participants in our clinical development program, largely, as you mentioned, that they still carry a significant risk of transmission, vertical transmission with reinfection or reactivation. I mean, there's belief now that most of these events are probably due to reinfection. There's been a longstanding discussion in the field is how do you demonstrate impact on reinfection? And currently, there is very limited, research tools with which to do this with that are probably not, fit for purpose for a phase 3 trial. To that end, I think ultimately, we would see this as an expansion of our clinical development program post-licensure, where we would assess a real-world effectiveness study, the clinical impact on congenital infection and disease in populations that include both CMV negative and positive women. The other point I would make is that we don't know the biological significance of this, but we do feel that if we do see a decrease in shedding, perhaps this is compelling information that would lead us to believe that we may be successful against somehow limiting viral replication in the mothers and then subsequent transmission in those mothers who are already seropositive at the time of pregnancy.
Yeah, sure. And just maybe one last question. right, if I remember, there were about 1,800 women who would be seropositive. What do you expect the sort of incidence of shedding to be over the course of the study?
Yeah, so we expect, I think the point prevalence at any time point with someone who's CMV positive, it really depends upon how recently they were infected. It's somewhere around probably between 5 and 20% in range. And we do monitor this on an ongoing basis. We are seeing this, and we are collecting the specimens with some frequency with which we expect to detect a significant frequency of viral shedding in this population.
Okay, thank you.
Thank you. And just, Dr. Zuger, you brought up a very good point, which I did not mention earlier today. We actually let all of the voting members ask questions first and then move out to our ex officios and liaisons. So you were next, I promise. Dr. Asturias.
Yeah, thank you, Dr. Pars. So two questions here. One related a little bit to Jane's, in a sense that have you, in this issue of reinfection, have you tested these antibodies to see if they neutralize other, or what diversity of strains of CMV do they neutralize? That's the first question. The second is, I know that you told us that you will not be presenting data on the cellular immunity from the phase 2, but any hints that you have from the phase 1 study on the cellular immunity development? Over.
Yeah, I'll answer the questions in order this time. So the first question is an important one, and it's one we've assessed, and there is actually a paper published in the Journal of Virology showing our assessment, at least from our phase 1 trial data, assessing sort of wild-type contemporaneous clinical strains of CMV to assess the breadth of neutralization for this vaccine, and found that there really was not an impact on differences in these viral strains with respect to neutralization. The second question is we have seen the induction of T-cell immunity in our phase 1 trial, largely using an ELISpot assay. And we're currently evaluating this data using a more contemporaneous in ex vivo intracellular cytokine assay, which we hope to be presenting data at an upcoming meeting with some evidence to support, the T-cell responses both after vaccination and then with time up to 12 months after vaccination. So we do suspect that, like our other mRNA-based platform vaccines, that we will see some robust T-cell immunity.
All right, that sounds great. Thank you so much. We'll move on to the initial work group considerations.
So earlier today, I talked about CMV and CCMV epidemiology and disease burden, and just now, Dr. Paris presented data from the phase 1 and 2 trials of Moderna's CMV vaccine candidate. Now I'm going to present initial considerations of the work group for CMV vaccine policy. The first consideration is that the burden of congenital CMV is substantial, yet awareness is low. There will be a need to assess vaccine acceptability among the general public and providers, as well as the feasibility of implementation among providers. The second consideration is the complex epidemiology. Primary maternal infections, which depend on the population susceptibility level, have a higher risk of transmission, are estimated to cause most CCMV infections in the U.S. and result in more severe CCMV disease if occurring in the first trimester of pregnancy. Therefore, vaccination before pregnancy and long-lasting protection throughout childbearing years would be needed. CMV seroprevalence increases with age, but certain groups of the population already have high seroprevalence by adolescence. The Moderna CMV mRNA vaccine candidate encodes the CMV-GB and pentamer complex with a 3-dose schedule within 6 months. The ongoing phase 3 trial included 7,500 non-pregnant females 16 to 40 years of age, with about 5,000 CMV seronegative at enrollment. The seronegative group will be evaluated for the primary endpoint of vaccine efficacy. Safety and reactogenicity will be assessed in all participants. Participants will be followed for 24 months after the third dose, with an extension to 48 months for a subset of the cohort. The work group discussed data from Moderna's mRNA 1647 vaccine phase 1 and phase 2 trials, and initial interpretation was that apparently there are no safety concerns. Regarding immunogenicity, there is a need to better understand differences in neutralizing antibody levels against epithelial cell and fibroblast entry, and also to understand cell-mediated immune response with vaccination, such as antibody-dependent cellular cytotoxicity and phagocytosis. Regarding long-term protection, some data from phase 2 extension studies show antibody persistency through at least 3 years after dose 1, but it will be important to know if protection will last throughout childbearing age years. There are several additional considerations. Moderna's planned vaccine indication is for non-pregnant females 16 to 40 years, regardless of serostatus, given in a 3-dose series within 6 months. The ongoing clinical trial will assess efficacy only for primary infection among initially CMV seronegative subjects. Data on duration of immunity will be limited, and it's needed to ensure protection before pregnancy and throughout childbearing years. We will not have efficacy data against vertical transmission, CCMV infection, or disease, which is what ideally the vaccine would prevent, but would require a much larger and longer study. A better understanding of correlates of protection against vertical transmission is needed, and though the trial will look at the safety and reactogenicity in CMV seropositive subjects, the benefit to this group is yet unknown, while serological testing prior to vaccination would pose significant implementation challenges. Additionally, groups considered for vaccine recommendations might change as data from future clinical trials become available. So today we reviewed the public health burden, initial phase 1 and phase 2 data on the CMV vaccine, and initial considerations of the work group for CMV vaccine policy. Over the next several months, the CMV work group will continue to review the data as they become available and fill in additional domains of the evidence to recommendation framework. And to conclude this session, some takeaway messages. An effective CMV vaccine could reduce the disease burden. We estimate over 16,000 children born with CCMV infection in the U.S. each year, nearly 3,000 with CCMV disease. An mRNA 1647 CMV vaccine candidate has shown to be safe and immunogenic in phase 1 and 2 studies, and efficacy data on prevention of primary CMV infection in CMV seronegative women 16 to 40 years of age from ongoing phase 3 trial are expected next year. The vaccine would need to be given before pregnancy to ensure protection against CMV infection and reduce vertical transmission, particularly in the first trimester, which is associated with more severe outcomes. Protection against non-primary infections is also desirable. The low awareness of CCMV and potential need for serological screening before vaccination might pose implementation challenges. Finally, the CMV ACIP work group will meet regularly to review data and develop CMV vaccine policy options. And I'd like to acknowledge the AC work group members and CDC staff for all the work. Thank you.
Thank you. Any questions? Dr. Shaw.
Yeah, thanks very much. I guess you alluded to a little bit on one of your slides, but I was wondering, and this is a question for the work group or possibly for Dr. Paris about potential plans to test this vaccine or others in the context of transplantation, where reactivated CMV disease is still kind of a big deal, and the argument could even be made in the context of the aging immune system, where reactivation of CMV is so frequent it can substantially skew the repertoire, particularly of CD8 T cells. So more of a question, I guess, about transplant, but questions about any plans or information on ongoing studies in that vein.
Do you want me to take this?
Yes, please.
Yeah. So this is Bob Paris again. So to answer your question, I about transplant, I would say yes. This is an active part of our program. We are currently conducting a study with in the setting of hematopoietic stem cell transplant. People being vaccinated after they've received their bone marrow transplant. That study is currently enrolling and ongoing, but we recognize as CMV as being an important, potentially unmet medical need in that population of both stem cell as well as solid organ transplants. I think that's the first question. The second is around this association between CMV and its impact on aging and the immune response. I mean, this is an area we've had, I think, pretty robust discussions on how we approach that, but we would certainly welcome the work group's input on that, on how we might potentially address that as an important another sequelae of CMV infection as we look to an aging population.
Thank you. All right, before we move on to the U.S. meeting, I wanted to swing back around and check in on some of our liaison representatives because I know they joined late, and then we can move on to our session on measles. Was someone from the American College of Nurse Midwives present? American College of Obstetrics and Gynecologists?
This is Kevin Alt, and Dr. Joseph was here earlier in the day, and I've been on since about noon.
Perfect. Great to hear your voice again. America's Health Insurance Plans? American Osteopathic Association? And then Association of State and Territorial Health Officials. All right, measles.
Osteopathic present. Sorry, I could not get in.
Oh, perfect.
Unmuted.
Thank you so much. Appreciate it. Okay, measles. Okay, that came out wrong because actually I do want to preference. I do want to start this conversation with. I find it absolutely devastating that we're having this update today. There's no reason why we have healthy children dying of measles in the U.S. when this vaccine is amazing. It's highly effective and has a very long-lasting immunity. So pardon my original excitement about getting to the last session, but I am not excited that we are actually having this conversation. So Dr. Sugarman, if you will please lead us through this.
Thank you. Yeah. No, it's very good to be with you to provide an update on the state of measles in the United States. This graph shows a history of measles cases in the U.S., including significant vaccine dates and when measles was declared eliminated in the United States by the World Health Organization. Prior to measles vaccine, there were 3 to 4 million cases per year, of which 500,000 were reported, which dropped significantly after vaccine introduction in 1963. In 1989, ACIP recommended a second dose at school entry in response to school outbreaks, and in 2000, we achieved measles elimination in the United States, defined as the absence of continuous spread of disease over 12 months. Since measles elimination, there have been 11 large outbreaks in the United States with more than 50 cases. 7 of these outbreaks occurred in the last 5 years, and 9 were among close-knit communities with low vaccine coverage. Coverage among these communities was far below the 95% coverage needed to provide herd immunity and prevent measles outbreaks. The most recent outbreak began and is most concentrated among a close-knit community in Gaines County, Texas, with 2-dose MMR coverage among the public schools at 82%. True coverage is unknown, but potentially lower with many in the community attending home schools or in private schools without reported coverage. There has been subsequent spread to 21 additional counties in Texas, as well as 3 counties across the border into eastern New Mexico. From elimination till the COVID-19 pandemic, MMR coverage remained above the 95% herd immunity threshold required to prevent outbreaks. However, coverage has been decreasing since the pandemic, and during the 2023-2024 school year, approximately 280,000 or 7% of kindergartners did not have documentation of 2 MMR doses and were potentially at risk for measles infection. As the map of 2-dose MMR coverage shows, coverage is also heterogeneous across states, with several states reporting coverage less than 90% shown in dark orange. Coverage is also quite heterogeneous at the county level, potentially hiding true outbreak risk. This is a map of estimated county-level coverage from the National Immunization Survey Child, using the 2012-2016 birth cohort with 1 or more doses of MMR vaccine at 24 months of age. Gaines County and others with outbreak cases in Texas are seen in light gray with under 80% 1 or more dose coverage. Here's an epicurve with monthly measles cases from January 1st, 2023 to April 10th, 2025. Following the COVID-19 pandemic, we've had a measles resurgence due to increased measles transmission abroad, a surge in international travel, and declines in measles vaccination, especially in close-knit communities with already low vaccine coverage. Cases have increased from just 59 in 2023 to 285 in 2024, which we've already more than doubled in the first 4 months of 2025, hitting 712 on April 10th. While the number of outbreaks fluctuated from 4 to 16 over this period, the proportion of total cases that are outbreak associated increased from half to 93% this year, with 5 outbreaks ongoing. We'll be tracking duration, working closely with our state and local partners to ensure we don't cross the 12-month threshold and preserve our elimination status with ongoing spring and summer travel and congregate events. This map shows measles cases by state from light to dark blue. Half of our states are reporting measles cases. Most states are reporting no or limited further spread from importations. Of note, there are also large measles outbreaks in the same close-knit community to our north in Ontario, Canada, bordering Minnesota through New York, and to the south in Chihuahua, Mexico, bordering Texas and New Mexico. This epicurve shows 2025 cases connected to the Southwest outbreak, including Oklahoma, Texas, and New Mexico in blue, and those not related to the Southwest outbreak in gray. Over 90% of the current national cases are related to the Southwest outbreak, driven by transmission in close-knit under-vaccinated communities with low vaccine coverage. The non-Southwest cases are largely importations with some degree of spread from all WHO regions, largely from Canada and Vietnam. The majority of cases are in unvaccinated children with a median age of 8 years, typical of our recent measles outbreaks. 97% of cases are either unvaccinated or of unknown vaccination status. The reasons for unknown vaccination status are multifactorial. First, Texas has an opt-in immunization information system requiring patient consent to share immunization records with public health. And second, adults often do not have access to their vaccine records. We have also seen cases in those with 1 MMR dose, 1% of cases, or 2 MMR doses, 2% of cases. 12% were hospitalized, a little lower than the typical 20%. Among those hospitalized, 68% were unvaccinated and 31% had unknown vaccination status. Sadly, very sadly, 3 deaths have been reported. The 2 from Texas were among unvaccinated school-age children without any past medical history. Measles was also detected following the death in an unvaccinated adult from New Mexico. The official cause of death is still under investigation by the New Mexico Office of the Medical Investigator. Of note, from 2001 to 24, only 3 deaths were reported, 2 in 2003 and 1 in 2015, and 2 of these were in immunocompromised patients. Measles virus genotyping plays an important role in tracking transmission pathways during an outbreak investigation. In other words, the connection between cases. This graph shows genotyped cases by epidemiologic week. There are only 2 circulating measles genotypes, both of which are currently seen in the US. B3 in shades of green and D8, the predominant genotype, in shades of blue. Strains can be further disaggregated using the N450 region with distinct sequences. We've seen 4 distinct sequence identifiers, or DSIDs, for B3 and 6 for D8 this year. In this outbreak, most of the sequences thus far are genotype D8, DSID 9171, which is present in Texas, Oklahoma, New Mexico, and Kansas. This same sequence has also been identified in the ongoing outbreaks in Chihuahua, Mexico, and Ontario, Canada, among the same close-knit under-vaccinated community. 4 other D8 DSIDs are also from the Texas outbreak, though differ by 1 to 2 nucleotides, which can be common during prolonged outbreaks. The majority of B3 sequences are from Asia, in particular from Vietnam, which is experiencing a large ongoing outbreak. Now I'll review CDC's support to jurisdictions in responding to measles cases and outbreaks. At the invitation of Texas Department of State Health Services, we deployed 15 from CDC, including 2 from NIOSH, through an FEA to provide on-site technical assistance to Texas during March 4th to April 1st, with another team of 7 deploying today. On the ground, we've provided infection prevention control assistance to 7 healthcare facilities with ventilation assessments and proposed solutions, reviewed school infection control activities and risk mitigation strategies, developed an internal dashboard for Texas to track cases by location and exposure location, and supported measles prevention communication. Our team at headquarters continues to provide remote technical assistance to multiple state health departments to include laboratory diagnostics and genomic sequencing of the virus, guidance on post-exposure prophylaxis, healthcare infection prevention, case investigation and confirmation, and communication support. We're holding bi-weekly national measles calls with public health partners to provide a forum for CDC and health departments to share information regarding the measles outbreak, and bi-weekly trilateral calls with Canada and Mexico to share updates and best practices. CDC's Immunization Services Division continues to make additional outbreak-related MMR vaccine doses available for health departments in order to order at their request. Following the second measles death in Texas, CDC released a clinical outreach and communication activity, COCA, and EPIX alert partner organizations and providers, which included healthcare provider letters summarizing routine and outbreak-specific MMR vaccination recommendations as published in the 2013 ACIP statement. We're supporting several laboratory activities, including coordination with the Association for Public Health Laboratories Vaccine Preventable Disease Reference Centers for genotyping and sequencing. We're helping standardize and expand testing through wastewater surveillance for measles with the National Wastewater Surveillance System and Center of Excellence in Texas with multiple sites in Texas and New Mexico. And CDC's Center for Forecasting Outbreak Analytics is providing ongoing modeling support to determine risk to the general population and close-knit communities. I'll stop there and happy to take any questions you may all have. Thank you.
Thank you very much for that update. We have time for questions, so please, Dr. Sturgis.
Yeah, Captain Zuckerman, thank you so much for that update. And, I have been sort of tracking the Texas outbreak a bit, and it is impressive when one looks at, the 2 deaths of school-aged children and looks at the 41 cases that Lubbock has reported where these cases, I think, are coming from. One comes up with a case fatality rate of about 4.8%, which is way above, what we know that is the case fatality rate of measles, which is 1 to 2 per 1,000 in an outbreak situation. So I don't want to think that there is a higher mortality there, but or perhaps what's happening is a huge amount of underreporting of the cases of measles that are happening in that jurisdiction. Could you comment on that?
Yeah, it's a very good question. We do believe that there's quite a large amount of cases that are not reported and underreported. In working very closely with our colleagues in Texas, in talking with families, they may mention prior cases that have recovered and never received testing, other families that may have cases and never had sought treatment. So we do think that there is under-testing and therefore under-diagnosis and under-reporting, which leads to a smaller denominator than likely is there in this. And it's not uncommon in close-knit communities that may also have lower healthcare seeking behavior at baseline as well.
Dr. Zucker?
Yes, thank you. And thank you for the presentation. My question has to do with the mobilization of resources and the response. I had been deeply involved in the response in New York City when we had an outbreak, what I guess is still the largest outbreak since 1992. We had 649 cases of measles over a period of 11 months. And it really took, an unprecedented level of resource mobilization to bring, that outbreak, under control and transmission. For example, the cost to the health department was estimated at somewhere around $8.4 million. Over the course of the response, about 7% of the health department had been part of the response. I mean, admittedly, New York City is a large health department, but at its peak, we had actually 261 people working, on the measles outbreak, again, to work to end transmission. So, my question to you is about the sort of proportional response in Texas, and the other places where there have been ongoing outbreaks. And if you can speak to, again, the mobilization and resource mobilization, for this response to end transmission. Thank you.
Yeah, thanks, Jane. And I'm here with Dimitri, who helped lead the measles response with you in New York, which was an incredible feat and something we're obviously trying to emulate here. So there are quite a number of resource requests coming in particular from Texas. There are funding limitations in light of COVID-19 funding dissipating, and they are mobilizing the resources they have and moving staff from other domains into measles, moving them from other regions into Region 1 in particular to help support the response, though they're also seeing cases outside of Region 1 and need to stay ready. We are attempting to support and impart the field staff that are deploying or to augment the staff on the ground, but there are additional financial and personnel resources that we are hearing from Texas, in addition from other jurisdictions. So we're trying to support where we can, but I'm assuming if this is going to be ongoing, that those will be significant financial resources needed. On estimate, the estimates are that each measles case can be $30,000 to $50,000 for public health response work, and that adds up quite quickly. So I don't know if others have more to share, but I think that we are scraping to find the resources and personnel needed to provide support to Texas and other jurisdictions.
Yeah, if I may just, you did bring up personnel now, but it is more than just money. It's also having the staff on the ground, because as we all know, the personnel needed to do contact investigation, all the follow-up communications and so forth is really, quite large especially for an outbreak of this size. Mm-hmm. Thank you. Over.
Ms. Moser.
Thank you. So I'm sorry if I missed this, but can you tell me, you mentioned that elimination is defined by the absence of continued spread over 12 months. I've heard, people are getting concerned that we, the United States, could lose our elimination status. When would that happen?
So that, correct, would happen after 12 months of ongoing circulation of the same sequence.
When would that be?
Well, we're 4 months in, so This would be the end of January of the following year.
Thank you.
About the 20th, around the 20th of January of next year.
Thank you.
Dr. Alt.
As I said previously, I'm representing the American College of Obstetricians and Gynecologists. From that 2019 New York City outbreak, we know that there was considerable morbidity among pregnant women. Do we know how many stillbirths, miscarriages, and preterm deliveries we've had during this current outbreak in Texas? Over.
We have not had reports of stillbirths or miscarriages. We have tracked measles cases in pregnant women, including a case of congenital measles, who recovered. But it is, as you mentioned, a significant risk in pregnant women that can develop measles and go on to have preterm labor, complicated deliveries, and then infants that can have negative outcomes. It also leads to complicated exposures in hospitals that we've already also seen at one of the facilities in Texas and could be others as pregnant women come in and may not necessarily have a rash, may have minimal symptoms that then progress to additional symptoms and are not necessarily in negative pressure and then require that. So that's another substantial cause of morbidity with spread from pregnant women that may present with symptoms.
Thank you, Dr. Lair.
Yes, thank you. So as a family physician, I have a number of adults coming in because they were born between 1963 and 1968, and they're not sure if they got the killed virus vaccine and whether or not they should be getting a booster or getting titers. My understanding from research is that the minority of people in those 5 years got the killed virus vaccine, that it was less than 1 million out of several million. Do you have any suggestions for primary care doctors when we're faced with this question from our patients? Thank you.
Yeah, it's a very good question, one we often get. You're absolutely right. It's less than 5% of the vaccines received between 1963 and 67 were the inactivated vaccine that had a lower vaccine efficacy. And a lot of this is reassurance that, for the most part, people should be protected and not at risk. And we often recommend that be a communication between provider and patient. And some patients may want a titer to check. Some may just want an additional vaccine. And I think it's really going to be a direct communication with the provider. But overall, at a population level, that risk is incredibly low because so few receive that inactivated vaccine over a very short number of years.
Thank you.
It's a very depressing way to end the session. We're not quite done yet. No one ran out. But it, I think, really highlights the importance of the work that's done by our CDC colleagues and by the vaccines that are available. And so thank you. And I'm going to hand the session over to Dr. Wharton before we adjourn.
Thank you, Dr. Talbot. So for those listening to the webcast, there will be a new link for tomorrow, which should be posted this evening. And so look for that. It will not be the same link as we were using today. I would like to thank all of our ACIP members for being available for this rescheduled meeting, and as well as our ex officios and liaisons. Thank the work group leads for great work today, the Secretariat for all the preparatory work, NCRD's Office of Communications and CDC's Office of Communications for really excellent support to help us put on this meeting, as well as the engineers in CDC's Global Communications Center. We were anticipating a lot of challenges today, most of which didn't materialize, and it's because of the hard work of all those people I just mentioned. So thank you all very much. And Dr. Talbot, I think you could recess the meeting if there's no additional business.
Have a great night, everybody. This meeting is recessed until tomorrow.